every seat that has been filled today. For each mind and heart that feels the presence of this room, we thank you. Only you know what we are setting out to accomplish today. We have an idea, we have a vision, we have hints and instructions. We have talents, we have abilities and time to work. However, only you can see in perfect detail the end of every beginning. Thank you, Lord, for loving us. Nothing is ever in vain, for even mistakes are missteps, and they are always used for your good. Your righteousness transcends all our efforts and understanding. Forgive us all for our pride, the pride that puffs up, the pride that threatens to unqualify us. Strengthen us, Lord. Give us confidence in who we are and what we have become. Set us free from comparison in order to work together efficiently. Bless this meeting today, Lord, and all those that are present, as well as the lives of those we will encounter. Count. In Jesus' name we prayed. Amen. Thank you, Lord.
Hallelujah. Thank you very much for the prayer. Ladies and gentlemen, in a short while, the chief guest will be with us here. And when she gets inside, we shall all stand up and give her a standing ovation as she comes to take her seat. But that will closely be followed with our national anthem before anything else. Meanwhile, we are waiting for the arrival of the chief guest. We are not going to usher the Director General to come and give his remarks and the objectives, but we shall just delay this for 1 or 2 seconds to allow the guest of honor to enter here. I expect that the Director General, the Director, the Program Manager, the Assistant Commissioner for TB and Leprosy Program to go out and receive our chief guest and usher her in. Meanwhile, ladies and gentlemen, for those ones who haven't registered, please do the registration quickly before the chief guest gets in. Ladies and gentlemen, you know that every year would love to have the annual National TB and Leprosy Conference. As you know, COVID has not made everything rosy. But I think this is a blessing for us today to have this take place. And let's utilize the opportunity we have here to make sure that the time we spend here is time well spent, and we don't count it as time wasted. And so we shall expect a lot from you so that we are able to speak to the acceleration in the progress towards the 2022 United Nations high-level meeting on tuberculosis targeting the COVID-19 era. And so, ladies and gentlemen, this is a very, very important meeting. And so let's give in our best. I will want you to give us the same amount of energy that you came with. There will be quite a number of presentations, and also we shall want you to take note of what the program looks like. The program booklet is all over the place. If you don't have one, please let us know. And if you need to be guided, feel free to come and approach us. There will be a few changes, and if they are there, we shall also let you know. But as of now, the changes are minimal. It's all because we are starting a little late. But we shall see how to catch up with the time lost and make sure that every activity we have highlighted in the program book falls in place. Sorry. As we are here, ladies and gentlemen, let's continue to observe all the SOPs and guidelines as stipulated for us in the public health measures to curb COVID-19. Mr. Omicron is already around with us. We don't want him to take advantage of our being here. And so if you are guided that, please wash hands, don't ignore. If you are guided that, please put on your mask properly, please. Just understand why you are being guided in that direction. If they are saying, please observe social distance, please, it's important. You came here without COVID, we want you to go back without COVID. And if you came with COVID, keep it to yourself until the 14 days are over. So thank you for listening to me, and I hope I have been a little clear. We have already said our prayers. We think the next is to take a deep dive into the programs. Let's give ourselves a few moments as we wait for the Director General to come into the building and we get to receive the objectives of this conference. It's a 2 days conference, ladies and gentlemen. It starts today. It will run up to tomorrow. So you have not missed anything, you have not lost anything. There will be quite a number of presentations. Ladies and gentlemen, don't miss any. I want you to pay special attention to our keynote speakers to actually open up our minds in the direction where we want to move in accelerating the progress towards the 2022 United Nations high-level meeting on tuberculosis targets in the COVID-19 era. And these keynote addresses will be focusing on why investing in ending the TB epidemic is a good economic investment for Uganda. And the people who will give us these keynote addresses will be none other than, number one, Professor Freddy Segoba. You know him. If you don't know him, you will listen to him today and get to know him. The second person who will give us the keynote address will be Ines Gracia Bina. Okay? Let's prepare to listen from their experience and how they want to guide us in taking this battle against tuberculosis forward. So I don't want you to miss those keynote addresses. And probably these keynote addresses will give us the direction of how we tackle tuberculosis in the country for the next coming years. Yes, our chief guest is about to arrive. So let's keep waiting for a while. It's just being delayed. And so just bear with us for a while. The ushers are all around. They are there at your service. Please reach out to them for anything. Don't sit on your issues and you walk out of here with the issues and the next time we are hearing it as a complaint. We want you to get out of this conference when we have met your expectations. So ladies and gentlemen, when you hear me say, let's stand up for a standing ovation, just do that. Can we rise up and give a standing ovation to our chief guest who has just entered the building? Ladies and gentlemen, we recognize the arrival of our chief guest, the Honorable Minister of Health, Honorable Dr. Jane Ruth Acheng Ochero, the Minister of Health. You are most welcome. Honorable Minister, we expect that you come and take you up center stage on the podium as we prepare to receive the national anthem. Ladies and gentlemen, keep standing as we wait to start with our national anthem. Honorable Minister, you are welcome. In this building, we have a lot of delegates here. We shall get to know them one at a time. So ladies and gentlemen, keep standing as the DJ gives us our... Can we take our seats? Honorable Minister, you are most welcome once again. You found we had already committed this conference in the hands of the Lord with a big prayer. And now we want to run our program back to back. And at this juncture, allow me request that our Director General, Dr. Mwebesa Henry, comes and gives us his remarks, but also gives us the objectives and the expected outputs of this conference. Dr. Henry Mwebesa, our Director General, you are most welcome to the podium.
Honorable Minister of Health, Honorable Minister of State for Health, PHC, who is online, Honorable Members of Parliament, including our Chair of the TB Parliamentary Committee, the CDC Country Director, all our development partners here present, all colleagues from Ministry of Health, all implementing partners, ladies and gentlemen. Good morning, ladies and gentlemen. My role is to take you quickly through the objectives of this meeting. Who is projecting for me? I want it. Okay. This is our, Honorable Minister, this is our fourth. I think since I'm alone here, I can remove my mask. This is our fourth National Tuberculosis and Leprosy Stakeholders Conference, and we'll be taking you through the objectives of this meeting. Honorable Minister, first of all, I want to thank you and welcome you to this very important meeting. And I want to thank you so much that you have committed time to be part and parcel of this very important meeting, considering your very busy schedule, in particular this week, where you have been even up country and you just came late last night, specifically because of this meeting. I think somebody projecting is much behind. Oh, I'm the one supposed to do it myself. Okay, meanwhile I can continue. Ladies and gentlemen, I want to welcome all of you to this 4th National TB Leprosy and Stakeholders Conference. As you realize, this conference is organized within a COVID-19 environment, but I want to thank the organizers for the very excellent arrangement. As you all can see, we have adequate social distancing, we have sanitizers, and there was screening as we entered. So this is forward. Yeah, thank you. It is a 2-day conference which starts today and tomorrow. We expect about 150 participants who will be in here physically, but we also have very many participants online, estimated at about 300. So we'll be having those who are following us online and those who are here physically present. Those online will be on Zoom and other social media platforms that who have already joined us. There are a number of speakers who will be here with us for the 2 days. Some will be physical and others may be online. Seems this IT is not doing very well. Honorable Minister, the overall goal of the program is aimed at reducing TB incidence by 20% and leprosy notification among children from 8% to 3%. And all presentations and discussions in this conference will be highlighting these issues, how far we are going towards achieving those targets. And as many of you know, TB and leprosy control activities and management are implemented through a multi-sectoral approach. It's not only we as health workers, it's not only Ministry of Health, but all collaborating partners. We have development partners, we have implementing partners, we have other ministries which work with us, we have civil society organizations, even the private sector. So we use a multi-sectoral collaboration to address or to control and manage TB and leprosy in this country. But also, we emphasize accountability, strong leadership, and resource mobilization. So it has gone backwards. Honorable Minister, what is our overall objective of this conference is to review the current progress of the program, activities, and achievements made as outlined in our National Strategic Plan. Because there are certain activities, targets that we made, and through this meeting, we will share with participants what we have done, what we have achieved, the challenges, and the way forward. And this will also include deliberations on how COVID has affected the performance of the program. And we will highlight the barriers that we encountered, especially over the last 2 years, as we have been implementing this program within a COVID environment. But we will also show that a lot was done to make sure that all the activities of the program kept on course, and we achieved even a lot despite the COVID environment. And therefore, we want to applaud the health workers, the implementing partners, development partners, who have supported this program throughout the COVID environment, making sure that we even achieved substantial targets despite the COVID environment. Honorable Minister, our theme is accelerating progress towards the 2022 United Nations High-Level Meeting TB targets in the COVID-19 era. And that is the theme that will be guiding this meeting for the 2 days that we are here. Specifically, the specific objectives of this meeting, which are what I have already outlined, is that we shall update participants on the performance of the TB and leprosy program since the launch of the strategic plan 2020-2025. You know, we have our TB strategic plan, which is running from 2020 to 2025. And we'll be updating members on the performance or achievements or progress towards attainment of targets and activities for that strategic plan. But we will also specifically review the progress in achieving the 2022 United Nations High-Level Meeting TB and leprosy targets. That will also come out clearly through the presentations. We shall present and discuss the challenges and also opportunities posed by the COVID-19 for attainment of the United Nations High-Level Meeting TB and leprosy targets. So that will also be presented and it will come out clear as one of our specific objectives. Honorable Minister, in addition, we shall share new innovations and research findings that propel evidence-based programming towards attainment of those UN high-level meeting targets. These are really actually outputs, but also to highlight that we shall disseminate the National TB Leprosy Report during this meeting. This report will be disseminated. And we shall also launch the out of ordinary COVID-19 mitigation approach, the CAST TB. As I have already said, we shall also update on the last year communique that was provided. You recall in the last meeting, we had a communique, and we shall update the participants about the progress of that communique. Finally, we shall there'll be innovations in TB leprosy programming that will be shared, especially from the presentations by the different groups. Honorable Minister, thank you very much. Those were the objectives of this meeting and the summary of the planned activities for the 2 days. Thank you very much. Are you going to use this? Okay.
Ladies and gentlemen, another round of applause to our Director General. Please, if you want to clap, clap. Very good. Thank you very much, ladies and gentlemen. Like I said, we shall go back to back with our programs. We should be listening to a welcome remark from our permanent secretary, but we hope she will be available soon, and we shall give her that opportunity when she arrives into this conference hall. Again, we should be listening to our representative. We should be listening to our adolescent survivor from TB, but also the time will come when we shall have that opportunity. But let me use this opportunity, ladies and gentlemen, to request our Executive Director, USTP to come and give his remark on behalf of the civil societies. You are most welcome.
Thank you very much, Chair. Yeah, my name is Dr. Isiko Kawanguzi Paul. I'm the Executive Director of Uganda Stop TB Partnership. The Honorable Minister of Health, our dignitaries here present, the members of Parliament present, the Executive Director of Stop TB Partnership, who is online, the Global Fund representative, bilateral partners, the Permanent Secretaries present, the Director General, Minister of Health, the Directors, Commissioners, Assistant Commissioners, DHOs, and the different officers. The civil society members whom I'm representing here of different responsibilities, the board of directors of Uganda Stop TB Partnership, implementing partners, the TB affected persons, and all conference presenters and delegates. I'm here representing the civil society. I'm giving my remarks. The slides may be crowded, but these are remarks, so they were just converted into PowerPoint so that everybody can follow. Honorable Minister of Health, on 16th September 2018, the first ever United Nations high-level meeting on TB was held. This led to the political declaration on the fight against tuberculosis, which has sent out commitments to be made by the member states to eliminate the TB disease by 2030. Uganda was ably represented by a delegation which was led by the Prime Minister, then Honorable Hakana Rugunda, and the civil society was well represented. Honorable Minister, thank you for being there and being part of it. The resulting UNHLM political declaration affirmed, among other issues, that all people with and affected by TB should have access to people-centered prevention, diagnosis, treatment, and care, as well as psychosocial, nutritional, and socioeconomic support. Affected communities, civil society should be meaningfully involved in the TB response, and decisive and accountable leadership on TB should be provided for the TB affected. Inclusive of affected communities, civil society, and we are here today to take stock and accelerate progress that has so far been made amidst the COVID-19 pandemic that has ravaged the world for the last 2 years. Time has run out to meet the TB targets that are committed to by the heads of state and government at the ever United Nations high-level meeting on TB in 2018. Yet the coronavirus 19 pandemic has reversed gains and set back the fight against TB by several years. TB remains a disease of poverty and economic distress, Vulnerability, marginalization, stigma, and discrimination are often faced by the people affected by TB, and the civil society remains well positioned to rally with the communities. The struggle to end TB is hence also a struggle to end poverty, inequity, unsafe housing, discrimination, and stigma, and to extend social protection. And yet in Uganda, we are aware that this prevalence survey showed that, the cost survey showed that 53% of TB patients and families are spending catastrophic costs of over 25% of their household income while treating and caring for a TB patient, which is quite unacceptable. The patients should be supported. As civil society, we echo the need to strengthen community systems alongside wider attention to resilient and sustainable systems for health, with due attention to implementation of a person-centered approach that looks beyond medical factors, but to holistically address a person's social needs, mental health, economic status, and aim to catastrophic costs by the patients and families. Actions are needed now more than before to move towards a gender-responsive approach with clear guidance to the communities on how to implement those actions. We in the civil society call for a response to TB that recognizes how stigma and discrimination that exacerbates or even supersedes the medical, social, and economic hardships of the disease and remains a super barrier to accessing quality, affordable, and timely care and support. The Uganda Prevalence Survey report highlighted that men are 4 times more affected by TB than women, and time is ticking for implementing men-differentiated care TB programs and services. We, as the civil society, are very grateful that domestic funding for TB in this country increased 9% as compared to the previous year when it was a decimal 5%, as reported in the WHO country profile of 2021. And we call on an accelerated trend if we are to end TB. We remain grateful to the advocacy efforts of the Uganda Parliamentary TB Caucus, combined with those of the civil society and every other stakeholder. On 8th September 2021, with the support of the Stop TB Partnership in Geneva, the civil society in Uganda held a hearing meeting, focusing on the UNHLM targets, and which is actually for one of the reasons that we are here. And it was noted that Uganda is still behind in achieving its United Nations high-level meeting targets, and hence the need to double the efforts. The following issues during that hearing meeting of the civil society came to the forefront, and I'll mention a few. TB survivors could contribute to the TB response and should get empowered and be followed up even after treatment, with the need to focus on a person, not just the TB disease. Let's not make TB so scientific. And there remains limited information about the disease in communities that need to be handled as a priority. Let's fight stigma in all its forms. Let's avoid scientific language, jargon, as we communicate to the communities, and instead share the TB statistics in a language that the community can easily understand for the benefit of all the affected. Let's endeavor to integrate TB program with other diseases for efficiencies. TB remains a community threat, and this should be known by all people. And our village health teams, who are foot soldiers down in the communities, in the villages, up to the household, should be supported also to integrate TB in their work, since they are closest to the communities. Involving the private sector and private facilities should be seen as a priority. Screening for TB should be done at each service point, both the public and private sector. There is need to support community structures, especially to coordinate the TB survivors, the TB champions, the TB expert clients, that remain a great resource to support community TB education and other areas on the treatment and care cascade. The civil society in Uganda is in agreement with the rest of the world that there remains a deadly divide between the commitments that were made at the United Nations high-level meeting and the current realities. Hence, the call to everyone to contribute towards closing the gap in the targets that were set if we are to end TB. We are also in agreement and equally recommend that there is a big need for active investment in TB-affected communities, the civil society, and to ensure their meaningful engagement in all aspects of TB response. In Uganda, some of the pressing issues for the civil society include: in Uganda, the key stakeholders have made important advances in the TB response. But let us be reminded that key and vulnerable communities remain hardest hit by tuberculosis. It is hence very important that the TB-affected communities and civil society are engaged further, since their work is very close to the affected persons. Set up a multi-sectoral accountability for the TB response with an engagement of the high-level political and administrative leadership that are in charge of making important decisions at different boardroom levels. Of course, we already have the MAF, Multi-Sectoral Accountability Framework, which is doing already very well. We call upon government, donors, multilaterals, that there is a dire need to increase investments in the TB response for the affected communities, civil society, in research and development, and in expansion of the point-of-care technologies to reach the most vulnerable and marginalized communities in real time. Let's embrace the bold response to COVID-19, the bold response that has been made to COVID-19, which pandemic has disrupted everything and reversed the gains that had been made for TB. Let's take opportunity of what we have learned to make sure that we can strategically end tuberculosis. Allow me to thank everyone as listed there. Minister of Health, National TB Leprosy Program, led by Dr. Stavia for the wonderful job done, the development partners, the Stop TB Partnership, in particular, Dr. Luchika, who is online, and who partly sponsored this conference. Everybody listed there, including all of you here, we are very, very grateful. We at Uganda Stop TB Partnership, we say we keep TB on the agenda. Keeping TB on the agenda is a role for everybody. Keeping TB on the agenda is a role for everybody. Lastly, and possibly most important, time is ticking. We don't have time. We must end TB. Thank you all for listening to me.
Thank you very much, Dr. Isiko, Executive Director, Uganda Stop TB Program. Honorable Minister, as you realized, we transitioned quickly into the opening ceremony, and I'll be taking us through this ceremony. Honorable Minister, I want to recognize that there are people online who will be part of this meeting, especially of the opening ceremony, and will be making remarks. We have the Executive Director, Global Stop TB Partnership, Dr. Lucia Dutoy, who will be making comments soon after. We have also our Task Manager for Global Fund, Dr. Zaman Samani, who will also be making comments. So this opening ceremony will be going as follows. We've received information that David Nyanzi is not available. So we've received the presentation from Dr. Isiko. We'll be now going to the Executive Director, Global Stop TB Partnership, Lucika Detoy. After that, who will be online. She'll make her presentation online. Honorable Minister, then we shall have Dr. Zaman, who will be making his presentation from Global Fund Geneva, will also be online. Thereafter, Honorable shall have Dr. Lisa Nelson, the CDC Country Director, who will actually be representing the USG Ambassador. After that, we shall have the WHO Country Representative, Dr. Jonas. I'm advised he will also be making his presentation online. Thereafter, I have received the speech of the PS, which I will read and then invite you to address the audience. So that is the order of the opening ceremony. And at this juncture, allow me to invite Dr. Lucika Detoy to make your remarks. You have the floor.
Thank you, sir. I don't know if you can hear me. I am sure you cannot see me, but I hope you can hear me. Good morning, everybody. My camera is disabled by, I think, the team that organizes the meeting. But I was able to, I am online for the last hour and a half, so I participated to the registration and everything, and it's a pleasure to be here with you. I don't know if somebody can open my camera. And I don't know if you can hear me. Hello?
Yes, we can hear you.
Okay. Thank you very much for hearing me. If somebody will open the camera, we can also see each other, but if not, I actually was able to see the room, to see people speaking, and very important to see the Honorable Minister. Thank you for being with us, the TB community, and thank you for all the support and hard work that you put in supporting the TB, and not just the TB, but the health of the people in Uganda and advancing it. My name is Lucica Ditiu. I'm the Executive Director of the Stop TB Partnership from Geneva. And I'm sorry that you cannot see me. It's not from my side. It's from, I think, from the organizer's side, but I will go ahead. I'm very honored to be here with you, and I will try to explain why. There are amazing, it was very impressive, the start of the meeting, and I think the Honorable Minister in her recorded speech, as well as how to say, the host, the chair of the meeting, spoke very nice about you all as the participants. Because I think we all need to applaud your hard work and resilience. These are not simple words. Is you existing and being in the front fighters for not just TB but also COVID, and having the need to really fight in the same time multiple fronts, and still finding the time not only to attend the conference but really to perform and do great job in terms of the work that is happening for the TB response in the country. So there are amazing things that are happening in Uganda. And you know very well, it was remarkable the fact that several of you discussed about the UN high-level meetings. The head of the Uganda Stop TB Partnership had an impressive presentation, as well as the other colleague. We know very well the increase in the coverage of the TB treatment in Uganda, which is remarkable, going up to 80%. We know about the increase in funding, and what I consider very important, the amazing leadership coming from the Ministry of Health, as well as the NTP manager. From the Stop TB Partnership Geneva, is not just that we are supporting you in a way with words, but we are supporting you as much as we can with different kind of platforms that we have. Uganda, as you know, is receiving big support from Global Drug Facility. Co-national from Uganda, our colleague Annette, is working with us for the last 3 years. 13 millions in drugs and diagnostics we were able to provide to Uganda, as well as support for new tools. In the recent months, we will ensure that 5 X-ray machines, and as well as portable gene expert machines, as well as support for digital technology and the rolling out artificial intelligence and chest X-rays, portable chest X-ray in Uganda. And this is actually what I want to speak about. What I want to say is that for us, Uganda is one of the pathfinders countries, as you might know. And when I say that, is the fact that if some of you might be aware that the TB community is sometimes characterized as a slow uptake of new tools, a bit, slow in pushing things forward. We are very proud to support the Uganda program and the Ministry of Health in being among the top countries as top pathfinders and top supporters of the new tools. The fact that already you looked over a mobile X-ray, artificial intelligence, mobile diagnosis for TB with the Indian machine called Trunat, digital adherence technology, is showing a very good mind towards the future, set up to take forward the challenges for the future. As was already said, because of COVID, TB was very hardly pushed back in terms of the achievements that we had, and in terms of seeing the end of this disease. To bounce back to where we were supposed to be, and to regain the energy to look at ending TB in the next 9 years, we really need to be very innovative and very rapid. Our team, one of our teams in Stop TB that is looking at reimagining TB care, is actually working close with the colleagues from the Uganda program in seeing how we can ensure that we make it as easy as possible for people with TB to access patient-centered care. How can we make sure that the care comes to the door of people? And it's not just about TB, it can be about a package of interventions that can be offered in the same time. In March next year, we will have a call for our TB Reach platform, in which we will provide funding to the projects that will come with innovative way in integrating diagnosis and integrating in such a way that making sure if we have a capacity to bring closer to people, either through community healthcare workers or to mobile units that can be equipped with X-ray, molecular diagnosis, blood tests, can we do tests for TB, for HIV, for malaria, for cardiovascular, for cancer, for diabetes in the same time. And we remove in this way any barrier that comes to people into accessing these tools. So we will have a call of proposals for that. That's not about our call of proposal. It's about the fact that we need to really think forward and to see what can be done in a different way. And speaking of that, we have a recent project that we will be funding in Uganda, and we hope that this will be an example for the entire world. And we work with, obviously, the NTP, the Ministry of Health, our friends Akil and Walimu, in looking forward on how to strengthen the health information systems as well as the national electronic case base, and basically trying to put together the different type of electronic databases that exist, that there is a sort of one record per individual, integrating as well the other existing data from digital adherence technology, from the health information and so on, and moving towards what we saw that is happening these days with COVID, when everything is live, everything is digitalized, and therefore the data can become easy accessible, easy used, and very visible for the decision makers. My last point is less technical, to say so, and it's more, let's say somehow high level. The challenge that we have with TB is that we are not as lucky as in Uganda to have the minister and the government individuals and colleagues, a strong national TB program, a national Stop TB partnership that can come together to push the agenda. TB is very often forgotten, unfortunately. And unfortunately, TB is very often forgotten by also big donors, and as well, including some very big ones, such as the Global Fund. For TB, the resources that are coming from the Global Fund are completely insufficient, but it is what it is. And we will have to deal with what we have from the Global Fund, but we will have to look at very many other different ways of raising resources for TB, because the gaps are really big. There are a lot of big needs in Uganda as well, we know. Roughly 30%, 40% gap from the resources that are needed, but I am pretty sure that there will be a good way forward to start closing that gap, and we will be keen to discuss together on how we can do that and support you, because we know domestic resources are always pushed in a lot of different other buckets, and it's not easy to secure all the funding needed just from the domestic resources. We would like to, in 2022, we will focus a lot in trying to identify ways to increase the funding for TB. This is a general discussion, it's not specific to Uganda. It's a big need from us at Global Fund and at global level. And obviously working with the Global Fund further, even though the 18% available for TB is a very low figure. The biggest needs are in the African region, and we hope to really bring a lot more attention to TB in the African region. And with this, I want to see if the Honorable Minister will like to be for us a champion to try and steer and show in the region as well to other countries how it is to really support a TB program in a manner that is happening here in Uganda. It doesn't mean that everything is perfect. It doesn't mean that we achieved all the targets. There is a way to go on NDR, on preventive treatment, especially among contacts, on funding, as I said, but it's an amazing path that we find ourselves on. From Stop TB Partnership, please count on us to support always you, and I'm extremely honored and humbled that I had the opportunity to speak today. Thank you very much.
Thank you very much, Madame Lusika Detoy, for those very important remarks. Honorable Minister, before I invite our Global Fund Portfolio Manager, allow me to quickly recognize Honorable Joel Sebukari, the presence of Honorable Joel Sebukari, the President of Parliamentary TB Caucus. He's always with us whenever we have TB activities. I also saw Honorable Dr. Boka at one point. I hope he's around. Honorable Dr. Boka is a member of the Health Committee. You are welcome, sir. I think, Stavia, when we get new members of parliament, you will let me know so that we recognize them. But allow me also to recognize the presence of Dr. Kware Joseph, our Director for Governance and Regulations, who is here with us. Dr. Nathan Onyachi is representing all hospital directors, and I think he's also around. And then Dr. Stavia Triahav, of course, the program manager. So at this juncture, allow me, please join me to welcome our Global Fund Portfolio Manager, Dr. Zaman Saman from Geneva, who will be submitting online. You have the floor, Dr. Saman.
Good morning, EJ. This is Saman Zamani FM for Uganda from Global Fund Secretariat. Honorable Minister, distinguished colleagues and partners, ladies and gentlemen, all protocol observed. It's a great honor for us to be with you during this conference. It's virtual. We really wish to be with you in Kampala, but we use maximum opportunity we have through these virtual meetings. It's a great honor to be in this conference and listen to achievements of all TB stakeholders. On behalf of Global Fund, I wanted to recognize and appreciate the close partnership we have with government of Uganda, partners, civil society. To us, it's an optimum platform and situation in Uganda. Thanks, Honorable Minister and colleagues for taking us so advanced in TB control as well as other priority diseases. On behalf of country team, I wanted to comment both PR's Ministry of Finance, Ministry of Health, NTLP, TASA, and stakeholders for achieving this impressive progress despite all challenges we all had during COVID context. We know how COVID-19 impacted service delivery, but program and implementing partners show resilience. This is a really remarkable progress. As we discussed with NTLP management and PR and Minister of Health colleagues, we are extremely pleased with the performance and financial absorption. It's really, really big progress you are making, and we are very encouraged by the fact that in recent results of the program, we have seen even increased the number of sensitive cases detected and notified. So all this happening in the context of COVID, as you know how restriction and other limitation brought to us. So congratulations to all implementers and stakeholders for this achievement. What we learned from Dr. Savio and colleagues, the community platforms and extension of TB control activities into community has been one of the key factors for the recent increase in notified cases. And this is really impressive, and we hope to see even advanced level of operation through community level, and we are very much interested in what MOH and NTLP has proposed through CAST, community awareness, screening, testing, and treatment. I know that it is planned to be implemented in a campaign mode, but we really want to see a streamlining of this. Should it be useful for reaching and finding more cases? Nothing else than praise of the achievement during this period. Appreciated our close collaboration with both PRs. Dr. Savio led us very well into a new era of TB partnership. Thanks to her and NTLP team in general. We are eager to learn during this two-day conference the new study findings, a new innovative approach, and we would be very happy to share your experience with other teams in the region and the Secretariat. So thanks again for giving us the time. Really appreciate it, and I wish a very fruitful and successful conference in 2 days. Thank you. God bless you, and take care.
Thank you very much, Dr. Zamani, for those remarks from the Global Fund, which have been communicated to us. Thank you very much. Honorable Minister, I'll continue. Okay. Honorable Minister, I'll continue recognizing people gradually as we go on. I'm advised we have Honorable Nekesa Victoria, Member of Parliament representing UPDF, who is here with us. You are welcome, Doctor. Honorable, we also have Honorable Aker Sharom, Woman MP for Gulu City, and also a member of the Health Committee. You are welcome, Honorable. Where is she? Thank you very much for coming, Honorable. Colleagues, may I request that we give them a proper... Good. Thank you very much. We also have Honorable Bahereira Silvia, Member of Parliament from Kamwenge, and also a member of the Health Committee. Thank you very much. Honorable Minister, just so you know that our keynote speaker for this conference will be Professor Fred Sengova, who is very well known to this audience. He's a professor of public health from the School of Public Health, Makerere University. Then we'll also be having as panelists the Commissioner General for Prisons, Dr. Johnson Biabashaija, and we are happy that he has accepted to be a member of the panelists. On the same panel, we'll have the PS of Ministry of Gender, Labor and Social Development, Mr. Chivenge Agri. And at this juncture, I also want to bring apologies from the PS, Ministry of Health, Dr. Diana Twine, who is out of the country on official duties related to the East African community. So, Honorable Minister, allow me to invite Dr. Lisa Nelson to make her remarks. on behalf of the U.S. government. Join me to welcome Dr. Lisa Nelson, please. This thing doesn't spray.
Good morning, colleagues. So, Honorable Minister of Health and your team, members of Parliament, health development partners, private sector, providers, representatives, civil society organizations and representatives, conference participants, ladies and gentlemen, and also to our online colleagues and my dear friends, Dr. Luchika and Dr. Saman. It's so great to see so many of you here today, and I would fully agree with the importance of political leadership, particularly for tuberculosis. Good morning again. I'm pleased to join you for the 4th National Tuberculosis and Leprosy Annual Stakeholders Conference 2021, and I'm here on behalf of our ambassador, Natalie E. Brown, who unfortunately isn't able to be here today, but also our U.S. government team that includes a number of U.S. government agencies, CDC, USAID, and others working in tuberculosis, and I think it's a priority for all of us. For more than half a century, the United States has been the largest contributor to funding for global health security and humanitarian assistance. We were on the front lines supporting Ebola, and we support countries in battling tuberculosis, HIV, AIDS, malaria, and infectious diseases. As you know, large HIV program, the President's Emergency Plan for AIDS Relief, which also provides support for HIV co-infection. We're also the largest donor to the Global Fund, which globally is the largest multilateral funding for tuberculosis. But I would certainly agree with colleagues that TB has been neglected for far too long and remains underfunded. But I just want to reassure you, as a U.S. government team, we're all in this effort for tuberculosis. Now, also, over the last 2 years, we provide substantial technical and financial assistance in the global response to the novel coronavirus disease, or COVID-19. As you may know, the U.S. government has now donated, I believe it's over 9 million doses of COVID-19 vaccine here in Uganda, which is part of the commitment to provide safe and effective vaccines around the world and supercharge the efforts to fight this pandemic. To save lives and stop the new threat of variants, we must vaccinate as many people as possible, as quickly as possible. And when I leave you today, I'm going to the U.S. Embassy to get my booster. So any of you who haven't yet completed your primary series, I hope you will do so as soon as possible. Since the COVID-19 outbreak, the U.S. government has continued to work closely with Uganda's Ministry of Health, other stakeholders, and implementing partners to develop, disseminate, and operationalize technical guidance to ensure sustained delivery of critical, life-saving, and essential health services in the areas of tuberculosis, HIV, malaria, maternal, newborn, and child health, family planning, water, sanitation, hygiene, and nutritional services. And as we know, aside from COVID in the last year, tuberculosis remains the leading cause of death worldwide from a single infectious agent. In 2020 alone, tuberculosis caused 1.5 million deaths worldwide, including 214,000 deaths among people living with HIV. I commend the government of Uganda, and I think we've already heard this morning, for its response to TB, especially during these trying times of COVID-19. Despite progress in some TB indicators in recent years, the World Health Organization has designated Uganda among the top 30 high-burden countries, as well as the top TB and HIV high-burden countries. Disruptions during the COVID-19 pandemic have had a major impact on access and delivery of TB diagnostic and treatment services. The U.S. government continues to invest in fighting TB in Uganda. Despite the pandemic, the U.S. government and its implementing partners worked with district health officials, facilities, health workers, and community volunteers to rise to this challenge. Just some examples. The USAID Global Accelerator to End TB aligns with the United Nations High-Level Meeting's commitment to end TB by increasing the capacity of governments, civil society, and private sector to speed up countries' progress toward ending TB. The U.S. Centers for Disease Control and Prevention, or CDC, where I work, continues to support the government of Uganda in expanding access to high-quality TB laboratory diagnostics, strengthen infection prevention and control measures, establish TB case-based surveillance, and conduct groundbreaking research on TB diagnosis and treatment through the TB Trials Consortium and operational research using PEPFAR funds. As part of PEPFAR, CDC also provides TB and HIV diagnostic and treatment services, as does, of course, USAID. But for CDC in particular, we support prison staff and prisoners, a population vulnerable to high rates of TB and poor outcomes. And just earlier this week, together with Dr. Stavia and UPS leadership, we visited Luzira prison to see the investments in an MDR experts, in better laboratory capacity, and in specimen referral by availability of motorbikes. And I'd like to wish you a happy holidays. Thank you.
Thank you very much, Dr. Lisa Nelson, for those remarks on behalf of the U.S. government. Honorable Minister, before we receive Dr. Jonas, I also want to let you know that Ms. Garcia Baena will also be making a keynote address after break. So at this juncture, allow me to invite, I will also be letting you know if we have sent out feelers for any district leaders who may be in this meeting so that we recognize them. So Stavia, please, if there are district leaders, if you get a record of them, let's get to know and we recognize them. May I request Dr. Jonas, the WHO country representative, to make your remarks at this point. Join me to welcome Dr. Jonas, please, with a big clap. Dr. Jonas will also be online.
Thank you, Dr. Henry, Honorable Minister of Health, Honorable Minister of State for Health, Honorable Members of Parliament, Dr. Henry, the Director General, also representing the Permanent Secretary, Dr. Lisa, Director CDC, representing the US government, Dr. Lucia Ka, Executive Director of the Stop TB Partnership, Dr. Saman, Portfolio Manager of the Global Fund, government representatives in your respective roles, representatives of the Health Development Partners, all participants attending this conference in person and virtually, all protocols observed. Good morning. I'm pleased to be part of this fourth National Tuberculosis and Leprosy Annual Stakeholders Conference to further discuss the advancement of health agenda in Uganda. As you may know, the global effort to combat tuberculosis are parts of the UN Sustainable Development Goals. These efforts were re-energized at the historic 2018 United Nations high-level meeting on tuberculosis, which was called partly by WHO. The goals and commitments reached at these two high-level political events are further concretized in the WHO NTB strategy, which is 2016 to 2030. This year's National TB Conference, therefore, takes place in a crucial junction in Uganda's effort to meet the United Nations high-level meeting on tuberculosis targets. As a result, it is critical to discuss how the national TB response can be accelerated over the next 12 months to meet the specific targets indicated for 2022. There has been a significant progress in the national TB response since 2018, resulting in an increased TB treatment coverage from 65% in 2018 to 75% in 2020, and treatment success from 72% in 2018 to 84% in 2020. However, Following the COVID pandemic, Uganda, like the rest of the world, has seen a reversal of the progress towards TB prevention and care. Globally, the COVID pandemic reduced TB notification by 18%, which was mirrored at the national level as well. In the current situations, Uganda will need to double its effort to get back on track to achieve the national TB commitments and targets. Honorable Minister and ladies and gentlemen, as noted in this year's Global Tuberculosis Report, ending the TB pandemic is also part of the strategy to end poverty, inequality, unsafe housing, discrimination and stigma, and extending the social protection and universal health coverage. So it is a major agenda in our effort to ensure universal health coverage. WHO has developed a multi-sectoral accountability framework for tuberculosis to address the broader social and economical determinants of TB outside the health sector. Given the impact of COVID-19 on the health system and economies worldwide, particularly among the poor people, multi-sectoral actions are now more important than ever before. And the participation of this conference reflects the multi-sectoral engagement in Uganda. And I think this should be a good forum to discuss how we can accelerate our engagement in all sectors to address tuberculosis. WHO has also developed and updated several TB diagnostic and treatment tools that are required for effective tuberculosis prevention and care. I urge Uganda to quickly adapt these tools, and I also urge the TB stakeholders at all levels, including partners, civil society, and affected communities, to facilitate this rapid uptake and implementation. And I believe that this is possible given the country's political support and donors' commitment to TB prevention and care in the country. I urge Uganda to increase and broaden access to TB prevention, preventive treatment, including increased TB screening at a household level and increased access to short rifampicillin-based regimens as recommended in the updated WHO guideline. I urge civil societies and TB survivors for their increased participation in the national TB response, as well as was well demonstrated in the response for HIV, AIDS, and other major health threats. The National TB and Leprosy Program could also be leveraged to expand treatment coverage for respiratory disease like asthma, chronic obstructive pulmonary diseases, as well as child lung health and hazards of tuberculosis, of tobacco and air pollution. The lessons learned from TB prevention and care could also aid the improvement in lung health in the general, including in the case of COVID-19. Ladies and gentlemen, as I conclude, I would like to emphasize the need for us to accelerate our effort to meet the United Nations high-level meeting on tuberculosis targets for 2022. At this conference, it is an excellent tool to discuss and achieve these common goals. You can always count on WHO to work towards this goal. And I would also like to emphasize that as COVID is real and is taking away our brothers and sisters, we need to follow the public health measures in this conference and everywhere, and most of all, get vaccinated and ensure that everyone you know and come across get vaccinated. I wish all the conference delegates a productive conference for a healthier, safer, and fairer world for everyone and everywhere. I thank you.
Thank you very much, WR, Dr. Jonas. very important remarks. Good. So, Honorable Minister, I think we are coming close to the end of the opening session. Before I invite myself, this light is coming back. Before I invite myself to read the PS's speech, I want to recognize the presence of Dr. Patrick Tusime. Dr. Patrick Tusime is the Commissioner, National Disease Control, which directly supervises the TB program, TB and leprosy program, but he will also be chairing some of the sessions this afternoon. Honorable Minister, allow me to, at this juncture, to read the PS's remarks, and I will also take the opportunity to invite you to address the meeting. Honorable Minister of Health, Honorable Minister of State for Health, PHC, who is online, Honorable Members of Parliament, the CDC Country Director, WHO Country Representative, the Global Fund Portfolio Manager, Executive Director, Global Stop TB Partnership, colleagues from Ministry of Health, colleagues from other ministries, departments, and agencies, the keynote speakers, directors of regional referral hospitals who may be here and online, all development partners, our private health providers, our civil society, the district leaders, ladies and gentlemen, protocol observed. Still morning, good morning, ladies and gentlemen. I would like to welcome all of you to the 4th National TB and Leprosy Conference. This year's conference is coming at the end of the first year of the people-centered National Strategic Plan for TB and Leprosy, where we committed ourselves to the 4 90s, 90, 90, 90, 90 targets for TB and leprosy. To highlight quickly, these are awareness creation. That's the first 90. The second 90 being prevention. The third 90 being diagnosis, stroke treatment coverage. And the fourth 90 being treatment success. I'm happy we have organized this conference with the theme that is focusing on accelerating progress to meeting our targets. The TB program. So to address the country's TB burden, the National TB Leprosy Program has now adopted a multi-sectoral approach. The Ministry of Health, through the Office of the Prime Minister, the Ministry of Health, through the Office of the Permanent Secretary, is responsible for providing overall leadership for the program, and in particular for the required multi-sectoral TB actions, which are coordinated by the Office of the Prime Minister. This multi-sectoral approach is already being used in this country. As many of you know, we've had a number of approaches covering HIV, a number of approaches covering malaria. Many of you know that the Office of the Prime Minister has also been coordinating the COVID response. And all these have achieved measurable results that we could learn from and we could adopt. It should therefore work for us addressing the TB leprosy problem in this country, as well as we have developed a good experience with multi-sectoral approach. I'm happy that during this meeting or conference, we have some ministries who will be sharing their experiences on the progress made so far to address TB. Ladies and gentlemen, I also wish to use this opportunity once again to make an appeal to everyone in this conference to intensify efforts to reach the 490s I have talked about, the 490 targets for TB. This means that we have to raise TB awareness to more than 90% of the population of Uganda. For the entire population of Uganda, which is over 40 million, at least 90% of our people should know about TB, how to prevent it, and how to control it. Then, at least 90% diagnosis and treatment of at least 90% of Ugandans who have developed TB. Since we said we have at least 90,000 people developing TB every year, we must at least make sure that 90% of those have been started on treatment. Preferably, actually, 100%, because they are just 90,000. The point is looking for them and finding them. And if you find them, then there should be no reason why we shouldn't start all of them on treatment. Then the third 90 is to successfully treat all those that we have started on treatment. And also the fourth 90, provide TB prevention treatment to 90% of TB contacts and people living with HIV. The Ministry of Health will mobilize the necessary resources, and remember, this is the PS's speech. So when we talk of mobilizing resources, she knows what she's talking about. It's not Mwebesa. So the ministry will mobilize the necessary resources, both domestic and external, to ensure that significant progress towards these goals is made. We have included some TB indicators in the mainstreamed RBF to ensure improvement in this area. I want to call upon all districts to ensure that TB and leprosy surveillance and prevention are prioritized each year under the 30% PHC resources. Furthermore, we need to emphasize the importance of integration of TB among all services being provided in the country. To strengthen the ministry's support and supervision of TB and other diseases, the ministry, with support from partners, has developed a strategy to strengthen regional referral hospitals in their role of providing leadership and oversight to district health programs to improve the decentralized response to HIV, to TB, and other diseases. The emphasis here is, as we get very many districts, the center can no longer be fully in control or supervising the districts adequately. So we are strengthening the regional referral hospitals, the community health departments in those regional referral hospitals to take charge of the catchment districts under those regional referral hospitals. And this includes the anchoring of the regional TB leprosy focal persons to the regional referral hospitals and the specialized care for drug-resistant TB in the country. All regional referral hospitals are hereby required to strengthen TB response in their respective regions. And this message, I want to request Nathan, who is here, for all those colleagues from hospital directors, kindly take this message to them and emphasize that, and a circular has already been sent to strengthen TB services in their respective catchment areas of the regional referral hospitals. Through this strategy, Honorable Minister, the regional referral hospitals will provide the necessary leadership and technical support to the districts within their areas. And in these areas in particular, we expect regional referral hospitals to support districts to strengthen governance and leadership. We expect them to support districts to strengthen planning and coordination, capacity building, especially skills development in diagnosis, in treatment, in follow-up and surveillance. We also expect them to strengthen strategic information, collection, utilization, and analysis. We also expect them to support continuous quality improvement efforts in the different programs, and also strengthen laboratory services through this strategy. I therefore call upon the directors of regional referral hospitals and the district health authorities to support implementation of this strategy as one of the means to accelerate national progress towards those 490s. Appreciation. In conclusion, Honorable Minister, allow me to acknowledge and appreciate all our development partners and implementing partners who are supporting our efforts to control and prevent and eliminate TB and leprosy from this country. In particular, World Health Organization, the Global Fund, USAID, US CDC, UNICEF, QUAM, German Leprosy and TB Relief Association, and others. Let me also thank district local government teams, especially those who have performed very well over the years and this year. I also want to acknowledge and thank the civil society organizations, especially those who are involved in TB prevention and control. I want to thank the TB survivors and patients who also continue to support the program by disseminating the messages and even calling on their colleagues as peers to address the problem of TB. I want in a special way to thank our beloved frontline workers for the job very well done over the years and through the COVID response period, because we know that they have, despite the COVID situation, they have also continued to provide services for TB and leprosy. I also want to thank in a special way the TB leprosy program headed by Dr. Stavia here for steering the national response with visible results, as you'll be seeing in the presentations of today. Finally, allow me to appreciate the organizers of this conference, headed again by Assistant Commissioner, TB Leprosy. Dr. Stavia, please stand up for recognition. And let's applaud Dr. Stavia. Madam Minister, allow me also to recognize in a special way the chair of the organizing committee, Dr. Andrew Ochero. Please stand up for recognition. I know he's behind there because he's coordinating and organizing various activities. I want a bigger clap than that for Dr. Ochero. Not for any reason, but because he's the chairman organizing committee. I also want to thank the funders of the conference, the Global Fund, and Stop TB Partnership. Finally, as I conclude, let's give a big clap to the funders, please. They have made our life comfortable. They have made sure that you have social distanced, hired this big room, and as Stavia said, was it the chair who said we came negative, we should leave this place negative of COVID. And that has been made possible by our funders. In conclusion, ladies and gentlemen, COVID is still with us, and now there is even a new variant, Omicron. I appeal to you all to observe SOPs, and I also encourage you and request you please to vaccinate against COVID-19. I also want to urge you to integrate TB COVID screening, as the key. Screening is key as the two diseases present in similar symptoms. Integrate TB COVID screening is key as the two diseases present similar symptoms. I'd like to urge all of us to embrace multi-sectoral approach to TB leprosy and be accountable in our renewed efforts to combat this disease. Let us not forget that TB is a major cause of household poverty and a leading cause of death among people living with HIV, and that leprosy still causes significant disability to the affected Ugandans. I welcome you all once again to the 4th TB Leprosy Stakeholders Conference, and I wish you all successful deliberations for God and my country. Dr. Diana Athwina, Permanent Secretary. Thank you very much. At this juncture, allow me to invite the Honorable Minister of Health, Dr. Jane Ruth Acheng Ochero, who is the Minister of Health and Woman MP for Lira City, to address this meeting. Thank you very much.
The Honorable Minister of State for Primary Health Care, who is online, Honorable Members of Parliament present, and Chair TB Parliamentary Caucus, the representative of Her Excellency the Ambassador, Dr. Lisa Nelson, who is the CDC Country Director, the World Health Organization Country Representative, the Director General Health Services, all our development partners, our Global Fund Portfolio Manager, Dr. Saman Zaman, who is online, the Executive Director, Global Stop TB Partnership, private health providers, civil society organizations, the representative of the hospital directors, district leaders, Ministry of Health officials, invited guests, ladies and gentlemen. Good morning to you all. It is with great pleasure that I welcome you to the 4th National TB and Leprosy Stakeholders Conference. I thank you for sparing time to be part of this important event, which offers an opportunity to review the implementation of the first year of the National Tuberculosis Leprosy Strategic Plan, which runs from 2021 to 2025, with a goal to reduce the tuberculosis incidence by 20% and leprosy cases among children from 8% to less than 3%. As you're all aware, the last 2 years have been consumed by the COVID-19 response activities, affecting access to quality TB, leprosy, and other health services. This year's conference theme for our deliberation is accelerating progress towards the 2022 United Nations High-Level Meeting TB targets in the COVID-19 era. In this conference, we will share with you the national performance status on tuberculosis and leprosy, which comes when we are left with 2 months to the end of 2022, when we will be expected to report our national performance to the high-level meeting. From the performance, we are not fully on track in achieving our targets. And to catch up, we must intensify our efforts on TB prevention and care to find additional TB patients. The Ministry of Health has therefore designed the interventions that you've been hearing about: community awareness sensitization treatment, codenamed CAST TB leprosy, to be implemented every 6 months. This is on top of strengthening routine TB leprosy programming at facility and community level. The out-of-the-norm activities on top of mitigating the impact of COVID-19 on TB leprosy services act as a mop-up for TB leprosy cases remaining undiagnosed in our communities. We must end the TB epidemic and achieve zero leprosy by 2030. And this requires doing things differently. I'll briefly share some statistics on the status of our performance. For the first time in many years, Uganda realized a drop in TB incidence of 2.7% and a drop in TB mortality of 35% since 2015, as per the 2021 Global TB Report. However, we should not relax, as Uganda remains among the 30 high-burden TB and TB-HIV countries, 13% children. The majority, that is greater than 60% of the leprosy cases notified were from the West Nile region. And I hope that Honorable Boka has taken note of this. We need you to speak out when you are in West Nile. Ladies and gentlemen, despite the COVID response activities and challenges, the Ministry of Health TB and Leprosy Program has made key achievements that I will share with you. These achievements were realized together with our partners. One, we managed to expand the Gene Expert network to 289 Gene Expert machines in 264 health facilities, including 16 module machines in 7 regional referral hospitals. Access to improved laboratory diagnostics to 70% from less than 50% previously. 2, partners, we developed, tested, and piloted an electronic case-based surveillance system for TB and leprosy, and scale-up is ongoing in 200 health facilities. Expansion to an additional 800 public and selected private health facilities will also be undertaken shortly. 50 districts were supported to conduct a 4-day TB catch-up campaign where over 8 million people were reached with key messages, and over an additional 1,511 laboratory confirmed cases were initiated on TB. Response, and with funding from the Global Fund, procured and distributed motorcycles to support coordination of TB activities in districts that did not have transport previously. Using the National Emergency Operations Centers, the program has continued to coordinate all districts to report cases in a timely manner. This is the same mechanism we use for our outbreaks and other epidemics. This has led to increased TB case finding in certain districts like Lango, like Lango, Karamoja, Acholi, including Uganda Prison Services. Additionally, the response has now expanded to Teso, Bukedi, and Bugishu, which were identified as lagging behind this year. The effort has resulted in improved TB treatment coverage and treatment success, especially in Karamoja sub-region, where the success rate is now over 80%. Ladies and gentlemen, my appeal to you is to remain focused and vigilant in continuing to contain this pandemic and double your efforts to ensure we get on top of the TB challenges in the country. We now have significant amounts of knowledge, including support for us to move ahead. I know we have had a big challenge of COVID-19, which took us back by 3 months. However, Uganda now has adequate vaccines to cover all eligible people and enable full reopening of the economy. This therefore means we must position ourselves to continue providing services and running the race to end TB by 2030. I know everyone or some people may be scared of the Omicron variant. My call out to you is to get vaccinated, because reports coming from South Africa indicate that the infection remains mild. It tends to infect those who are not vaccinated. And of course, it is also more seen in the younger population. And in that respect, we have been running all over the country from region to region, encouraging people to get vaccinated. So far, we have covered 6 regions. We have 8 regions to go. So I will pause here a little bit, as I usually do, and I will request those who are sincerely vaccinated, without telling a lie, because God is watching and we are watching. If you're sincerely vaccinated, you stand up. If you're not, remain sitting. We shall call our vaccination teams who are outside to give you your jab. Thank you very much. I have seen a few people sitting down. 1 or 2 or 3 are still seated, but you can take your seats. Vaccination may not protect you from infection, but it will definitely protect you from severe disease and death. And it will also help us to keep our health facilities empty. 2 years has been a long time. Our health workers are tired. Everybody is tired, including ourselves. We are tired. People need to rest. And we all know very well that if you are in intensive care unit being taken care of by tired people, your chances of survival may be minimal. It is therefore imperative that we prevent. We prevent, and prevent. It is also common knowledge that as the virus continues to circulate amongst us from one to another, it has fertile ground to mutate. So we must deny the virus the chance to mutate. And we can only do that if we adhere to the standard operating procedures, which is known to all of you. Wear your masks properly. Sometimes I see people struggling with their masks which fall down and does not cover their nose. Why don't you get a mask that fits? I see people struggling to leave the bottom of the mask here open so that they can breathe freely. It is okay, you will breathe in the virus, and you will become one of the statistics that we shall be sharing in the near future, when the WHO finally comes to say COVID is no longer of public health importance. As I conclude, allow me to thank Professor Freddie Sengoba for accepting to give the keynote address, our technical development partners for the continued support, and in a special way, appreciate the organizing committee for your efforts to have this very important conference. We shall be receiving and discussing the annual performance report, and I take this opportunity to appreciate all the health workers and our partners who have contributed to the achievements during the financial year. I would also like to appreciate the leadership of the local governments, and I will mention a few: Iganga, Apache, Sembabule, Nakasongola, Busia, Budaka, Lamuo, Fort Portal City, Arua City, and Dokolo for their performance across several indicators, including case finding, contact screening, gene expert access for pulmonary confirmed TB, treatment success, and TB preventive therapy for eligible clients. I would also like to extend my appreciation to the districts of Obongi, Oyam, Terego, Moroto, Otuke, Ajumani, Apache, Yumbe, and Luengo, who exhibited excellent performance in the traditional indicators of case detection and treatment success. I was actually wondering why you are not appreciating them, and I had thought nobody is from these districts. I look forward to constructive discussions regarding what should be done to accelerate movements towards achievement of the UN high-level meeting targets come 2022. We aligned our programming for TB leprosy to be people-centered through a multi-sector approach with accountability to each other at all levels in the strategic plan. I therefore call upon all sectors and stakeholders to embrace this new approach, which should strengthen the multi-sector collaboration desirable in addressing the social determinants of TB and leprosy and health in general. It is through this way that we will all be able to see an end to the TB epidemic by 2030 and have a country where no Ugandan falls ill with TB or leprosy, and no Ugandan is stigmatized or discriminated. Lastly, once again, I appreciate the organizing committee of the 4th National TB and Leprosy Stakeholders Conference, headed by the program manager. I recognize and appreciate the efforts of the Defeat TB Project for the support in preparation of this conference and finalizing and printing of the annual report. It is now my honor and pleasure to declare the 4th National TB and Leprosy Stakeholders Conference 2021 officially opened. For God and my country.
Another very big clap. Thank you very much, Honorable Minister. Honorable Minister, we have one more request.
I was told that there is a launch. Should I sit down?
Yes, we have one more request to launch the CAS-TB approach, which is on this side. And I request Stavia to take 1 minute to tell you what this approach is about. Maybe. As Tavia comes, please allow me to recognize that we have here the RDC of Wakiso District, Mr. Damba Musisi. You are welcome, sir. Honorable Minister, also allow me to recognize 3 cows who are with us here. The cow of Buikwe District, Godfrey, cow of Buikwe District. Okay. We also have the cow, Deputy Cow, Bundibujo, Kisungu Zakayo. Thank you for coming. And then we have the Deputy Cow, Masaka, Tinka Betty. Thank you for coming. We have 12 DHOs who are part of this physical meeting, Honorable Minister. Let's clap for the DHOs as well. Thank you. Yes, Stavia, tell us what the CAS TB approach is in 1 minute.
Thank you, our chief guest, Honorable Minister of Health, Dr. General Captain Oshel, the representative of the U.S. ambassador.
We have observed the protocol for you, Stavia. You can go ahead.
All protocol observed. Ladies and gentlemen, CAS TB, the new approach, the out of the norm approach to addressing tuberculosis and leprosy in Uganda. This is community awareness, screening, testing, prevention, and treatment campaign for tuberculosis and leprosy in Uganda. The campaign is geared to accelerate our strides towards achieving, first of all, the UNHLM targets, which we have heard we have to account by 2022, but also towards ending TB as a public health problem in Uganda by 2030 and attaining a zero leprosy status in this country, where no Ugandan will develop or suffer leprosy. It will take a shape of a door-to-door campaign where we will engage at least one VHT in each village to visit the households every 6 months to screen them for tuberculosis and link those with TB or leprosy to the health facilities. This is going to be on top of routine screening that they do between the 6-monthly period. The approach will also create awareness in these households. We hope to leave IEC-related materials about TB and leprosy in each of these households in the first round of the campaign. So it will take every 6 months, home to home or house to house, with the screening, with the testing, prevention, and treatment. And for prevention, especially for contacts of TB patients, we target to initiate at least 3 contacts on TB preventive therapy using this approach. This way, we hope that we'll go a long way to achieve the UNHLM targets that we are progressing not so well, especially the prevention arm. I thank you.
Thank you. Thank you very much, Stavia. Honorable Minister, we request you to launch the approach by signing, what is it? And the Minister will be escorted by Dr. Lisa, by the DG, Minister of Health, by Dr. Isiko, Stop TB Partnership, Honorable Joel, the Director, Governance and Regulation, the CEO, Defeat TB, a representative of IDI, representative of CCM, and the program manager, of course.
Ladies and gentlemen, as the launch kickstart, I want to bring you to speed to also know that in the bag which was offered to you, you have all the conference documents, including the items you would want for guidance. Even the cast idea is inside that bag. So dip in your hand in that bag and pull out. Whatever you pull out is useful. They contain those documents. Again, when you get out those documents, look at one which resembles the one I'm holding here. Now, that one contains inside it, from page 15 through to the end, you will get the program for the day of today and program for tomorrow. So all what we are doing is in that booklet. So don't be left behind. And that's the reason why we gave you that book. Please, the launch is going on. People are pending their signature, which is a sign of commitment that I commit to do what I have been told and what I have read and what I've understood about eliminating TB from the face of the earth. And so those commitments are not a joking subject. When you put your signature, you are committing. And don't fear to commit, because the battle is ours. We need to take this battle back to the organism. So ladies and gentlemen, thank you very much. Remember, after the launch, there's going to be a group photo. After the group photo, you will have earned your break tea. Sorry, we shall give you a late break, but that's what the situation demands. So just prepare. When we finish with that, have the group photo and have the break. That's how we shall run. And after that, we all know that there will be the keynote address following the break tea. And I've already told you who will give us this keynote address. Prepare for it. But also, remember, at the beginning, I told you that a remark from a TB survivor who is an adolescent would come soon. That we shall do during the icebreaker. And you know the icebreaker is going to come immediately after the keynote address. So prepare for that. You have not lost anything. Thank you very much. You can continue to observe as people commit by signing, and observe very carefully, and also take note of those ones who are signing. So walk with them this journey. Ladies and gentlemen, again, I want to bring you to speed that there will be two people to give us keynote addresses. We said there will be Professor Freddy Sengoba. That is somebody who is here with us. But there will also be Mrs. Ines Garcia Bani will also give us a key note address. Professor Freddy Sengoba will set the stage. We'll begin, and that will be followed by Madame Garcia. So don't get surprised when you hear two separate voices all speaking to the same aspirations. That is how we shall do it. Madame Garcia will speak on behalf of WHO. That is how it will work. Yes. The launch is still ongoing. After that, I think the same team that is doing the launch, committing by signing, will again accompany the Honorable Minister for a group photo. You do a group photo before we usher you for tea. So we are doing it here. Guidance is that the group photo will be here. And again, because we are committed to physical distancing, don't mind if don't mind if you are not captured in the picture, but would love that the honorable members of parliament who are here with us also join the honorable Minister of Health to take this photograph together in memory. So honorable members of parliament, you are welcome for the photo shoot. Please don't capture me, I'm not part of the... Thank you, thank you. That's wonderful. The photo shoot is taking place. And ladies and gentlemen, I've said after the photo shoot, we shall go for break tea. But remember, when you look against the wall where we have written Imperial Resort Beach Hotel, there are a lot of exhibitions there. Please, as you go for break tea, as you keep around in the building, remember those exhibitions are for us all. Have a glance, read what is there. You will be taken through step by step on what each exhibition stands for. Don't miss out their useful information in those exhibitions. So ladies and gentlemen, there will be no formal order of the exhibitions. The exhibition material will be here with us the whole day of today, the whole day of tomorrow. Take your time, at least put an energy to look at those exhibitions. Thank you very much. And so, as you look at the back there is a door which will usher you outside of this hall, but you find a table set for you for your tea. There is no high table for that tea break, so just go out there and serve yourself. Don't even ask me whether there is a coupon. I have taken care of the coupons myself. So just walk out there and serve yourself. I'm giving ourselves only 20 minutes for this break tea. So don't waste a lot of time doing what is not constructive. Get your tea, take it quickly, exercise as you walk around, and come back. In the next 20 minutes, we want to have the keynote addresses running. So ladies and gentlemen, please, the time is strict. The time is strict. Thank you very much. Ladies and gentlemen, the tea is compulsory. That's why I took note of your presence here by registering you. So please make sure you take our tea. Yes. So please make sure at least you visit an exhibition stall, at least for today. Make sure you visit an exhibition stall. Yes, please. So ladies and gentlemen, the exhibitors are around, they are waiting for you. Don't disappoint them.
Karamoja is one of the poorest regions in Uganda, with an approximated population of 1.2 million people. In 2019, the Ministry of Health declared it as one of the most TB-burdened regions in the country. with 5 out of 10 patients completing treatment, 3 cured, and 2 succumbing to the disease. The following year, the area notified 1,075 new TB cases, affirming the alarm that the fight against this killer disease is far from over.
TB is one of the most important diseases in the sense that it causes a lot of death and illness in the Ugandan population. And every year we expect to have about 82,000 new TB cases in the country.
And it is pertinent that we remind the people of Uganda that TB is still a big burden in Uganda. And Uganda is one of the 30 countries that is still grappling with this high burden of TB.
The highest crude prevalence of tuberculosis was reported in the Karamoja region at 2,394 out of a 100,000 population, almost 10 times the national average.
Ever since TB has been in Karamoja, we have had also MDR cases. Cumulatively, 50 cases have been notified since the beginning of the programmatic management of drug-resistant TB in 2015.
The region's treatment success rate sat at a low 48% in Uganda, and this was linked to the migratory nature of the pastoral communities, low income, and lack of education. This necessitated the intervention of several health organizations like KUAM to support TB patients' complete treatment and see this rate improve.
Since 2018, Doctors with Africa KUAM is implementing a TB program with funding support from the Italian Agency for Cooperation and Development and Fondazione Assistance Internationale, covering the 5 southern districts of Karamoja region. The project aims at supporting the districts, their facilities and the communities in improving the quality of the TB service delivery, both for drug susceptible and drug resistant tuberculosis.
Maria, Abunta Young, a lot of a sub-count to pay Paris, Locuma. A guy I ram a rebo. I can't think why I rebo. Togaking I crebe, Nakan, I crebe Nedadang, Taka, I come in Nedadang. So I will keep you running. A guy on you, Pacaladactare, Roinis, Layapi. Abay a lot of men. Kayararokum, Paka. Roin is in it. All a Kayarokum, Mara Yarokum and Paka Kampala. A Yakazing, no moon yet Arkumalo, a Roin is. Abuna is. And he kept Bonga the Kamaga, a result Kamaga in Yaboka. Upon it, not when I be TB.
After Maria's 2-month treatment, she was discharged out of hospital and directed to take her medicine from home. But after 3 days, the doctors drove to her house and picked her up.
Maria, you like in your Akonirukum. You like in Akonirukum, Mangerenyo, Nikito Lugu. Angerang told you, Like Lugu. I toner a Parakonirukumai, Kidiama.
Maria's TB level had escalated to a multi-drug-resistant stage that, if not attended to with haste, could be fatal.
Amazing and Danny near Kakin. Naganyang Kado Katavakayong, Lore. Apani Yona Lore. A mamma Kilele, Labo Labuni, Ayan Yonayokoi, a lot of time. Yebune kilepa kaje tarauni aipi kayo ke kilongo agwe kilongo tema be are zilimu kwane riamuneta beronaga.
Left to fend for her and the kids, Maria received some transport refund from KUAM and more assistance from other partner organizations that would continue assisting her under treatment.
Ngale ubo ko na kwa. Kana kina yong nka bro lugwa kana na ke moy. Ngoro lugwa uto hemaret. Alu kwari. Ngoro ngo mona lugu. Ke transport ngelenga. Kone ko jela ngina ya azim. Patenga azim naga. Ko tara to pipe nyoni akowan. Ani la tala ramune reke ci azim. Kori itingi yade ko zinamba. Ni radio ni iriacha kina na kowan. Taramuni. Taramuni azimu ai magane ni kes. Ba e boy je gangat. Eni ka yong to luka ngezendani na amazicha ni arenga oporo epe David. Ba oporo epe David tama ai aka opore ka yong. Kana emazi ya ketoy kamazi ngezendani. Emazi ya ketoy kamazi ngezendani aka opayang.
Once again, Maria abandoned treatment for a week.
Taramune tenga da kata ikugazi. Ke buana zanaga tarama azim ngeda kata ilu tarama za maga. Bo rika mam yobuna Maria ngata ka za bit ngebuna. E mam yobuna jek. Ito koy. Ena ngaki ni akaramba gine tena bogugi. Maria nyubo. Nyo mam ngibuni ti yonga atama ka opurika yonga jek akamata kitoy. Bian ezi chok na be peza tama. Bian araba gwa angololo talelew. Ayo na ngin ta daw na yene ni etoruni. Zicho kwa ngina. Todo lete kuki kama. Ama toka pa lore nege ko munete renga ka kala ye la pa ngon. Apa ya gu. Ako munete. Mari atonyo ai ape gitu ai ima. Mi akira mana boko ala ka pa burundra ngara bunere. E boko ya mam. Nyango unterio ngatonyo ga pa na lo to. Be chale tu ataga kente kwangin. Kamare te to nyoro yong ha nyawni. To nyawni ka ko ngeda ngare lugu. Ni ada ke ka ngini je atama ri afana. Wa gini boro la ke ka puru ko daji ko ngina peje ka ba. Lolo robo kana ba ngakrona. Du boy gini malo tana ya maga ka panisi nganga bito ngine ngare. Boy gini ma je. Buya ko kai buya ta ka ta ya tama. Wa ke je kira kan mo je. Wa Karau na isi caya na ya beneran na i. Maka magai boy kini nyata bito ngare luga ni abonguni na ya tamaru apan na ilore. Betolo tolore. Bu na isi cala fe. Ai na ngite na ka keto ka ke mo. Ka zelenga lugu ngoro lu dadang he mare to lugo ka uto. Obu na ya la felakal. Na buni na tamakna na ite tama ka mo ina bo ka ya keto e. Ka pe do na ba lo isa ki boy ya maga. Aki boy kama wezi kinta yong kade boko nan kade lu chiklugu na e kwana e kile dalo ye na mani e mamu na boy che mamu na boy che to ngani e pedo rak daran kade e lili ngara lili ana yang ngiri kina ya ke tay logo tarawu na ya wona ke tay paka la da ke tari logo toro de lo de na ka abeziti na kera na ga Elozi, ako ame kata nini, maka eno ayo. Yawo neni keng, na ya lozi na ye eliko na neni keng. Eliki na ya na kata neni keng. Ni ka be si aka na tengena na sena kere. Eliki jike kata neni jik. Aja ko na pe. Aja tene rongo na jikara kara na rupia majik.
We are glad to say that the strategies introduced have been able to improve generally the quality of care offered to the TB clients, including a strong follow-up of the patients in their communities. And the main results of these strategies is an improved retention in care that is then later translated in better treatment outcomes. In fact, in the last 2 years, we have seen the loss to follow-up rate reducing from 42% to 8%, and the treatment success rate instead increased from 36 to 85%.
And because of the QAM intervention, we managed to put the first gene expert, the machine that detects that organism which is resistant, okay, to the key medications. We got the first gene expert and put it in Matany Hospital. And from there on, we continued to build on following up the patients who were picked up wherever they came from, using a model of care which we have now coined as ambulatory care model. Okay, so we were following these patients and treating them close to home, okay, through their nearby health facilities, Health Center 2, Health Center 3. Of course, we had to do the needful to train the staff and give them the capacity, those health center staff, to give them the capacity to be able to put these people into proper treatment and to follow them if they got lost.
Another TB survivor who has benefited from this good job is Okalapo.
I came to understand the virus when I was working in Masindi. I worked there for almost 9, so the 10th year, that thing now started coming to me. I didn't know that it is maybe TB or which illness, whereby I tried to go to the early centers to take the sputum to check whether what illness is this, but actually I failed. Then reaching the 31st, that is 2019, I had to say myself, since I've failed to identify what's happening, it's better let me go home. I find elsewhere what is happening. The 31st, I reported to Matany Hospital, whereby I was sent for X-ray, saying that wait for results. When the result came late evening, they said that admitted to TB ward. When I was admitted for 2 weeks, I received treatment. After receiving treatment, then they said you can now go home and start getting treatment from your nearest early center.
Paul started taking medicine from home, but his journey to healing was averted by the global coronavirus pandemic that exposed him to social segregation and stigma.
When COVID-19 came in, things become disorganized. Now people came to think that, since the virus has come, which is finishing people, this might be the virus which these people they are having. Even where I was staying, they had to talk to the landlord and say that, why are you keeping this kind of people in this area? Or you want all people to die? They had to go to write letters to police to go and report to the OC. The OC came to me and said, please go and get your clear clarification from your doctor.
Paul was pushed to defend his health status as fear of him spreading the coronavirus in the community was escalating. He turned to Kuam for assistance.
I went in the morning up to Matany Hospital. I got my staff plus the doctor of Com group. I told them what is going on and what is happening, and they wrote for me a letter. After writing a letter, I brought back to police. They brought a report back to the people. And the people were not understanding it. They couldn't pick it. Even though you go to the market, you say, please give me, maybe I want tomatoes for 1,000. They had to say, these things are not for sale. They are not selling it. Because they know that this person is what? They suspect it has a coronavirus. Even though you go to the shop, they say, things are not for sale. I say, no, what is happening? If these people have started eating me like this, even though you come and sit with people like this, People started running. I say now, things are worsening. Unless I was renting a certain house in the center, whereby they told the landlord, we are giving you days to remove this man from the house. Let him go back where the parent is.
Even with a medical clearing later, the community still dejected Paul and drove him towards suicidal thoughts.
Now, when I think myself, I say, if the community has rejected me like this, now there's nothing again which you can do in this world. It is better you go and what? And just enter to the river. Then when I called the Kwam group, they told me, be patient. They are going to come and we talk to the community and we tell to the community what is happening. The Kwam group doctors plus the staff doctors, they came all together and they talked to the community and they tell them, this guy is not a coronavirus patient. He was detected as a TB patient, whereby we kept him for 1 month in the hospital, releasing him out, knowing that that germ which was spreading to others as what? Has died. If he goes home, he will no longer spread to what? To others.
Through such challenges, QUOM and supporting organizations continue in the fight against TB by continuing to avail assistance to the people of Karamoja.
Yeah, we call upon the government through the different partners to put in place accelerated interventions in the communities, help identify,
Hello, ladies and gentlemen,
detect,
thank you for accepting to take
and
tea.
bring back
And I
patients.
told you tea was compulsory, and I know the tea has been very nice, but I think let's reconvene. Let's reconvene. Those ones who have finished with their tea, please can we take our seats? Our time is up. Ladies and gentlemen, do you hear me? We want to reconvene. We have a lot of activity in our hands. Hello, those ones at the back, those ones doing exhibitions, please. I'm not asking you to chase them, but just close the discussion now. Let's get into the next session of the program. Okay. I'm going to make that announcement. Okay. Yes, ladies and gentlemen, as we reconvene, can I request the people who made presentations that those presentations were very insightful, they were very intriguing, a lot of information. There are people who are requesting that this information be made available to them for reference purposes, but also for use and consumption at whatever level. And so we shall make efforts to avail some of those presentations. You will approach the secretariat who will make that available for you. Okay? Ladies and gentlemen, let me take you through again what the program stands like for this hour. At this very particular moment, we are getting into keynote addresses, and there are going to be keynote addresses by two people. The chair has not yet changed. The chair for these keynote addresses is still the Director General Health Services. I would like to invite the Director General Health Services. Please come and usher us into the next session. People would love to receive the keynote addresses. Okay, ladies and gentlemen, I was also guided that this same session is shared between two chairs. One is a co-chair, and that was to transition the chair of this session from the DG to Commissioner Dr. Patrick Tusime. So as we wait to receive the DG, may I invite Commissioner Dr. Patrick Tusime to come forward and take the chair and usher us into the keynote addresses. Yes, we can see Dr. Patrick Tusime coming, please. You are most welcome. Come and take the podium. And we start with keynote address. So as Patrick Tusime takes us through the keynote address, remember immediately after the keynote address, there is an icebreaker. Around that time of the icebreaker, we are going to have a presentation or a remark from a TB adolescent survivor who is already with us here. Immediately after the keynote address, I pray that the chair, that is Commissioner Dr. Patrick Tusime, invites this very important and special person to come and give us a remark as an experienced person who has gone through this disease called tuberculosis. So you are most welcome, Dr. Patrick Tusime. The chair is all yours. The session is yours. Thank you. Okay, ladies and gentlemen, I take the pleasure to hand you over to the next chair, that is Commissioner Patrick Tusime, to take us on. Thank you very much.
Thank you, Dugum. No, he's called Dugum. Dugum in the local language means the sound of a big gun. So we thank you, Dugum, for taking us through the first part of this conference. Honorable Minister, members of Parliament present, all partners present, all protocol observed, ladies and gentlemen, we are starting the next session where we are going to have keynote addresses. And the first one is by Professor Freddie Sengoba of the School of Public Health. Dr. Fred Sengoba is an associate professor of health economics and health systems management with over 20 years of teaching and research in health policy and systems. He's the chair of the Health Policy Planning and Management Department and director SPEED project and the Center for Health Policy and Systems Development at Makerere University School of Public Health. Dr. Sengoba has background training as a medical doctor and has worked in a clinical setting as a hospital director and as a district health officer. He has a doctorate covering the intersection of public health policy and institutional economics from the University of London. In the last 17 years, Dr. Sengoba has been teaching and has been doing research focused on health policies, program design, implementation, and health systems development. He has led a multidisciplinary team undertaking health systems assessment for Uganda, the National Maternal Health Review and Consultative Study, operationalize national plans such as safe male circumcision for HIV prevention, reproductive health, and health workforce and financing reforms. Ladies and gentlemen, this is the person going to speak to us as he delivers his keynote address. Professor Sengoba, you are welcome. He'll do it online. You are welcome to start the keynote address.
Good morning, dear delegates at today's fourth annual Tuberculosis and Leprosy Stakeholders Conference. My name is Freddie Sengoba, and I work at the School of Public Health at Makerere University. It is a pleasure for me to be invited to reflect on the topic of today, that is financing the end of the TB epidemic in Uganda. Before I go further, let me appreciate the invitation I've received from the organizers. I want to thank you very much for organizing yet the fourth meeting, and this shows commitment to the topic and subsector over the last three events. I'm privileged to be asked to give today's talk together with others. I wish to salute the Honorable Minister, all invited guests, and fellow ladies and gentlemen. When I was given this topic, I quickly looked at how much the media has been preoccupied with the pandemic, especially of COVID, and in there looking at the issues about financing and how in the last 2 years we have ideally managed to shift a lot of our financing priorities to deal with the epidemic. And I want again to thank the minister herself, the government, and all Ugandans who have played very positive roles to see that we are at this stage in the pandemic. And as you know, Uganda has done fairly well relative to many other countries, given the resources we have. So if nothing else, at least these stories show that we care about the costs and the financing of programs, at least the pandemic as it has evolved. It also reflects the fact that there are many priorities that remain or can be brought to bear as we think about how much we have spent. And clearly, I believe in this conference, we'll be looking to see how can these overlapping pandemics, our needs and financing claims can be balanced so that progress being made in programs like TB do not necessarily get negated because the shifts have taken resources away from continuity and sustainability of those programs. Allow me to quickly reflect on why we need to look carefully at the financing of TB services. Clearly, like COVID-19, this is a contagious respiratory disease. It's a disease associated with poverty, overcrowding, especially in living conditions where people don't have decent space for a board. Is also associated with the weakened immune system, especially if people have conditions like cancer, HIV, or other conditions that reduce their immunity. And we know that these are amidst us, and we have to pay attention to TB, especially as we try to manage the epidemics that are likely to bring about more HIV or more cancer and related conditions. We also know that TB has a vaccine, and us in Africa, in Uganda in particular, we have been having good immunization, especially for tuberculosis, almost at birth, and this is very high in the 80s and 90s in terms of coverage for children born. There is also a clear systems problem in the fact that part of the reason we have TB is that we have delayed diagnosis and treatment. So many people who come with chronic cough may not be easily diagnosed quickly, and they continue to spread, especially those who have open TB, which can easily be spread through cough and just like COVID. We also know that TB continues to be a disease of very high stigma in the community. So even those who have it have reason sometimes not to come early or to not notify authorities and receive the care they need. We also know that because of that and many other reasons, this is a treatment that takes a long time. Treatment failure is always a problem. People don't complete their medication. And the biggest danger now is that we start to culture or get bacteria that are resistant to the medicines that are available or the medicines that are likely to be cheaper for a country like Uganda to afford. So as we get resistant TB, then we are going to end up with more costly treatments. The good news also is that we've had through TB and HIV opportunity to actually improve our diagnostic and laboratory capacity as a country. But also this comes with extra cost of trying to ensure that we are able to diagnose and manage all cases, as I will later reflect. And these combined together give us a unique opportunity for us, or a unique perspective for us to look at how we manage TB and how TB success or treatments or case finding and generally the benefit we make by trying to reduce TB can come to be useful in terms of reducing costs. But clearly we have these issues that all combine to make TB care and financing a challenge. Just briefly to say that as we continue to face the pandemic, we also continue to note that TB remains a fairly big public health issue. Annually, we lose about, just globally, about 1.4 million deaths, and many of these happen in sub-Saharan Africa and Asia. So we have a lot to contribute, just like we have clearly seen a death in the last 2 years of COVID climb up to 5.2. But let's remember that for TB, these are annual figures, and every year we are facing the same situation. And unless we take on the challenge posed by WHO to try and eliminate TB, we will continue to have a big welfare problem in terms of the people we lose because of TB. There is something to celebrate on TB. This is data coming from 2016 and does show from Uganda the cases for TB have been going down. At least the trend is looking in the right direction, meaning that a lot has been done, and we need to acknowledge and celebrate those efforts and thank all those that have been involved. But still, we can see that we continue on an annual basis to have literally about 86,000 new cases of TB. We continue to have about 15,000 cases of mild drug-resistant TB, especially to rifampicin. We also see that this triad of HIV and TB continue to go hand in hand, and we have about 11,000 HIV positive also having TB every year. In terms of case detection, I've just talked briefly about the laboratory diagnostics. These have improved, but clearly diagnosing a case is costing us about $80 per case detected, meaning we continue to face a big cost, or we have to test very many in order to identify a case, which is also a way of saying that we are going to be spending a little more money as we try to find these cases, but this is definitely money well spent. We also know that those who have TB face major loss of earnings. They tend to be poor, but also they tend to spend a lot of days out of work, partly because of sick or treatment, and that is an extra cost that it may not be faced in the health system, but it's important for us to reflect on and see how to mitigate. As I said, we have this dual challenge of TB and HIV. There's a study that was done, Uganda, trying to do geo correlations. On the top, you see how Uganda appears in terms of TB prevalence and down on HIV prevalence. The paper eventually comes up with correlations of about 70%, which shows that in many places, regions with the ITB also tend to have HIV. So we need to manage this together, and also to say that in here lies the opportunity that as we are trying to fix the HIV, a lot of improvement in TB, thanks to programs like PEPFAR that have come to address this, these two, and the Global Fund and others that have actually led the investment in terms of care, diagnostics, and the technology adoption that have helped Uganda to become one of the few countries that have actually been able to meet the targets as set by UNAIDS for HIV, that is the 90-90-90. And in a sense, that also speaks to the capacity that this has helped to lift the TB detection and treatment. Just looking at the diagnostics in 2012, you could see the number of labs that we had with the gene expertise, and there were very few. By 2017, the country was fairly well covered. As we speak, we have over 237 centers which can do gene expert. And when COVID came, many of these became part of the technology that we've been using to try and do COVID testing. So we can see that the investments we've had to try before to deal with one problem has been also a solution and has continued to build our resilience going forward. And for that, I think we need to be proud. Definitely a lot to do in maintaining those laboratories in terms of people, in terms of equipment, maintenance, and the like, I think, and of course, getting the supplies is not cheap. But on the other hand, I think we can see that that investment actually can pay off in many ways, especially when we speak of the current pandemic. Briefly about the financing. You are speaking about Uganda trying to meet its TB treatment obligation, as well as other healthcare needs. We know that part of it is to do with the tax base. How well is Uganda being able to collect revenue? I just want to remind you that the biggest insurance for all of us is government and how it spends on health. And so government financing or tax-based financing is our primary number one insurance. So how it generates funds in terms of taxes, how it pulls those funds and distribute them to different needs, all is important. So we need to be looking at not only health expenditures, but also where are the other funds going, as we'll see much of our funds now are going towards roads, security, and paying debts. And debt currently is a big area of national spending, more than health, more than and education combined. And that tells you that, yes, as a country, we are continuing to face big challenges, including paying back money we borrowed. But how do we ensure that human capital elements, here we are talking about health, education, gender, are also important? Because that's where the TB and other health problems sit. The other element of this is the fact that Uganda continues to be mainly bankrolled by donors in terms of its financing and household. So out-of-pocket expenditures are very high, just like donor funding, and the money coming directly through taxes to finance health is real about 15%. This is the same graph to show that over the years, that picture has not changed. Government is still at the bottom with about between 15 to 17%. The blue is the development partner or donors, hovering around 40%, and household also around 40%. And we have very little private insurance, which is around 2% and not increasing for a long time. On the right side, you see what I would call the trend for financing. Overall, we'll see from 2013, 2016, and that's where the data I had ends, we see a trend going a little down south. Although as we add more years, we start to see that it is leveled off. But where we should be is the line up there. That line is coming out of the Chatham House study that was trying to look at what it would take to provide the basic universal coverage package in a low-income country. So we should be around $120 per person now in 2020, but we are far from it. And you can see the gap that is being built between where the funds are at the bottom and the purple line on top. And if that gap continues to grow, that means we may not be able to achieve what we are calling domestic financial adequacy, because clearly the gap is becoming big. It's also a risk that some of the programs doing well now may not necessarily remain so. So we really need to see how that gap is reduced. And in the process, I'll be talking briefly about some of the things we need to do across the financial financing spectrum. But before I do that, briefly about how government funds are currently structured. So we see government as our first insurance, and domestic financing is very important. But let's also remember that external assistance is part of government financing. External funders, bilateral friends, and governments give government money to try and help Ugandans, and the government should ideally also be interested in how our external assistance funds are used. And here, sometimes government doesn't do as much due diligence as it does for the monies. Much of the monies we see in external assistance don't go through the national budget, and sometimes they are outside of the scrutiny of government, which we needed to try and address as we go forward. And that is one of the areas I believe a lot stands to be benefited from, because clearly there are inefficiencies that can be able to improve the financing. The other issue that is important, which I think I've already touched on, is off-budget funding tends to be a lot. And as you can see, HIV financing in that year was literally that 2018-2019 was much more than what government was having for health through what I would call health budget. So clearly you can see that HIV, and if you add other programs like malaria, reproductive health, and essential drugs, they may occupy almost 60 or 70% of the funds available. And most of those tend to be off budget. The ones that are on budget are the ones that have unpacked down below. And there you see where it is going, mostly to primary care, pharmaceutical products, referral hospitals, clinical services, reproductive health, and the rest. So that is more or less how the picture pans out. Coming to what we actually spend healthcare funds on, we'll see that TB, our topic of today, actually takes about 1% from the government. Although since that year, that has doubled from about 1.2 billion to about 1.4 billion. The latest figure we have, and we appreciate that doubling, but it still brings us to 2.4 billion Uganda shillings. If you compare that to the support we got for the current same period, it was almost 24.5 billion. That's about $7 million. And so for every 1 shilling we have from government, we have almost 10 from funders to contribute to TB. And that alone tells you the journey we have to travel in order to cover as much if we are going to fund the entire TB within the domestic resource space. So there is a lot more, 10 times or tenfold to climb. Clearly, donors have told us that they are reducing their contribution. We call it donor transition, and some governments have already made a good their transition. We've heard from our former masters, the UK, that the external aid has been cut almost to half, and the priorities have now gone to Indo-Asia as opposed to Africa. So, and some programs, especially that have been financed through UK aid, have already have started suffering the cuts, because many of them have now gone into a pause. Which now brings us to the question, can government absorb these costs, and where is the money going to come from, and how will the TB programs cope? We clearly don't want to see a reduction in progress. On the other hand, we want to be realistic and say, how is this funds going to be addressed? And that brings me to this framework, basically trying to see where are the areas we can look. But I think as we look internally, I can't shy away from saying that we are going to continue to look for resources within our external friends, because we know that our economy may not be in position to shoulder all the health needs, but there is areas where we can improve. And this framework here has basically the households and the communities, those that have resources from which we need to mobilize those resources, and then those monies need to go to those agencies that are going to serve as payers, insurance, or government. And then those will pay the healthcare providers, and healthcare providers will provide the service back to the household. But in the middle there have to be a financing policy and systems that work to ensure that those relationships are well managed. Briefly, the relationship between household and those that collect the money, there are aspects we can fix here. This is where we look at government as insurance, but also we start to think about how do we establish contributory health insurance. I think we've been talking about the National Health Insurance Bill back and forth, and that is one of the areas where we can mobilize some resources. But as I was later said, this takes a journey, and we needed to make public expectations very clear. But on the other hand, we need to expand public awareness about insurance, provide the subsidies for the poor as we design those initiatives, minimize the administrative costs so that we do not spend all the money into paying salaries of people running the fund, as opposed to putting the money into the service. And of course, innovate to reach the informal sector, which may not necessarily be easy to collect funds from. And also, of course, in that area, also looking to see how to reduce the off-budget financing where possible. The other relationship is the relation between those that are paying and the providers. And here we are looking at how do we become more strategic in the way we purchase healthcare from both public and private sector. We've had a big fight literally about how to bring the private actors into the space for COVID and also for epidemics, including TB. Clearly, those who go to the private sector are literally not registered in the program, and many times they are considered as not receiving care, but we have not taken enough of our systems to be able to harvest the actions of the private sector. And I think that is a low-hanging fruit that need to be managed. We need to improve the cost literacy. We saw a lot of uproars in the public about intensive care for COVID, but I think also chronic care like TB is very expensive. And as we start to manage resistant strains of TB, the costs are also going to become very high, and we need to continue to think about that, but also educate the public about it. For the providers, the important thing is to ensure that they are compensated for the services they provided, and those compensations are made in time so that they are able to continue running the business. As we consider insurance, we also need to see how to provide more and more space for autonomous decision-making for our providers, including the public providers. And I've already talked about how to reduce administrative costs, how we set up these systems. The more we automate them, the better, but also ensure that we design the automation not to become a problem in terms of rural and remote providers not being able to be reached. So having empathy in the way we automate, I think, is going to be important. But clearly, we need to ensure that we set systems that are able to reduce the administrative costs. The last part of this relationship I'm going to talk about is the relationship between the providers and the communities that they serve. Here, I think the issue is to reduce the cost burden on the household, because that is one of the definition of universal health coverage, to reduce catastrophic expenditures on household and ensure financial risk protection. But also in doing so, how do we ensure that private providers receive either subsidies to ensure that their services are affordable where they are actually able to provide and complement the public sector. There is a tension between how much we can invest in specialized care versus basic care, but clearly a lot has been done in terms of specialist hospitals, specialist centers, and we have to applaud government for those efforts. But we need also to make sure, especially to see that close to community facilities are actually functional and are able to offer quality services, and that is the best way we can make the services cheaper, but also achieve more coverage. It's also important, especially as we talk about this relationship, that providers do not only go to provide curative care, but they are also able to provide promotive and preventive interventions. I'm glad that the ministry has restructured to ensure that they give prominence to health promotion and community, but I think more resources and more programming are yet to be realized. And I think this is something we need to do, especially how we go and prevent TB. Right now, I'm not sure whether a district that is preventing TB is going to be reflected in the data as not diagnosing enough, or is going to be thanked for reducing the cases, because the data that we are using for TB in many cases is basically does not reward prevention. So a district that probably is able to do prevention will be sanctioned for not bringing enough cases. And this tension, I think, is something that we also need to manage, especially if we are going to ensure that the programs are able to save money to the public purse. We need to improve prevention and reward it. As I wind up, I'll say one or two things about insurance, because this is one of the areas everyone is been looking at, especially these days, to try and improve domestic resource allocation, or resource mobilization to finance health. Just briefly about the flow, it's important because when health insurance comes, it kind of rewires the system differently. This is what we would expect to be happening currently. Funds from domestic revenue or treasury and donors flowing through national budget and off budget, some going through fiscal transfers to local governments, some going through the Ministry of Health to cover those upstream functions, and also through third-party agencies, especially IPs, we call them implementing partners. And then when they get to the local government, they are shared to the health facilities, and health facilities then deliver service to the community. We also need to note that communities also have resources they bring back to the facility in terms of out-of-pocket and others. So that is the basic framework. When we introduce insurance, we also need to see that we rearrange the system and flows. And this is very important in a sense that you will see that the relationships have increased, and every relationship is almost a transaction that will have administrative arrangements and what we call transactional costs. It's also a way to say that as we introduce national health insurance, we need to think about the extra administration and the cost thereof that we are introducing, and ensure that we are able to mitigate them so that they not absorb as much. I know Ghana has been an example we look at, but at some point, almost 40% of the national health insurance revenue was going just for administrative purpose. And that's something we want to avoid. Right now, I think we are still in that space of Mose is asking for more consultation, and everyone is trying to check what do we do, who has been consulted, who has been left out, and how do we ensure that we have covered all the ground. But as we try to address Mose's question, it's also important to make sure that we are very clear about the journey. The journey for insurance takes long, and many times I've had government officials, both in health and outside of health, civil society, friends, they've made the expectations so high and so instant that it looks like once the bill is signed, the following day or the following year, things are going to be put into place. And that public expectation can be a killer assumption. Is a deal breaker in a sense that people get disappointed because they don't see the results immediately. This is the journey of Thailand. Thailand is one of the countries that was able to establish health insurance around, I think it was around 1992 thereabout, with about what they call 30 baht, or about $17 or $19 equivalent per household. And over the years, you can see it took them about 10 or 15 years for them to actually get to a level that they can call universal health coverage up to 2002. that's when they started climbing to a level that's about 70 and subsequently 90% coverage, those red bars that you see. So the point here being that we needed to engage with the public about the journey for insurance and let them know that it's going to take some time to get to function well, but we can leapfrog that, but every time you leapfrog a system development objective, you build vulnerability within it. So we really need to walk the journey and keep fixing the system until it's able to deliver. Otherwise, we run a risk of people seeing in the first 2 years nothing making a difference, their money going, and subsequently getting annoyed and throwing the whole thing on the street. And we see demonstrations are common where these public relations have not been well managed. So in there, I'm trying to say we need to start. Insurance should have started a long time ago. We maybe would have moved a lot by now. But as we start, it's important that we do not oversell the outcomes of insurance in terms of especially universal coverage and financial risk protection, because it takes some time to be realized. And hopefully that way, we will be able to move with the public with realistic expectations. So as I finalize, I think it's important that we continue to advocate for all avenues and of generating and improving the public financing and insurance that is coming on board. We need to prepare the ground so that it is ready. We need, as I said, to make public awareness, and we need to be prepared to learn as we go, because clearly the resources we need are not going to be adequate domestically. We also need to continue to engage with our friends, especially external funders, to see that we do not make we do not go backwards in the progress that has been made. Ladies and gentlemen, thank you for listening to me. I want to wish you good deliberations and God bless. Have a nice.
Thank you very much, Professor Sengova. Another round of applause for Professor. This keynote addresses stimulate our minds to see how big the problem is and also what innovations we can put in place to address the challenges. As we were told earlier, the response is multi-sectoral, multi-stakeholder. Each one of us, we have a contribution to make. It's not only government, it's not only members of parliament, it is not only everybody, including the private sector. Thank you, Professor. We are not doing well with time. Allow me to invite Ms. Garcia Baena. She works with the World Health Organization. You are welcome, Ms. Garcia. Share with us your thoughts. Thank you.
Honorable Minister, partners, delegates, dear colleagues and friends, I am Inés García Baena, and it is a pleasure for me to be with you at this important 4th Annual National TB and Leprosy Stakeholders Conference and share today a presentation on making the case for investing in tuberculosis as a worthwhile but also very needed investment following Dr. Sangoba's excellent presentation just now. And on behalf of the World Health Organization Global TB Program, I would like to start by thanking Uganda and the conference organizers, participants, and civil society who are contributing to the fight against TB. Before moving on to the agenda, I just would like to quote Dr. Tedros from the World Health Organization, who says, health is a human right, not a luxury for those who can afford it. And bearing in mind this, I will do my best to walk you through the evidence on why TB is a worthwhile investment. I'm just wondering if you can see the slides well, and they are scrolling through, I believe so. So I'll be touching on 5 elements during this 30 minutes presentation. First, I'll go through the background on the epidemiological, but also on the economic burden that TB and post-TB impose, using the latest global TB report data for Uganda in 2020. And I'll then touch upon TB as a low and highly effective intervention. Then I'll mention what the impact of meeting or missing the NTB target by 2030 means in terms of deaths, life expectancy, and also economic returns. So what is the cost of inaction? I'll then give some summary of the estimates that have been given on the return on investment for TB. So for every dollar invested, what the return in terms of economic returns is. And then I'll be linking this to your national strategic plan funding and how that looks in terms of the 2030 horizon. So just on the background, as it was mentioned by the Honorable Minister and the acting ambassador for the US, with COVID-19 pandemic, a lot of efforts have been put into ensuring the continuity of essential TB services. However, while 66 million lives were saved due to prevention and care since 2000, the COVID-19 pandemic has reversed years of progress in the fight against TB. So for the first time over a decade, WHO is reporting an increase in tuberculosis deaths. So approximately 1.5 million people died from TB in 2020, including 215,000 HIV positive people. And this is almost the double of the number who died of HIV. That is 0.68 million. So as it was mentioned before in the opening ceremony, TB is the leading killer of people with HIV and a major contributor to antimicrobial resistant related deaths. So with COVID-19 disruptions, TB services have been severely impacted, and in fact, fewer people being diagnosed and treated or provided TB preventive treatment. So as it was mentioned earlier on in the opening ceremony, there was an 18% drop in the number of notified cases globally. And as you see on the graph on the right-hand side of the slide, Uganda was among the 16 countries that globally contributed to this 19%, this 18% drop. So the 16 countries account for 19% of this 18% drop in the number of cases. So what does it mean in terms of the targets for 2030 for the NTB strategy? So we had milestones for 2020, and we haven't done well, neither globally, not at the level of Uganda. So as you can see, the milestones for 2020 included that the reduction of TB incidence from 2015 to 2020 would aim to be 20%, and globally 11% reduction has happened, and for Uganda it was 2.7% the reduction since 2015. So slower pace than desired in order to achieve the 2030 targets. In terms of TB deaths, there was a target, a milestone of 35% reduction since 2015. in 2020 at the global level, and the global level was at 9.2%. However, Uganda was doing better than the African region and also than globally, with 20% reduction in TB mortality due to TB when you compare 2020 with 2015. In terms of TB treatment, we aimed for 40 million cases to be on treatment, and we are at halfway through with 19.8 million, and Uganda with 61,000 cases. In terms of the households that face suffering and catastrophic cost, the goal was already to have 0 by 2020. And as national TB surveys have demonstrated, we are, so evidence from about 23 countries shows that 1 in 2 TB patients face costs that are higher than 20% of their household income. And Uganda implemented the survey and found that 53% of the households experienced catastrophic cost. This is more of the data from Uganda that I will not go into, and it's extracted from the app, where you can compare, for example, the progress of the African region and Uganda. So you can see the TB incidence decline that I was mentioning earlier, that is highlighted on the left, with a decline in 2.7% versus the decline in Africa that was 19%. And the good progress on TB mortality reduction in Uganda of a decline of 27% compared to the 18% of the African region, and more data. And there's more data in additional slides that the chair will be sharing with you after the presentation. In terms of the burden of TB, so it's not only that when there's a recent studies showing that the burden of TB is not only during the treatment, but also if you consider post-TB, the estimates of the burden are higher. So for Uganda, Nick Menzies shared with me the estimates that are shown on the slide from the paper that is coming out this month. And it shows that the disability adjusted life years considered post-TB disease show that 760,000 deaths due to TB in a single year, and additional 549,000 additional due to post-TB. So 71% of the deaths are lost during productive years, so during the period of 65 years. And it is important to take this into consideration when the burden is considered, because it might drive a different thought on the allocation of funding for TB and so on. In terms of the economic burden of TB, as I mentioned earlier, the study conducted by Makerere University and the National TB Program shows that the average cost for a patient during a TB episode is in the range. So it's for drug susceptible TB is reaching $400 per episode, and for MDR TB treatment it goes above $3,500. So these are costs that are, when measured against the ability to pay of households, they show that a large proportion of patients face unaffordable cost. So 53% of households in 2017 were facing catastrophic cost. due to TB. And it's not only the costs that are borne. Many TB patients lose their jobs while they are on treatment. So the unemployment rate amongst the surveyed patients rose to 66%, which means the main means of subsistence are not there to face the cost and to face the cost of living. So it is very important to use the key recommendations from this survey as an entry point to the multi-sectoral accountability framework discussions that you're holding during this conference and later on, and try to find ways to mitigate the cost, both transport, food packages, relocation that is needed when care is far away from the patient and not centered around the patient, and also the loss of income due to loss of employment or interruption of work. So in order to meet the NTB strategy, there are different policy avenues that are suggested in the paper from Mutamba et al. The policy avenues include TB service delivery changes, patient-centered delivery care, contributing to the design of the national health insurance that Dr. Sengoba was mentioning before, because it has to be done very carefully in order to succeed in the universal health coverage access objective. And then also to look at social protection and labor market measures. So it's very interesting that in this conference, you are also involving partners from those sectors that can contribute to alleviating the costs that are faced by TB patients when accessing care. In terms of TB as an intervention, there's extensive proof that TB is a cost and highly effective intervention. So that I'm just showing on the screen as a taster, just some examples from Uganda on how the country is contributing with research to demonstrate the cost effectiveness. So community screening for CAF followed by chest X-ray in Uganda was shown to be cost effective with an incremental cost effectiveness ratio of $536 per year of life gained, and so on. And there are other examples on the use of other screening cost and methods coming from the systematic review of Alsdorf et al. In terms of what the missing or meeting the NTB strategy means. So in the next slides, I'm going to be sharing what the cost of not moving or not accelerating fast enough the plan and the targets and the associated funding would mean. So there's a paper that was recently published in the Lancet Global Health in September by Silva et al. That shows the cost of not meeting the NTB targets globally. So the NTB targets are shown on the left of the slide. And we're looking at the three indicators. So a reduction in the number of TB deaths of 90% by 2030 compared to 2015 levels. So Uganda is doing very well in that, relatively well and better than the African region in that indicator, and is making good progress towards the 2030 target. Then we have the reduction in TB incidence rate that is planned for 80% compared to 2015 levels, and doing this with patients removing the catastrophic cost, which were identified as 53% in 2017 in Uganda. So the consequences of not meeting the targets in 2030 are, the numbers are very large, so and they are in US dollars, but I hope you take into consideration what the humongousness of the numbers means. But in terms of losses, we are talking about 17.5 trillion losses of not meeting the NTB targets by 2030. And if we take trillion, and if that means also in terms of deaths that we would have between 2020 and 2050, 31.8 million dead because of TB globally. And what this means also in terms of life expectancy at birth is that there would be a reduction of 0.31 years if the targets are not met by 2030. Now, if the targets are met in 2030, the deaths will be 8 million, the economic losses will be 4.4 trillion, and the average life expectancy lost will be 0.05. If instead of meeting the targets on time in 2030, we delay to 2045, the numbers on economic losses and deaths and average life expectancy are shown on the slide. So we would have 13.7 million dead over the period of 2020 to 2050, 7.2 trillion economic losses during the same period, and a reduction in the life expectancy at birth of 0.15. What does it mean in terms of the cost of inaction, which looks at the difference between acting on time on 2030 and acting late on 2045? This means 3 trillion economic losses, 5.7 million deaths, and an average life expectancy at birth, years lost, of 0.10. Now, this is at the global level. We actually have the numbers that were estimated for Uganda and also for the African region, and I'm showing this on this slide. So in terms of the impact of not meeting the 2030 target, it means that between 2020 and 2050, there will be 50 billion economic losses and 14,779 TB deaths. And the life expectancy at birth in Uganda will be reduced by 0.65 years. If the targets are met in 2030, the losses will be 14 billion economic losses over the period of 2020, 2050, and 2,180 deaths. The life expectancy reduction, which will be much less if the targets are met. It will be 0.095. And again, if the success of meeting the target is delayed to 2045, the economic losses will be 23 billion. And the life expectancy at birth loss will be 0.3 years. And the number of TB deaths will be 6,901. So what it means in terms of delaying, so not accelerating the response to TB and meeting the 2030 target, it means $9.3 billion plus, in terms of economic losses, 4,721 deaths of TB, and a shortening of the life expectancy of 0.84 years at birth. And the numbers for Africa are shown on the right-hand side of the screen. So very important, these are modeled estimates, but they give a sense of what it means to be late or not achieving the NTB targets. For TB mortality, which is the only indicator that was taken into consideration for this study. So the study didn't look into morbidity. It just stopped at mortality, one of the 3 high-level indicators. So in terms of what investing $1 of TB brings in terms of economic returns, there's some global evidence available, which I'm going to be walking you through, and it mainly stems from 3 global price tags or evaluations. One is the global plan, the current one, which goes from 2018 to 2022. So this is a Stop TB Partnership global price tag. That is the new one is in the making for 2023 to 2030. There's also the document that was used as an investment case for TB, HIV, and malaria for the 6th replenishment conference for the Global Fund to raise funding for the following years in 2019. And we also have the Copenhagen Consensus Group that where around 30 economists from all fields were ranking investments in all sectors and giving a ranking on the best investments. So I'm just going to walk you through the different returns on investment for TB that have been floating around so that you have some sense of what investing $1 brings in terms of economic return. We've just seen what the losses would be of in terms of economic impact, but this basically gives you the rate of return in terms of $1 invested, what you get in per dollar in economic return. So I'll just go first to the Copenhagen Consensus, which gave, so this is basically ranked the investments. And as you see, so this is quite old in the sense that it's from 2015, but the message stays valid in the sense that reducing tuberculosis ranks 5th, 1, 2, 3, 4, 5, 6th on the investments after trade liberalization, access to contraception, reducing tax evasion, increasing migration, reducing stunting, and then comes reducing tuberculosis. So this was the conclusion that that came from the Copenhagen Consensus Group that included some Nobel laureates on economics. And so it's reassuring on the messaging of TB being a good investment. And in terms of what they mentioned on the returns, it was that the benefit to cost ratio for TB investments, which is when you divide the total benefits over cost over a certain period, showed in the period of 20 years, actually, between 2015 and 2035, the return would be between 16 and 82. So up to $82 would be obtained in economic returns with every dollar of investment made for TB. Now let's moving on to the global plan price tag work. So in addition to estimating what the funding needs for the world were and giving some distribution of the funding needs by income groups and by regions, so they didn't go into the details, so the details per country are not published. The global plan also shows what implementing the plan in a standard manner or in an accelerated manner would bring in terms of economic returns. So I produced a graph showing the different returns on investment that are shown in the global plan. So with the standard global plan, that is the one that we always quote and use as a reference also during the UN high-level meeting targets, we also have the funding needs and the plan, which is the global plan standard, that yields $44 per every dollar invested. Now, if the global plan for 2022 would have followed an accelerated path, the yield would also have been higher. Although now with the COVID-19 disruptions, we see that we only have a year to catch up and meet. So if we would have implemented the accelerated global plan, the yield would be $85, which is what the Copenhagen consensus was giving us, the higher yield to an investment. In both cases, they are very high yields for an investment. And then the yield tends to be lower for low-income countries. It would be $13. And the previous global plan, so the one that was carried out between 2016 and 2020, the yield of the investments and the scale up and coverage that was planned gave a yield of $27. Now moving to the investment case that the Global Fund put up in order to raise funding for their replenishment, that document was quoting a yield of return on investment for the 3 diseases that was $19 in terms of economic gains. And it could go, if the coverage was higher than the standard package that they were presenting, so the more ambitious scenario, the yield will be also $34 rather than 19. And this takes into account direct economic cost from the 3 diseases that are incurred when workers are absent due to illness or because they have to stay home and care for sick family members. Children affected by the 3 diseases are more likely to miss school and therefore may do less well academically, and reduced worker productivity and increased healthcare spending have also a direct cost effect on households that can be catastrophic. In addition to this direct economic cost, the indirect economic cost that value the projected health life gains were also incorporated into these $19 or $34 that were provided. So going back to other returns on investment that are quoted, the paper by Reed et al. That is mentioned at the bottom of the slide quotes that for every dollar invested, the yield is approximately on average $10. So again, it's different yields depending on the ambitiousness of the package, but on average, this is what is quoted. Now, WHO and partners are currently, including London School of Hygiene and Tropical Medicine and Harvard, are working on the TB vaccine full value assessment, which wants to quantify. So in addition to, for the introduction of the upcoming vaccines that we hope will be successful in phase 3 soon, there was an estimate of what this would mean in terms of different aspects, including the economic impact. So in an upcoming publication that quantifies the return on investment for each country, and it's used to simulate a model that describes changes in resource utilization, household economic impacts, and health outcomes for every country over the period of 2028 to 2050, hoping that the vaccine would come before 2028. The results, it's very provisional because the work is ongoing, but introducing a new infant vaccine yields above 2 trillion economic returns globally over the period of 2028 to 2050. And introducing a new adolescent adult vaccine yields above 20 trillion economic returns globally over 2028 and 2050. So it's like very large impact that we would gain should the vaccine be introduced for these groups, and in the manner that the investment case describes, so with a certain implementation conditions and so on. Now, what does it mean in terms of so these are the price tags and what the returns on investment that we would get should the package and mix of interventions be as described in the global plan or in the replenishment TB and malaria and HIV investment case and so on. Now, where are we today in 2020? So currently, from the 13 billion that were estimated to be needed per year to achieve the global plan target and the UN high-level meeting targets by 2022, we only have 5.3 billion available for TB globally in 2020. So that the gap is huge. Similarly, for TB research, that follows different funding stream, the target of the global plan there were 2 billion annually needed for TB research. And as the Treatment Action Group monitors annually, less than 1 billion was available in 2019. So again, a large gap. So looking at the actual gap actually globally. So what is shown on the screen is the funding gap of 8.2 billion in 2020. That's the difference between the global plan high-level target of funding and what we actually have as available in 2020. Now, TB is not funded by external donors primarily. It's funded by governments. 81% of domestic funding funds TB. And the international funding comes as 1 billion. So as the remaining 19% of the 5.3 billion that were available in 2020. So in terms of the difference between this available and the 13 billion, we have 8.2 billion gap. And for research, the gap is 1.1 billion, which is financed through other mechanisms, not national health financing. Now, in terms of the Uganda situation, so the gap of funding compared to the global plan targets would be for Uganda 125 million. So the figure that I'm showing on the slide is not published because it's behind the global plan estimates globally. But the estimate that was given by the global plan per year to meet the 2022 targets was around 158 million for 2021. Now, the funding available for TB was 33 million in 2021. I mean, that's the commitment according to what Dr. Stavia reported to WHO. So we have 8 million of domestic funds, which include 4 million allocated through the National TB Program, and then 4 million that we estimate are needed for inpatient and outpatient care, and 26 million from international financing. So there's a very high dependency on the international funding for TB. And still, there's a gap of 125 million should Uganda want to follow the ambitiousness of the standard global plan for 2022. Now, the actual plan of Uganda measured against the available funding for 2021 is less, so that the ambitiousness of the coverage is less than in the global plan. So the funding gap reported is only 15 million, which is still very large. So the message that I want to portray is that the dollar invested in TB getting a $44 economic return is valid for global plan targets. Intervention coverage and funding is met. So if you invest the 158 million per year and you meet the coverage targets and the ambitiousness and accelerated response of the global plan, the return will be $44. Although, yeah. So with this in mind, WHO and partners are calling for redoubling efforts and investments to close the gaps. So we have gone back with COVID-19 pandemic in the global progress of tackling TB and seeing TB deaths increasing for the first time. So we need to place urgent measures to restore access to essential TB services and to doubling the efforts, the investments on TB research and on innovation, as well as the contributions from the national TB budget has gone over the past 3 years. We can see on the left screen that in 2018 it declined to then it's expected to increase in 2021. But of those 45 million that are said to be required by your national strategic plan, plus the 4 million that are estimated to be needing to deliver care in ambulatory and hospital care, there's the 15 million gap. And should you require to step up and accelerate the response and meet the global plan coverage and investment of 160 million, the gap would be higher as 125 million. And on the right-hand side, I'm showing the percentage of the budget that is showed on the left that is unfunded. And there's a comparison here of the trend in the African region with Uganda, which all this comes from the application that is associated with the Global TB report, where you can see and compare how the share of unfunded has gone and other indicators that may come useful in your conversations during this annual conference this week. And this is showing the percentage of domestic funding, which for Uganda, shown in blue, shows that the share of domestic funding is slowly increasing to 10%. Yes.
We need you to summarize. We are running very late. Thank you.
So this is the end of the presentation. Of different partners were asking to ensure sustainable financing for tuberculosis, boosting domestic resource mobilization by increasing the distribution of public resources to health, pooling financing, and allocating tax revenues to health, especially in middle-income countries, reduce reliance on private finance of both private and public providers of TB services, increasing focus donor financing for TB on investments in global public goods, including market-shaping activities, support for TB advocacy and leadership and research and development, continue donor financing for TB treatment and prevention as a priority in low-income countries, and in addition to invest in reducing the spread, particularly across DR-TB, and to develop new models of donor financing to catalyze domestic funding and encourage innovation, and strengthen accountability to citizens rather than donors. That was what was mentioned in 2019 following the UN high-level meeting. And this would be made through a strong evidence-based national strategic plan that you have in place that could be revised to be in line with the upcoming global plan target and coverage. So in terms of take-home messages, Uganda and most of the world missed the 2020 milestones to end TB, but accelerating the response will bring reverting COVID-19 disruptions and redoubling efforts to improve the pace of TB incidence, mortality, and catastrophic cost reduction to meet the targets. And as we've seen, TB is a low cost and highly effective, as Uganda's research has shown, and cost effectiveness is a criteria that is always considered as part of the TB intervention recommendations and plan design, and should be one of the criteria of the universal health coverage benefit package design. And the cost of not meeting 2030 NTB targets is high for Uganda in terms of almost a year short of life expectancy at birth, 50 billion loss in economic returns, and 14,779 TB deaths, according to the Silvidal study. And returns on investment for $1 invested in TB have ranged from $44 to $85. So being ambitious and mobilizing sufficient funding and building a strong national strategic plan should be a good way to aim for the 2030 targets. And with this, I just like to acknowledge the input from colleagues and academia that have contributed to this presentation. And thank you very much for this opportunity to share this important message with you. Thank you.
Thank you very, very much for this enlightening presentation. Another appreciation for our sister. It was difficult to stop her because the information is so rich, and it opens our minds to see the justification for investing in the TB response. The funding gap you have seen, and the last call to redouble our effort as the partners, as the stakeholders, to make sure that we close the gaps if we are to meet the targets that have been set globally. Thank you very much for your patience, all of you. I know we are behind time. I'll need guidance from the organizers on how to proceed. Do we continue with the program, or? Dr. Stavia is coming to provide some guidance. Ladies and gentlemen, just bear with us, and we have one more presentation by Dr. Stavia, which actually is the gist of the matter, summarized in this report showing the annual performance. I know you've sat for a long time, and with permission from the Honorable Minister, she has told me to tell you to stand up a bit and stretch your legs a bit for about 2 minutes. Make sure your muscles move and blood can flow to your brain. Yes. Who can give us that stretching thing for 1 minute? You are done? Are you sure? Stretch more. Backwards, forwards. Eh? Very good. You know, we sit for long, and with age, you can sit at your own pace. If you feel like standing, feel standing. As Dr. Stavia comes, share with us the summaries of our performance in this first year of the strategic plan. Thank you.
Good afternoon to you once again, our Honorable Minister and all protocol observed. Allow me to take you through the achievements of the Ministry of Health as far as tuberculosis and leprosy is concerned for the first financial year of our NSP 2020-21, 2024-25. I am Dr. Tuya Westavia, the Assistant Commissioner in charge of TB and leprosy. Wow. The technology here is a little bit difficult. Either the cells are, you can move the slides from that side, please, as the technology is being sorted. We have known, the vision of the ministry is to have a Uganda free of TB and leprosy, and we stand to provide quality, accessible, and affordable tuberculosis and leprosy services. And our mandate is in policy formulation, is in resource mobilization, planning and budgeting, monitoring and evaluation, and capacity building. And we are mandated to establish a network of TB and leprosy diagnostic and treatment services across the country. So, like has been alluded to, our current strategic plan requires us to reduce the TB incidence by 20% by 2025, and the notifications among leprosy among children for leprosy by about 5%. The 90-90-90-90 targets have been explained by the PS. They stem from creating awareness about the disease to the tune of over 90%, prevention services for those who are eligible for prevention to over 90%, and for those who fall ill with TB to reach over 90% with diagnosis and treatment initiation, and for those that we start on TB treatment, to make sure that they complete TB treatment to the success of over 90%, and we put in place systems to ensure that these happen. And we also continue to look at notifications of leprosy among children, reduced from 8% to less than 3%. So these are the major key interventions that have been highlighted for your information. TB and leprosy in this country are mandatory notification diseases, and we watch these diseases closely and routinely. Wherever diagnosis of TB is made, whether it is private, public, we must notify the case of TB and leprosy. We also take TB in this country as a public health emergency. Because of the burden that we have as a country, being on the global watch list, among the 30 high burden countries in the world for TB and TB-HIV, we cannot continue to do business as usual. We need to continue to look at the disease in emergency mode. We also are looking at having the people who are diagnosed with TB across the country accessing the drug susceptibility test, DST. Now, this is what we get from the Gene Expert machine testing. But because this technology is not everywhere, some people are still being diagnosed with a microscope. So anyone who has been diagnosed with a microscope in the country should have a Gene Expert test for us to know whether they have TB that is sensitive to the treatment, the usual treatment, or TB that is resistant. contact screening for every confirmed TB patient as part of TB prevention in the country and providing them with preventive therapy. The situation has been also said, allow me to repeat that over 90,000 Ugandans develop TB every year. This is not a small number, much higher than the people that fall or get infected by the HIV virus. The mortality is high. Thank God we were able to reduce it by the last global TB report you've had by 27%, which is good progress. Thank you to all who have participated in that progress. The incidence still remains high at that level of 90%, 90,000 people. 196, a reduction of 2.7 from 200 per 100,000 population. We have more TB in the urban setting because of the way the environment is and how we live and the congestion that is there. We also have about 40% of people with TB that do not seek care. The reason why we have launched the door-to-door approach so that we can reach each and everyone who has TB. The tuberculosis and leprosy situation is as that in the country. So in the new strategic direction, we seek to reach out to people who are infected with TB. And for this country, we have prioritized two groups: the people living with HIV that do not have active TB disease. Now, for this current financial year we are reviewing, we missed a good number of these people that were eligible to start TPT or TB preventive therapy, and that is not called for anymore, to a tune of about 63%. For contacts, children under 5, the percentage that received TB preventive therapy is even much higher, didn't receive is even much higher, to a tune of over also 60%. And the ones who are contacts but are more than 5 years, there we are doing very, very badly. We only reach about 5%. Over 95%, we have not tackled this group. Now, there are those that do not, they develop symptoms in the community, but we don't reach with TB diagnosis. That's why our efforts are only reaching 84%. We would like to reach them through the community intervention that we have talked about. There are those who visit our health facilities with TB, but still go undetected. And the reason the ministry has prioritized TB person who comes to our health facilities so that we can reduce the missed opportunities for that. And the Director General has already issued a directive to this effect, that everyone visiting a health facility in Uganda be screened for tuberculosis and managed accordingly. There are those we diagnose with TB because now we are using the Gene Expert, and it's in a few places across the country. You send a sample through the hub system. By the time the result comes, the person has already gone back to the community. So we diagnose them, but we do not initiate them on treatment. The community engagement activity should make sure that all those are identified and initiated on treatment. The ones who are initiated on treatment, the success has improved to about 85% now, but we want to reach over 90%. And this calls for a lot of community engagement, awareness creation, and all of us as stakeholders in this to make sure that when someone starts TB treatment, they are able to complete the treatment. About identifying TB across the country. Now, green stands for those who identified over 90% of the estimated TB patients in their districts. The yellow are those who are between 70 and 90, and the red have gone below 70%. So wherever you are, you can see how your district is performing. But also those who are in green. There are those who are in green but are not doing enough to reach everybody. There's a lot of TB. Yes, you are meeting 90%, but you have not reached all the people with disease because there is a lot of transmission in your community. Do not rest because you are in green. Continue to work until no one has TB or leprosy. The children are one of the key populations we have for TB. The notifications for children have been improving over time, but we still are missing a number of them. We expect that about 17% of all TB cases are from among children. You can see where we are. We are not yet at that level. We need innovations in making simple and accessible point-of-care diagnostics for this group of people so that they do not continue to die from TB. You will see that pneumonia contributes a lot of death in this country. But is that all pneumonia? If it's in children, those children could be dying from TB. In terms of identifying people with drug-resistant TB, that is making sure that every confirmed patient with TB has had a test with the gene expert. We have a number of challenges in that area. We are reaching about 70% of people with confirmed TB or PBCs with the gene expert test. Yet, with the hub system, we can have universal coverage for this test for all our TB patients. We are calling upon all those who are not prioritizing TB patients to get a gene expert test to embrace this so that we can find and treat TB with appropriate therapy. First or second line. To go to second line, you must have had a gene expert test. Short of that, you go on first line and you'll not get healed or cured. Now, contact tracing is a very key preventive activity that we promote and we must do if we are to end TB in this country. But it is done less and less across almost all districts, as you can see. So if you are manning a district and the TB patients in the district have not been visited at home to assess the contacts, because among contacts we expect to find many more TB patients. We have seen this where it has been done and it is documented. Up to 8% of people who have lived with TB patients will also have tuberculosis. But also in some circumstances, you find the person who has come to the health facility is not the primary person who has TB in that household. The grandmother is there with the TB, but you have been able to get the grandchild at the facility. So if you don't go to the home, the grandmother will continue to infect even other grandchildren. So we need to do the contact tracing. This is TB preventive therapy for this other high group that I talked about, the people living with HIV. TB is one of the top killers of people living with HIV, and we want to stop that. And one of the ways of stopping that is providing prevention to those that don't have active disease so that they will not develop the disease and they will live with their HIV and they have a good quality of life. But the performance is also wanting across the country with those very many big reds that you can see in the center, in the north, and also in the east. The treatment success rate, this map used to have a lot of red in the northeast part of Uganda. We want to thank the Karamojong people. Despite their nomadism, they have tried their best to change that. And that is part of the reason you see the national treatment success is coming up. They used to be in 40% of all people started on treatment, completing their treatment. They are now in 80%, which is very commendable, and we want to encourage everyone to know that this is possible. If it can happen in Karamoja, why not in my own district where there are no even people moving with cattle. What is the reason I'm still in red? If you see your district in red, I see Kisoro there. I see, I don't know whether that is Kitugum. In red, think about what is you are doing as a district to make sure that people are kept on treatment. So this is generally the national trend in terms of improving the TB treatment success. We want to say thank you to everyone who has supported this process. It has not been easy, but we want to go to the over 90%. And we need your support to achieve that. The drug-resistant TB case finding remains wanting, like I said, because we are not testing TB patients with the gene expert. I will not go into the details of that. The testing among people living with HIV, we are doing quite well. We have been above 98% testing them for TB, screening them for tuberculosis, which is good, and initiating them on treatment. A little about leprosy. We have heightened our efforts to search for leprosy as a country. We want to get to the zero leprosy status by 2030. But we cannot get there if we still get people with leprosy who have no hands, the feet are gone, they are full of ulcers, or the children are still coming up with leprosy. We have to go and find everyone out there that has got leprosy. And we are integrating that into the CAST approach that we have launched today. That as we search for tuberculosis in the households, we also look out for people who have signs and symptoms of leprosy and link them to the health facility. Like the Honorable Minister had said, most of our patients come from West Nile. Could be because of Democratic Republic of Congo and South Sudan, but also could be that the people in West Nile are looking more than the other people. The country doesn't know that we still have leprosy. You find people asking, do we still have leprosy in Uganda? So if people are asking that, it means there's no search for the disease. So let's all get onto the search arm and look for leprosy and put it on treatment. We have also, we are testing out in Arua a preventive therapy for leprosy, giving single-dose rifampicin. Once we know how to implement this to scale, we are going to scale it up to all contacts of leprosy in the country so that we stop the tap from flowing. So we want to prevent, treat, and cure these two diseases. This is the bad news I was talking about, people coming without hands because they have suffered leprosy. They live with their leprosy, move from community to community. They first go to the herbalists looking for a cure. Then they come to our health facilities, also health workers don't know what to do. And we get them when they have grade 2 disabilities. They add to the national burden of disability. As you have heard the economic losses that we make, also I know leprosy does the same to our country. Let's look for leprosy early and treat it. Briefly, allow me to share with you a snapshot as far as the UNHLM or United High-Level Meeting targets for tuberculosis progress that we have made as a country. And this is our theme. We would like to ensure that by 2022, we have better results. It is in red. The first graph is in red. We are not yet there. And the reason we are saying we go door to door. If we do this in March next year and in September, we should be able to report a different picture by the end of the year to the United Nations. So join us with the door-to-door campaign so that we can identify more people with TB and put them on treatment to reach our United High-Level Meeting targets for identifying people with TB. The people with the HIV started on TPT. These ones here in I don't know whether my pointer points to the, wow. Okay. The green circles, those two, we met the targets. And thanks to, we launched a campaign, I think in 2019, for TB preventive therapy, 100 days. And by the end of the campaign, we were able to meet these targets as a country. So we hope that with this campaign for door-to-door, we should also be able to meet the case-finding targets. But also, the contacts now. The contacts above 5 is this last circle where you see a small red, or that almost nothing has happened. So we hope that in this campaign, we also turn around that and bring more people who have been in contact with TB patients on TB preventive therapy. The funding gap has been highlighted according to the global targets. You can see what we have been able to put in as a country, both by our partners and our government, to address the problem of tuberculosis. We still have a big funding gap. And the reason we are here to raise awareness about this problem, the CAST campaign alone has a funding gap of $8 million US, but we hope with your support, we should be able to raise this and be able to go home to home to find TB and leprosy and put people on prevention. The movement has reduced of the slides. For the benefit of the technical people, just to say we have enough TB medicines in the country for first-line TB treatment, which is the most common TB, at least up to March 2022, and we are expecting more drugs through the government of Uganda support. We thank God that they are prioritizing TB treatment. Almost all the treatment or the medicine we are using this year and part of next year is support from the government of Uganda. And we want to thank God for that. For TB preventive therapy, we have gaps in terms of the availability of commodities. And like you can see, we need to have shorter regimen. The current regimen takes 6 months. We have an opportunity of a 3 months regimen, but the funding is not yet there. So we want to reach more people with prevention, but we require funding for us to achieve that target. But the number of doses available are reflected in the last column for the different regimens that we have and are using for TB prevention. We have at least the isoniazid preventive therapy in the country, and we can start on the campaign. Drug-resistant TB commodities have a challenge, but we are fast-tracking the procurement to make sure that we get the 2022 doses in earlier than scheduled, so that we can curb this impending stock out for key commodities for second-line TB treatment. Like they have said, COVID-19 put a lot of challenges on the program. We were not able to do certain things as planned. And some of the people that had TB were not able to access the services. And there was a lot of stigma that came with the COVID. And the TB people could not come up and say they are coughing. They feared to be taken as COVID patients. So were the health workers. They feared to also contract COVID by screening and testing for tuberculosis. So there was a lot of stigma related to TB from COVID-19. We continue to see less use of data across the levels of service at district and facility level, yet this is what would inform the tweaking of interventions to make sure that we reach all people If we have said everyone should be screened, if you don't check on your data routine, you'll not know whether everyone who is visiting the facility is accessing screening or not. You have to use data to inform the next steps. We also have screening that is suboptimal, and the reason why we are ramming up, screen and screen and screen at the health facility, everyone, until all people have had a screening and you have reduced the positivity among those screened. Allow me to appreciate, once again, add on the Honorable Minister's voice, the districts that have been able to meet the over 90% in terms of TB diagnosis, that is detection, and TB treatment success. Those have been our traditional indicators we've used to gauge your performance in addressing TB. But like you have seen in the presentation, we are now prioritizing prevention. So these two indicators will no longer be the yardstick we will use to gauge your performance. You have to add on the prevention component. We cannot only wait to see people falling sick at the facility without stopping them from falling sick. And you must be part of that effort to ensure that people receive prevention. But we are still recognizing you because this is transition from the old thinking of two indicators of those who are falling ill and keeping those who are ill on treatment. But we want to stop people from falling ill. So you must prevent TB. So thank you if you are listed among those districts. And I want to call upon the colleagues here also listed among the red and red-yellow to pull up our socks. If your district is listed here, you need to go back and change things around. It means you are missing. There are people who are in 44, I see there. You are missing over 60% of the people who fall ill with TB in your district. You are fueling the country's burden of TB. You don't want us to end TB by 2030. Go back and do something. And this red in treatment success. We have said it is possible. TB is a curable disease. It is possible that you can change that red to green. Means something wrong is happening. Please go and rectify that. Now, this is the league table, which is related to the current strategic direction, related to prevention of TB. So we have looked at contact tracing, how much we've been able to do on top of the two primary indicators of detection and treatment success. We have looked at TB preventive therapy for people living with HIV. We are looking at access to the Gene Expert service for your patients. Are you treating TB accordingly? Because if patients are not getting a Gene Expert test, it means you are just treating TB in the dark. And maybe that's why you have a poor treatment success if you are in both. Because people have resistant TB and you are giving them treatment for susceptible TB. So go back also and do the needful. So those of you who have done green in all the areas, is there any? We are still, I think, trying to adapt as a country to this new thinking. And we can get there, go and change every of those indicators if you are there to green, because that is the way we are monitoring our performance. And this, you can see, struggling. New direction. First year, we are reviewing performance of the NSP in this, with these indicators, and you can see how we are doing. But it is possible, and we continue to sensitize us to look at prevention, look at diagnosis, and go to treatment success. I want to stop here. I see the Honorable Minister is beginning to lift her bags and say thank you, Honorable Minister, for taking off time to be with us all these hours. We appreciate. Thank you, all of you, for listening to me.
Thank you, Dr. Stavia, for that summary. And you've had it all. Thank you, Honorable Minister, sharing time. Amidst your busy schedule, us in this conference. Thank you all members for your patience as we went through the presentations. Now, we are breaking off for lunch, and let us be very fast. We give ourselves 30 minutes, meaning that by 3 p.m. we should be back here to continue the rest of the program. Thank you again for your patience. Let's break for lunch and hurry up to be here within 30 minutes. Thank you. I hope members, you've been given coupons, dugum.
Hello, good afternoon once again. As we want to usher you for lunch, first let's give a round of applause to the chairperson.
People. In 2019, the Ministry of Health declared it as one of the most TB-burdened regions in the country, with 5 out of 10 patients completing treatment, 3 cured, and 2 succumbing to the disease. The following year, the area notified 1,075 new TB cases, affirming the alarm that the fight against this killer disease is far from over.
TB is one of the most important diseases in the sense that it causes a lot of death and illness in the Ugandan population. And every year, we expect to have about 82,000 new TB cases in the country.
And it is pertinent that we remind the people of Uganda that TB is still a big burden in Uganda. And Uganda is one of the 30 countries that is still grappling with this high burden of TB.
The highest crude prevalence of tuberculosis was reported in the Karamoja region at 2,394 out of a 100,000 population, almost 10 times the national average.
Ever since TB has been in Karamoja, we have had also MDR cases. Cumulatively, about 150 cases have been notified since the beginning of the programmatic management of drug-resistant TB in 2015.
The region's treatment success rate sat at a low 48% in Uganda, and this was linked to the migratory nature of the pastoral communities, low income, and lack of education. This necessitated the intervention of several health organizations like KUAM to support TB patients' complete treatment and see this rate improve.
Since 2018, Doctors with Africa KUAN is implementing a TB program with funding support from the Italian agency Assistance Internationale, covering the 5 southern districts of Karamoja region. The project aims at supporting the districts, their facilities and the communities in improving the quality of the TB service delivery, both for drug-susceptible and drug-resistant tuberculosis.
Maria, Abunta Young, a lot of the sub-county to pay Paris, Locuma. A guy I am a rebo. I can't think why I rebo. Togaking I agree, Hakan, I create near Dadang, Taka, I come in Dadang. So I will keep you running. A guy on you, Pakalakatare, Loinis, Layati. Abay a lot of them. Kayarukum, Paka. Loin is in it. All a Kayarukum, Mara Yarukum and Paka Kampala. A Yakazing, no moon yet Arukumalu, a loinis. Abuna is. And he kept Bonga the Kamaga, a result Kamaga in Yaboka. Upon it, not when I be TB.
After Maria's 2 months treatment, she was discharged out of hospital and directed to take her medicine from home. But after 3 days, the doctors drove to her house and picked her up.
Maria, you like in your Akonirukum. You like in Akonirukum, Mangerenyo, Nikito Lugu. Angerang told you lick a lugu. I toner a Parakonirukumai, Kidiama.
Maria's TB level had escalated to a multi-drug-resistant stage that, if not attended to with haste, could be fatal.
Amazing and Danny near Kakin. Naganyang Kado Katabakayong, Lore. Apani I know Lore. A mamma Kilele, Labo Labuni, I am Yonayokoi, a lot of time. Yebune Kilapaka Taran, I think I okay, Kilomotama, Beare, the Limucaneria Moneta Beronaga.
Left to fend for her and the kids, Maria received some transport refund from KUAM and more assistance from other partner organizations that would continue assisting her under treatment.
Kwana ko jalang na ya azim. Patenga azim naga. Ko tara to pipe nyoni akowan. Ani la tala ramune reke fi azim. Kori itingi yade ko zinamba. Ni radio ni iriacha kina na kowan. Taramuni. Taramuni azimu ai magane ni kes. Ba boy je gangat. Eli kayong ke to lukang zendani na amazicha ni arenga oporo epe David. Apare pe David tama ai Akaupuri ka ayong. Pana imazi ya ketoy. Kamazi ngizindani. Imazi ya ketoy. Kamazi ngizindani. Akaupayang.
Once again, Maria abandoned treatment for a week.
Taramune tenge da ketay kugazi. Gebana zanaga tarama azim ngeda ketay lu tarama za maga. Boko irka mam yebuna Maria ngata kya za bit ngebuna. Mam yebuna jek. Ito koy. Ena ngaki ni akarama gine tena bagugi. Maria nyubo. Nyo mam ngunti yo nga tama. Akaupuri ka ayong jek akamata ketay. Biyan ezi chok na be peza tama. Biyan araba gwa angololo talelew. Ayo na ngin ta daw na yo ni etoruni. Ezi chok ngana. To daw le te kugi kama. Ama to ka pa lore nege ko munete renga ka kala ye la pa ngon. Apa agi. Ako munete. Mari atanyo ay apegi te ay ima. Nya kero na bo kala ka pa burundira ngara bunere. E bo ka mam. Nya go teriyo ngato nyuga pa na lo to. Be chale ti ataga kin te kwangin. Kamare te to nyure yong ha nyawni. To nyawni ka ko ngida ngare lugu. Nya ada kit ka ngini che atamari apana. Gua gini boro laki ka puru ko daji ko ngina peje ka ba. Lolo robo kana ba ngakrona. Boy gini malo tana ya maka ka panisi nganga bitongi ne ngare. Boy gini mau je. Buya ko kai buya ta ka ta ta. Gua ya ke jikira kan mo bijik. Wa. Karau na iti caya na ya bunara na i. Maka magai boy kini ngala bitongi ngare lu gani abonguni na ya tamaru apana na ilore. Ya tolo tolore. Bu na iti cala fe. Ana ngite na ka ke to ka ke mo. Ka zelenga lu boro lu dadang he mare to lu gua ka uto. Obuni aya la felakal. Na buni na tamakina na ite tama kamu ina bo kaya ketoy. Ka pedo na ba lo sa ki boy maga. Aki boy kama ozi kinta yon ka de bo kana ka de lu chiklugu. Na e kwana e kile dalo ye na mani. E mamu na boy che. Mamu na boy che to ngani e pedo ya daran ka de. E lili ngara lili. Ana yang ngiri kina ya ketoy logo. Ekita logo. Tara wina ya wina ekita. Paka la da kita logo. Turu de lo dena ka abeziti na kera na se na kera naga. Elozi akwa me ekita ya nini. Aka eno ya. Ya wina ni keng. Na ya lozi na ye eliko na ni keng. Eliki na ya na ekita ya nini keng. Ni ka abeziti aka na se tengena na se na kere. Eliki jika ekita ya nini jik. Aja kwa na se. Sini rongo ina buat jika kara yang rupiah majik.
We are glad to say that the strategies introduced have been able to improve generally the quality of care offered to the TB clients, including a strong follow-up of the patients in their communities. And the main results of these strategies is an improved retention in care that is then later translated in better treatment outcomes. In fact, in the last 2 years, we have seen the loss to follow-up rate reducing from 42% to 8%, and the treatment success rate instead increased from 36 to 85%.
And because of the QAM intervention, we managed to put the first gene expert, the machine that detects that organism which is resistant, okay, to the key medications. We got the first gene expert and put it in Matany Hospital. And from there on, we continued to build on following up the patients who were picked up wherever they came from, using a model of care, which we have now coined as ambulatory care model, okay? So we were following these patients and treating them close to home, okay, through their nearby health facilities, Health Center 2, Health Center 3. Of course, we had to do the needful to train the staff and give them the capacity, those health center staff, to give them the capacity to be able to put these people into proper treatment and to follow them if they got lost.
Another TB survivor who has benefited from this good job is Okalapo.
I came to understand the virus when I was working in Masindi. I worked there for almost 9 years. So the 10th year, that thing now started coming to me. I didn't know that it is maybe TB or which illness, whereby I tried to go to the early centers to take the sputum to check whether what illness is this, but actually I failed. Then reaching the 31st, that is 2019, I had to say myself, since I've failed to identify what's happening, it's better let me go home. I find elsewhere what is happening. The 31st, I reported to Matany Hospital, whereby I was sent for X-ray, saying that wait for results. When the result came late evening, they said that admitted to TB ward. When I was admitted for 2 weeks, I received treatment. After receiving treatment, then they said you can now go home and start getting treatment from your nearest early center.
Paul started taking medicine from home, but his journey to healing was averted by the global coronavirus pandemic that exposed him to social segregation and stigma.
When COVID-19 came in, things become disorganized. Now people came to think that, since the virus has come which is finishing people, this might be the virus which these people they are having. Even where I was staying, they had to talk to the landlord and say that in this area, oh, you want all people to die. They had to go to write letters to police to go and report to the OC. The OC came to me and said, please go and get your clear clarification from your doctor.
Paul was pushed to defend his health status as fear of him spreading the coronavirus in the community was escalating. He turned to Kuam for assistance.
I went in the morning up to Matany Hospital. I got my staff plus the doctor of Kuam group. I told them what is going on and what is happening, and they wrote for me a letter. After writing a letter, I brought back to police. They brought a report back to the people. And the people were not understanding it. They couldn't pick it. Even though you go to the market, they say, please give me, maybe I want tomatoes for 1,000. They had to say, these things are not for sale. They are not selling it. Because they know that this person is what? They suspected has a coronavirus. Even though you go to the shop, they said, things are not for sale. I say, no, what is happening? If these people have started eating me like this, even though you come and sit with people like this, people started running. I say, now, things are worsening. Unless I was renting a certain house in the center, whereby they told the landlord, we are giving you days to remove this man from the house. Let him go back where the parent is.
Even with a medical clearing later, the community still dejected Paul and drove him towards suicidal thoughts.
Now, when I think myself, I say, if the community has rejected me like this, now, there's nothing again which you can do in this world. It is better you go and what? And just enter the river. Then when I called the Kuam group, they told me, be patient. They are going to come and we talk to the community and we tell to the community what is happening. The Kuam group doctors plus the staff, doctors, they came all together and they talked to the community and they tell them, this guy is not a coronavirus patient. He was detected as a TB patient, whereby we kept him for 1 month in the hospital, releasing him out, knowing that that germ which was spreading to others as what? Has died. If he goes home, he will no longer spread to what? To others.
Through such challenges, QUOM and supporting organizations continue in the fight against TB by continuing to avail assistance to the people of Karamoja.
Yeah, we call upon the government through the different partners to put in place accelerated interventions in the communities, help identify, detect, and bring back patients or clients who have TB.
And I want to end by thanking the Ministry of Health that supported us in all ways possible. The districts that worked amicably with us, the district local governments and the district health teams. And I want to thank also the other collaborating partners in the region. We have other implementing partners that are supporting TB, including IDI, including TASO, including Rights E, and their complementary effort also contributed to the progress that we are realized. And I want to thank, of course, the management and staff of QUOM that have been working on this, including the support we have been getting from our headquarters in Italy.
The government of Uganda is very concerned about the health of its population, and government has made TB services available in all public health facilities and accredited private health facilities. Treatment is free of charge. Remember, when you are in doubt, you will spend a lot of money in the private health facilities looking for health or seeking for diagnosis. I want to encourage you to report to the public health facilities where treatment for TB is given, and you will be screened and treated correctly. Do not spend money when treatment for TB is free of charge.
Tuberculosis is a killer disease that can be eradicated through encouraging and assisting patients to start and complete their treatment.
due to public demand. Due to public demand, I want you to pick your book where we have the program, and I want you to refer to page 16. Page 16 says, lunch break. Now we have had the lunch break, okay? And after the lunch break, actually we are starting with what we call a panel discussion. This panel discussion, we have a chair. And the chair for that panel discussion is going to be none other than Honorable Dr. Joseph Ruyonga. And I would love Dr. Joseph Ruyonga, Honorable, to come up and take the podium here as I mobilize the other arrangements. As Honorable Dr. Joseph takes his seat, I want to have MC Katz. If he's there, please, somebody call him. If in the next 3 minutes he's not there, he loses his time. If somebody knows where he is, let him come quickly, because the chair for this afternoon session is taking up his position, and the moment he says he's good to go, I'm not going to allow any other person interrupt his session. Please, 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 we are getting ready, we are getting set. Can somebody whisper in my ears if MC Katz is there? If he's not there, I sent him in the parking lot. Oh, I thought that's where you want me to send him. Sorry. Okay, I hope he's coming in the next few minutes. And ladies and gentlemen, you know that the panel discussion that is about to get going will feature the following. Can we listen to each other? I don't want to take this roll call and we are missed out. The panel discussion will feature the following. Honorable Joel Sebikali. Okay? Yes. It will feature Mr. Agri Kibenge. It will feature Canon Dr. Johnson Biabasaija. It will feature Dr. Yai Alfred. It will feature Johari Zabua Kasambira. It will feature Herman Joseph S. Kauma and Dr. Katamba Achilles of Makerere University. Some may be online, but the ones who are physically present with us, I think the chair will see what to do with them. It's not in my rightful position to tell them what to do. So ladies and gentlemen, as the chair settles down, can I invite MC Katz? MC Katz, come over here. MC Katz is going to do for us one small program which we did not do. And it was about remarks from a TB adolescent survivor. Don't ask me whether he's the one. But this is the man who is going to take us through. Few minutes. He had asked for 3 minutes. I gave him 5 minutes. So you are most welcome. The stage is yours.
Good afternoon. All protocol observed. My name is MC Katz. They call me King of the Mic sometimes. I'm a person living with HIV, but I'm a TB conqueror. My story is simple. I start coughing. As usual, you look for the nearest syrup. Syrup 1 fails, you go back, you're like, this one, my coffee is a bit hard. Give me a stronger one. Syrup 2 fails. Then I'm like, okay, I think my body can't do with syrup. Go back, do tablets. Then it kicks in when you start getting these evening fevers. Appetite is gone, you're losing weight, everyone is starting to point at you. What's wrong with him? He's sick. And it hits you like, now, seriously, I need to figure out what's going on. That, first of all, taught me that self-denial is the worst. And I decided to go to a doctor who was recommended by my mother. And you know how you go for those tablets, and TB is associated with HIV, and you don't want anybody to know, and there are lines. So my first day, I went practically to Mulago and walked out. The next day, I told the doctor, can I come a bit early or a little bit late? I can't handle all the audience there. Anyway, I get the tablets. I don't know if it was me or that's how they work, but you know, like you sweat the whole day. You smell like a pharmacy the whole day. So I did them like 2-3 months. And when the cough had gone and the evening fevers are done, I was like, I'm done too. 2 months down the road, it hits me back like this time around, like back, bad. Sick, weak, loss of appetite, can't do anything. And I remember someone telling me, the next thing we're gonna do, TB patients who are not on drugs, they send police to you to like forcefully lock you into the hospital so that you do your drugs, yeah? And somebody offered me, like it was a favor, come see the people who are really doing badly in Mulago with TB. The ones, I think they were on injections and all that. I looked through that word and I was like, no. I have kids, I need to get my drugs on. So what am I saying? What did I learn from my experience? First of all, I think if we going to do anything, we first of all have to first take away this stigmatization of TB and its all art around it. The fear, the running away from the fact, the ignorance of not knowing the signs. We studied these things when we were in school, but when we grow up, we forget all these things. Like you cough, you feel like it's just a normal cough. You get the temperatures, you feel like, I should get like probably a malaria tablet, just like a malaria coming. We first of all clean out that psychological thing. And I was talking to Dr. Isino, I pray I pronounced your name right. And I was telling him if there's a platform for me being an entertainer, TV presenter and all that, if there's a platform for me to talk to the youth countrywide, help you here and there, I'll be very glad to join them. And he said it's in the pipeline. I pray it works out. So for me, my talk will be more like these medicines work. People out there know they do work. You really, really, really can jump out of this TB thing, like totally. They really work. The fear of what will come next, how will people see me, you need to know you're saving your life. You just need to know this is going to help you as a person. Thank you so much.
Thank you very much, MC Katz. Ladies and gentlemen, join me and we put hands together to thank MC Katz for once. Good, that testimony talks volume, and I think yes, that testimony talks volume. I hope there are lessons to draw from there. It's time now for me to hand you over to our next chair. Our next chair is Honorable Dr. Joseph. He is going to lead the next session. This is the mother of all the sessions for today. Let's give it the attention it deserves. Honorable, this is your time. And let's put our hands together and welcome Honorable to take over from me. Thank you very much.
Yes, good afternoon. I have already been introduced. I'm Dr. Joseph Rionga, and I'm the MP representing the people of Hoima West in Hoima Oil City, much as sometimes I introduce myself as DHO Hoima. But it will take some time. I can't say that I miss the district, but It's a promotion. So I'm happy to be here. I'm sorry I've delayed. I had some other assignments. But I would like to welcome all of you for this afternoon session. And I'm supposed to have a co-chair by the names of Paul Isiko. I think that is a dangerous substitute, but I can see it's not very dangerous because he will be here by this time. But I will come for this afternoon session. What you have seen that time is not on our side, so we have to keep time. But I'd like to welcome all of you. The minister has gone, the PS and others, but I will welcome you in your different capacities. So I'd like to invite the presenters. I would like to start with Honorable Joel Sebkali, who is the chair of the TB caucus, and also he's a member of parliament. And he is the vice chairperson of parliament. When we are at the other end, he's my boss, but at this time here, I think he's under me, but I'd like him to come and take his seat. The presenters, let's be very strict with time. Each presentation is 15 minutes, discussion 15 minutes. After all, we go through all of them, then we shall have a discussion. So we have Honorable Joel Sebkali. His topic is prioritizing TB prevention and care and the role of a legislator. Then the second one is Mr. Agre Kivinge, the PS Minister of Gender, Labor and Social Development. And he'll talk about healthcare equity and access for marginalized populations, lessons for TB programming posed by the COVID-19 pandemic. Then we also have a colonel here, Dr. Johnson Diabasaija, who is the Commissioner of Uganda Prison Services. He will talk about TB in prisons, the current state of affairs. Then we shall have Dr. Ayayi Alfred, DHO Yumbe, these are the people who supported me when I was campaigning. The topic is experiences from mobile populations, including refugees. Then we have, I don't know how I can pronounce this name, Zuba, okay, Kisambira, Uganda Society of PMP, private health providers engagement, the TB patient first port of call. We shall have Dr. Herman Joseph, is Leprosy, the ancient scourge still with us in Uganda. Then there will be Dr. Katamba Achilles from Makerere University, the role of the academia in ending TB by 2030 within sight. Then after that, we'll have a discussion. So, your names? Where are the others? So if you had your name and you're supposed to present, please, I'm requesting that you come here so that you can be able to start. So I don't know when this man in uniform is coming. Should I stand up and salute him, or should I have to salute you, or you have to salute him because I'm the chair? I'm just joking. So are we all here? Let's get some more chairs, please. So long as it doesn't somersault. So are we all set? Should we start? So let me take this opportunity to invite Honorable Joel Sebkali to give his presentation, which is prioritizing TB prevention and care, the role of the legislator. So Joel, the floor is yours. 15 minutes strictly.
Thank you, Dr. Ruyonga, for the introduction. My boss, Honorable Chair of this session. I'm Sebkali Joel MP Ntwetwe, Chankwanzi District, and I'm the Chairperson TB Parliamentary Caucus, as well as Deputy Chairperson Health Community Parliament of Uganda. Prioritizing TB prevention and care, the role of the legislator. TB remains the world's biggest infectious killer and the leading cause of death among people living with HIV. TB is a disease of poverty and social disadvantaged, and it affects the most vulnerable people in society. And its impacts on health and general well-being is immense. Additionally, in Uganda, households having a TB patient borrow or use their savings or sell their assets to meet TB-related costs. And that has shown that about 53% of TB-infected households spend above 20. But data shows that they spend 41% of their annual household expenditure on the disease. Uganda and the world still have made insufficient progress to fulfill targets and commitments contained within the United Nations high-level political commitments that were made in 2018, for which I was part of the Ugandan delegation. The country, therefore, needs to prioritize TB prevention and care. Efforts are needed for community mobilization and rational use of national resources to enable planned breakthrough in the TB response. There is need for proper, well-focused legislation that looks at the various issues that may be impending progress towards ending TB. The fight against TB must be everybody's business, from the top leadership of the country to the ordinary person in the village, from the government, ministries, departments, to the smallest community-based organization in the rural areas. Everyone has a big role to play. The Ugandan Parliamentary TB Caucus was a vision of a free TB generation. The caucus was established some 6 years back, and it was established by policymakers committed to the fight against TB in order to walk our talk, bolster action, and leverage resources to end TB. Especially, the caucus is expected to advocate for good TB policies, advocate for resources from public funds, individuals, and institutional commitments, development partners, engagements, and community mobilization for TB prevention, care, and control. I will not go into details because the caucus is still being talked about, but I'll go to, I don't want to delay you, I'll go to actions to address current challenges in TB control. There is a need to screen all people entering health facilities. There is a need to screen people who are at high risk in getting TB. There is a need to provide comprehensive program for the prevention, treatment, and control of TB at all health facilities. Therefore, I call religious leaders and cultural leaders and other opinion leaders who should be effectively supported and engaged in TB control and care. Support offering of TB services across national borders, migrant communities, and refugees. Support patients who may be failing to take their medicines. Address at the highest political level the issue of insufficient resources to effectively fight the TB epidemic that leave an unfunded gap of 35%, increase domestic funding of only 5%, should be increased at least to 9% this coming financial year. Before I conclude, I started with the telling you that TB is a disease that is related to poverty and the social disadvantaged communities. Honorable members and dignitaries within this room, if we are ready to do something, if it is a disease for poverty people, the only way to end this is through the introduction of national health insurance. Because this one will enable these languishing households into poverty to save and develop themselves at a household level. But if therefore 41% is spent on treatment as out of pocket, then even if we talk from morning to evening, we shall not achieve what we want. I've spoken when the minister has gone away with some other important people. But there is no way, I never dream it, that Uganda can go to a middle income stage when there is no introduction of national health insurance. Even if you talk, even if you sleep here, even if you do something, without that, there is no way you can go there. Because all the monies of the households is spent on treatment as out of pocket, 41%. Then how do you lead these people to go to middle income stage? It is my appeal that all members of parliament, civil society organization, Minister of Health, and all partners, we talk the same in advocating for the introduction of national health insurance. In East Africa, we are now zoned to Dr. Congo and Sudan. The rest of the countries, Tanzania has gone to middle income stage. Kenya is looking there. Rwanda is looking there. But for us, we are somewhere. So we need a robust attitude to make sure that we reach where we want to be. And this entails a political commitment from the top to the bottom. As I conclude, therefore, the foregoing situation needs the right kind of legislation in the national parliament, and the legislators need to do what it takes to ensure that we end TB. I therefore appeal to all legislators here and elsewhere in this country to think about these issues. I also appeal to the stakeholders here to engage the legislature for it as it is its role to address all these issues, including what the technical officers have brought to our notes for God and my country.
Thank you very much, Honorable Joel. I think he dealt much about the national health insurance. We as legislators, it's what we are discussing, and we have a feeling that we'll go through, because minus national health insurance, then we shall keep on lamenting about lack of resources. The resources have to be at all levels. He is a member of parliament, but also, we also have other people at district level, at a municipal level, at a city level, and the council level. So all of them should be to take TB as a priority, that they can be able to allocate enough resources. When you go to the districts, they think that the health sector gets a lot of money, and they really put their resources. But we are requesting that at all levels, we should allocate resources to the health sector, especially when it comes to the fight against tuberculosis. Thank you very much, Honorable Joel. Now we can have the second presenter, who is Mr. Agre Chivinge, the PS Minister of Gender, Labor, and Social Development. He's going to talk about healthcare equity and access for marginalized populations, lessons for TB programming posed by the COVID-19 pandemic. So, Agre.
It's okay.
Time is 15 minutes. Thank you.
Thank you very much, Chairman. Honorable ministers present, members of parliament, senior government officials, invited guests, ladies and gentlemen, good afternoon. Before lunch, we've heard a lot about the hard science about these two things, TB and leprosy. You must have heard about the gene expert, digital technology, comorbidities, etc. But now we have to switch gears and hear from the short doctors. My name is Odong Francis Gimoro. I've been requested by the Permanent Secretary, Mr. Eddie Kibenge, he's called Kibenge, to represent him in this forum because of unavoidable circumstances. My position is Assistant Commissioner, Occupational Health in the Ministry of Gender, Labor and Social Development, but I'm also currently caretaking as head of department for the Department of Occupational Safety and Health in the ministry. I hope somebody is helping us to project. Am I right? Okay. So starting off, good health is not just something that should be given to us because of pleasure. It's a constitutional right that healthcare is equitably distributed and is paramount to ensure that everyone has a fair and just opportunity to be healthy as possible, irrespective of social or economic status and other considerations. This morning, this has been alluded to, that a healthy population is an imperative for increased productivity, societal happiness, and socio-economic stability. For your information, Uganda is the happiest country in East Africa, as rated globally. In the continent, we are number 20, and globally, we are number 119. So you can clap for yourself for being the happiest one in the ESA region, but we still have a long way to go globally. Just a little bit about what the Ministry of Gender, Labor and Social Development is mandated to do. One is actually to protect and promote the rights of vulnerable population, including women, children, unemployed youth, the elderly, and persons with disability, whom we shall see are actually many times victims of these two diseases. But also we have to address gender inequalities, inequalities between men and women, as it is a social construct in the term of gender. Uganda is a culturally rich country, and this ministry is mandated to promote that, as well as promote issues of labor, productivity, and employment. And lastly, to promote social protection, equity, and social cohesion. Coming to the subject, in terms of the analysis of the situation, and this has been alluded to by previous speakers, Uganda is a designated country of TB and HIV/AIDS. And we are aware correlationship between TB and HIV and AIDS, which has been extensively or talked to this morning. And so we see that the situation becomes worse because COVID-19 now affects the respiratory. Oh, something's where TB also resides. It makes to be 200 per 1,000 population with a mortality rate of 35 per thousand. Uganda is among the 22 TB high burden countries. And the Center for Disease Control mentioned that Uganda's TB treatment success rate was 74, which is commendable, 74%. In terms of the social impact of TB, we take note that it is the largest single infectious cause of death among young people and adults in the world, and accounts for nearly 2 million deaths per year, mostly in developing countries. And the majority of this are the economically active segment of the population. This sickness of TB reduces the productivity and increases absenteeism of workers, which affects economic development. There are also psychological and social costs, as patients may be rejected by family and friends or lose their jobs. Healthcare workers, in particular, face high risk of latent TB infections that may manifest long after employment. In terms of gender, we know that reproductive health, maternity mortality, and others have got higher attention relatively compared to TB. And despite TB being the single leading cause of death among women of reproductive age. And we know that women suffer from TB are less likely to be diagnosed or detected than the men. And of course, infirmity or death of a woman in a family due to tuberculosis causes economic loss to the household, and that can lead to ripple effects even to the children, including malnutrition and early childhood mental health. I mentioned that we have vulnerable groups, including people with disabilities, and when you put TB and poverty, lack of access to information, this situation is exacerbated. The elderly people have an increased susceptibility to infectious diseases, particularly of the respiratory tract, and TB is no exception. Elderly individuals with TB need more support because they are more likely to experience the negative life events, reduced mobility, loss of social status, and so on. Chair, a little bit about leprosy and social development. Leprosy, as has been alluded to, affects the poor and resource-limited countries, including our own. And if untreated, it leads to progressive physical, psychological, and social disabilities. Many of these victims have difficulties accessing health care due to high costs and distance. And of course, there's stigma that's associated with the disease, which sometimes delays seeking proper care until they develop physical deformities. The quality of life of such persons rapidly decline. And for those who are older, we know that we had resettlement centers for such victims of leprosy in the past. Unfortunately, they are not functional anymore, and I'm glad that we have members of parliament here who should help us in advocating for the revival of these centers to cater for such victims. Uganda achieved the target of eliminating leprosy as a public health problem, but of recent, there seems to be a resurgence, as evidenced from the previous speakers and also the 38 cases reported in LIDA in 2019. In terms of interventions, as a central government ministry, we are charged with developing policies and programs to address such vulnerabilities. And therefore, we have the following policies as highlighted: National Social Security Protection Policy, Policy on Disability, National Health Policy, and others. In the NDP 3, the National Development Plan 3, there is what we call the programmatic approach to ensure that there is fertile ground for government projects. And the ministry is taking lead in this particular program. And we note that all programs geared to prevention, treatment, and rehabilitation of TB and leprosy cases and others implemented by government and CSOs have higher chances of success if the masses are mobilized. The previous colleague talked about issues of mobilizing the population. And we also heard about contact tracing, a responsibility not only of the health workers in the medical doctors, but also the social development workers who actually spread across the country. We have the human resource and the technical capacity to do this, and this we think will catalyze implementation of socio-economic interventions through the parish development model and others, including health surveillance, treatment, and acceptance by communities. We appeal for support from all stakeholders. I've talked about the settlement centers, which need to be revived so that we can restore them to functional capacities. We also have the social assistance grant for empowerment and other social funding projects to support the vulnerable, like the older persons who get 25,000 shillings per month. Little as it may be, the impact has been seen to be enormous. And some of these go to PWDs, which include leprosy victims. We've heard about the Youth Livelihood Program and the Uganda Women Entrepreneurship Program, which is also a catalyst for social development. And when the household incomes increase, then these two diseases, which are actually diseases for the poor, will also get less and less. Finally, Chair, key lessons to learn is that communities need to be mobilized to know their rights and demand for them. 2, that communities need to be mobilized for effective identification and implementation of programs to prevent, detect, treat, and rehabilitate cases of TB and leprosy. Community services and lower health facilities are a critical component of the healthcare system in situations where higher level health facilities are overwhelmed or when people cannot afford the healthcare costs at the facilities. Also, we note that high cost of healthcare is a major barrier to accessing services by the vulnerable groups of people during the pandemic. And there's need for collaboration between TB and Leprosy Control Division under the Ministry of Health and the Department of Community Development and Literacy in the rehabilitation of those who have been affected by TB and leprosy. The scourge of COVID-19 is not likely to end any soon, and access to health and leprosy during the pandemic needs to be emphasized more than before. This therefore calls upon all of us to consolidate the defense built and work together for the good of every Ugandan. In the absence of effective data management system on vulnerable persons, targeting vulnerable persons for support in times of healthcare and other socioeconomic aspects is extremely difficult. This was evident when we had to give out the relief money for the vulnerable people because we didn't have the data. In conclusion, let's remember that healthcare is not only an essential service, but a human right. A healthy population is an imperative for increased productivity, societal happiness, and sustainable socio-economic development. I thank you for listening.
Thank you very much for your presentation. I think you have taken note of what he has presented. We shall have it when we are discussing. But the key was about increasing household income, and he talked of already being given 25,000 shillings per month, and also collaboration between TB, HIV, leprosy. Then now we have COVID-19. We are going to have our next presenter, but this one is a bit modern. It's going to be a video, which is TB in prisons, the current state of affairs. So he's organizing the video. It's going to be a video show. Kano can give us some highlights. Just get it in here.
I am here to present a small paper about TB in prison, the current state of affairs.
Where are the pictures?
The outline will be the introduction, the prison's health system, the burden of TB in prisons. Globally, people in places of detention suffer high prevalence of infectious diseases as a result of conditions and unfavorable living conditions. If you want to know unfavorable living conditions, you come to prison. You will know. The global population of people in detention is estimated to be around 10.3 million And Africa, I think, has about a tenth of this population, that is around 1 million prisoners. In Uganda, the prison population is estimated to be around 65,000 inmates, with an annual turnover of 189,000. This might be a bit confusing, but you should know that the number, at any one time, if you count the number of prisoners within our detention, you will get an average of around 65,000 monthly. But the ones who come in and go out because of our court system, others get bail, others released, case withdrawn, the whole turnover is 189,000. However, the available prison infrastructure, that is the holding capacity we have at the moment, is 19,983. In other words, we have 65,000 prisoners in custody, but the space available is only 19,986. And that means you have an occupancy rate of 330%. That is about 4 people occupying a space of one. Of course, this is not unique to Uganda only, but a global prison statistic. This should show you the extent to which financing of prison institutions is undermining on the global and national agenda. Even if I was the one in charge of finance, I don't think I would look much availing resources to the prisons other than availing them to the population that are not suspect in any way of having infringed laws of the country. Now, the prison health system. The prison infrastructure in Uganda was designed in the pre-colonial era and therefore does not adequately respond to the current decentralized approach of governance. Previously, health services in the prison was delivered by the Ministry of Health, which was decentralized prisons during the health reforms of 1996. After it was not only health reforms, I remember it was also the prison reforms around that time, and that's when they began to take effect in this country. While the policy and technical guidance remains the function of the Ministry of Health, the day-to-day planning and operations is the mandate of the Uganda Prison Service. At Uganda Prison Service, there are 259 prison facilities organized in 16 administrative regions. These facilities are in 3 categories of high security, mid security, and low security prisons. This categorization has a bearing on the available infrastructure, the holding capacity, and service provision. In the same regard, therefore, the health system is established in response to these considerations as number 1, the National Referral Hospital at Maxon Bay Prison. That is 1 referral hospital. Then we have 55 health center series and 103 health center tools. And of course, the village health teams that we can count to about 100. Whereas the referral hospital and the health center series and the TB, they fall short of national standards in terms of infrastructure and equipment. Of these, only 30 are formally accredited for ART. That is what is that? Antiretroviral treatment, while 26 are pending accreditation. The 103 health center tools are largely community drug distribution points, supported by the 55 health center series as outreach points for technical and health. The 100 village health teams level facilities entirely depend on the community-based public health facilities, and their main function is surveillance and referral. So what is the burden of TB? On the global perspective, prisoners remain at high or rising risk of contracting TB infection and disease, and are disproportionately impacted in comparison to the general population across all geographic regions. African prisoners are considered to have the highest TB burden globally, in a population that comes from a largely disadvantaged neighborhood with high levels of overcrowding, high HIV prevalence, and increased levels of malnutrition. At Uganda Prison Service, the prevalence of TB is estimated to be 4 times. That is around 650 persons per 100,000, compared to the national average of 154 per 100,000. Of course, the risk factors in the prisons are very obvious. The overcrowding, which I mentioned, at 306%, the rampant malnutrition, the high HIV prevalence of 15%. Actually, this is conservative. 15%, I think, is an average for males. If you got female inmates, it must be higher, as compared to the national average of 6.1%. Of course, we have inappropriate infrastructure with poor ventilation. You know, a prison is supposed to be something where nobody can escape from, and therefore ventilation is luxury. And of course, we have delayed TB diagnosis in the prison. These are really. So what programs have we designed to make sure that we intervene in this situation? We have the following: case identification through entry screening of TB and HIV during admission of new prisoners, TB surveillance through the use of peers as off monitors on the wards, increased diagnostic capacity for TB through establishment of laboratories, use regional laboratory hubs. I think this is use of regional laboratory hubs and access to imaging services, and increased access to TB treatment through accreditation of the 26 facilities to which I told you that are not accredited from the 30 that are accredited, and the clinic outreaches to the 103 health center tools. Also, we have to strengthen referral and linkage to public health facilities following release from prison. It would be terrible for a person to leave prison when he has been on a program of TB treatment, of TB therapy, and then he goes out and he cannot continue to access that vital intervention. Early diagnosis, treatment, and isolation of TB clients is one of the programs, and provision of TB prevention therapy for HIV positive prisoners. And that is for the programs, for interventions. And what are the achievements that we have recorded in the prisons? 2019 marks the turning point in TB management in the Uganda prison service. That's when we started receiving funding from Global Fund and the Centers for Disease Control for TB intervention. This led to increasing trend of TB diagnostic capacity and increasing initiation of treatment, reduced loss.
We are giving him only 3 minutes.
Follow-up and improved TB treatment completion rate due to introduction of a referral and linkage system for clients following their release. And the number of deaths due to TB reduced from 18% in 2016 to the current 4%. And here we have a histogram showing TB diagnosis and initiation and treatment, which shows you that there has been from, let's say, for example, from 2016 up to 2018, we had an increased TB HIV infection detected, and because of the interventions from 2018 up to, I think, the current, there is a growing trend showing that the patients that started on treatment of TB is increasing steadily, and also the reportability of TB cases has also increased. And the following graphs show the TB treatment outcomes, and you can see how those cured are showing an upward, very clear upward trend from 2019 when significant interventions from the Global Fund and the CDC, and also the gradual reduction in the death of TB patients, and also the increasing the follow-on treatment. The TB treatment outcome trends are still indicated in these curves, showing an improving cure rate and success rate from 2019 up to date. So what is the way forward? Out of the 55 health facilities we have, the health centers list, I said we have only 30 that are accredited. Let's have now the 26 the 26 facilities to be accredited for TB and HIV treatment. We should improve access to diagnostic capacity, especially imaging services. We should conduct a prison's TB prevalence survey. We should provide TB isolation infrastructure to control transmission. This is a very serious issue because we virtually don't have room for keeping prisoners. So when you say we should have isolation capacity, oh, I don't know what you are talking about. Increased ventilation in the prison wards. Yeah, of course, these days, all the cells we build, all the wards we build have got adequate ventilation. But we can increase ventilation of those prisons that date back to the colonial era. Then we must strengthen the surveillance for tuberculosis. And of course, we must establish a more robust referral and linkage mechanism for clients after release. Thank you very much for listening to me. I hope you have.
Now we are remaining with about 4 presentations, but I'm requesting, let's be brief. We don't want another video presentation because you don't see the person, you can't stop him. And it is not like Zoom. So that's why we had to wait for him to complete. So for the remaining presenters, my humble request, because night is 4, we want within 30 minutes to have, 40 minutes to have finished these presentations. So you have heard from the Dr. Yai Alfred, DHO Yumbe, just a brief summary on experiences from mobile populations, including refugees. Just a brief summary. Within 10 minutes or so, you can be able to do it. Thank you.
Thank you, Chair. I'm Dr. Tama Malon. I think inspired by the COVID campaign, he had delegated me to give the presentation on his behalf. I'm going to give a brief presentation on experiences from mobile population, including refugees. That is the case in the Yumbe district. My presentation, the outline, will be a brief background, Yumbe district TB and leprosy performance, key issues or experiences with mobile populations, response measures and recommendations. I think Uganda totally has about over 1.5 million refugees, and out of this, about 240,000 are in a Bidi refugee settlement, and that is in Yumbe. When we look at mobile populations, these ones have a key characteristic of moving from place to place. And of course, this affects the care that we give to them. And these mobile populations include the refugees. I already said that Yumbe has over 240 refugees. That is as per September 30th this year. There are self-settlers. There are some refugees, they are asylum seekers, I must say. They have self-settled within the district. This is also another key group of people that we have in Yumbe, and these are over 2,000 settled in Yumbe. Then we have businessmen and women. These ones move across borders between Sudan, Congo, and what have you. So this also affects the care that we give to them. Then we also have some pastoralists. Actually, Yumbe, we have pastoralists from all over the country, including the ones from West Nile and other regions of the country. So they are there, who are always moving in search for pasture. So when we look at the Yumbe district TB and leprosy performance for last financial year, our case detection rate was 121%, though the target was 95. we passed that. The case notification rate was 199 over 100,000 compared to a target of 160. The treatment success rate was 96% compared to 95. Then we had the MPDSR TB cases. Since April 2015, we registered about 18. 9 of these were refugees and 9 were nationals. Then leprosy cases, we had the 36, I mean. So what are the key issues or experiences we have with these mobile populations? So one, we have issues of high loss to follow-ups arising from these people. They have unplanned movements. The lack of clear addresses. Many of them, they don't have defined addresses that you can use to follow them. They use different names. This is very common among the refugees. They use different names from one settlement to the other. There's the use of different telephone contacts. When you ask for their contacts, they give different telephone contacts, just for purposes that they shouldn't be followed easily. 2, we have weak cross-border collaborations. You remember, you know Yumbe and other districts, we share borders with the other countries like Sudan and Congo. So there have been cross-border collaboration meetings, but still we have these ones weak. We really needed to strengthen them. Number 3, the treatment interruptions, which has been really common as a result of COVID pandemic now. So this one also hit us hard on issue of disease on top of the mobile populations. So there are some key issues experiences. Number 4, we have many districts have porous borders, actually internally and also with the neighboring countries. Our borders makes screening very hard. We have very few gazetted borders, but many people move through ungazetted borders. So that makes it very hard for us to do screening at the borders. So some of these infectious diseases, it becomes very hard to control them through screening at the borders. So what responses or measures have we taken? One, there have been quarterly cross-border meetings with South Sudan. That is the neighboring districts of Adjumani and Nimule. So we had one in Adjumani, that was August 2020. Then there's one in Nimule, that is August 2021. This was with support from IGAD. I think there's need to really strengthen this to see that all of us take concern in how we can address issues of these mobile populations. There's the intra-cross-border meetings for data exchange, experience sharing, and collaboration. So I think this has also been going on. Then there's a need to design a tool for cross-border monitoring of clients. So I think there's a really need to harmonize between the ministries in all the countries so that we have a harmonized monitoring tool for all the clients. Then we have community sensitization on the availability of TB and the leprosy services within the district. We do door-to-door screening using VHTs with the support from BRAC. I think BRAC has been supporting us to do screening, communities TB screening. And I think this really improved our TB detection rate. We have collaboration with humanitarian organizations such as UNHCR, IRC, Humanitarian Aid, and many others, including IDI. So this one is aimed at strengthening the TB and leprosy services within the settlement and even within the host. So this has been working well. So some recommendations we put, one, we need to have continuous sensitization. Still the population, their knowledge about TB and leprosy is still is not up to date. So we need to continue with utilization on the availability of services and the utilization. So this one can go to the local governments, the ministry, and even the partners. There's need to strengthen cross-border collaboration. I think WHO, IGAD, there's need to really support and strengthen this. Strengthen integration and multi-sectoral collaboration. I think OPM, local governments, they need to take part in this. Then there's need to develop a clear tool and the terms of reference for monitoring mobile clients on TB and leprosy treatment. This one is really cross-border. I think, Chair, that is the presentation I can give. Thank you.
Thank you very much, Yumbe. All your indicators are above the target, despite having those other challenges. Maybe someone will raise those questions if there's time. Then the next presentation is by Kisambira, Uganda Society for PMP, private health provider engagement, the TB patient first port of call. I think I'm giving you, let's agree, 10 minutes. Maximum.
Thank you. Thank you, Mr. Chair. Protocol observed. Good afternoon and good evening to everyone, because we shall not meet again and greet each other, probably. My name is Jauhar Zubair Kisambira, the General Secretary of the Society of Uganda Private Medical Practitioners, and also a member of the Technical Working Committee of the Public-Private Mix at the National TB and Leprosy Program. Today, I wish my presentation is okay, thank you. Our presentation will have an introduction. We shall talk about TB in the private sector, progress towards the UNHLM targets, challenges in TB work in our sector, the effect of COVID-19 to our work in tuberculosis, and then give some recommendations. Briefly, I'll talk about the Society of Uganda Private Medical Practitioners. It's an organization which unites all private health providers in the country with an aim of making sure we have uniform service delivery that adheres to the standards. We have a number of objectives, and amongst the many, I would cite out one, which is most important for today's occasion, is to construct meaningful bridges between government, private practitioners, and other non-state actors, on issues of policy programs, projects, legislation, including research. Today, we are here because we are collaborating with government to make sure we end tuberculosis in Uganda and in the world at large. To take you back a bit, please move to slide 6. To take you back a bit on end TB strategies, the World Health Organization put it that in its pillars and components, when you look at pillar number 2, component B, it talks about engagement of communities, civil society organization, and public and private care providers. And we thank the organizers of this national event for making us involved at all stages in the fight against tuberculosis in Uganda. TB in the private sector, literature has it, and people have mentioned it here, that many of the patients who suffer from tuberculosis first come to the private sector seeking for health care services. And a lot of work is being done, though it's unreported, or not all the work that we do is reported, but we do a lot of work including screening. Next slide, please. Screening, diagnosis, treatment, reporting data, and a little is still done when it comes to research. But this data, actually the data of the work we are doing is still underreported, and that still remains our problem and an area where we need support, Madam Commissioner. We have registered a number of successes when it comes to the UNHLM targets, working together with government. And the first success we celebrate about as the private sector is the commitment of the government and the IPs on engaging us on TB services, as it is stated in the Uganda TB Roadmap Fiscal Year 2021. When it comes to prevention, IPT has been availed in some of our facilities for patients who are at risk of getting tuberculosis, though there's still work, and more work is needed to be done in that area. When it comes to diagnosis, it is one area that we have excelled in the private sector amidst challenges here and there, but through partnerships with government, they have put in place working hybrid systems whereby our samples that we pick from clients are being taken to areas where there are gene experts that have been decentralized for us to access at free cost. Yeah? So our patients can access gene expert services, but not all of them. So we are still making sure people know that these expert machines are accessible and at a free cost, with the cost of transport being footed by government through hub riders. When it comes to treatment, we have registered an upscale of private treatment centers because many of our facilities are getting TB treatment medicines from GMS directly. When it comes to human resource, I've been part of the beneficiaries. Some of our staffs have been trained in the management of TB clients, and it's a score when it comes to capacity building and making sure we accelerate the progress towards the achievement of the UNHLM targets. We have championed in the vaccination programs, the UNEPI programs, when it comes to vaccination, and you know the role of BCG in protecting our children against contraction of tuberculosis. And the private sector is really scoring there. And the government has always engaged us, and it has formulated a technical working committee whereby some of us have been made members of the same committee to make sure there is progress towards the public-private mix in the joint efforts of fighting tuberculosis out of Uganda. And we have been having actually regular engagements on the same and development of guidelines. Data reporting has also been an area of improvement, though we still need a lot to be done there. However, there are a number of factors that are still delaying us from the achievement of the targets from the United Nations high-level meeting. And the first and of its kind is the knowledge gap that we have. We acknowledge the fact that many of us in the private sector rarely get continuous medical education and continuous professional development sessions on different diseases and health programs, unlike in the government. So many of us stay with our knowledge that we got in school, and we still use the same knowledge to work on clients, yet many of these have been phased out. So that knowledge gap on TB care still makes us be providing services to TB patients that don't rhyme with standards. And that is why many of the private health facilities actually have a low index of suspicion of tuberculosis. And we really need to engage them on that. The public-private mix awareness, a few of us actually in urban centers, if I would speak to be more specific, the public-private mix is much more known in urban centers and maybe in the city center than any other areas. So many private practitioners don't know that they can still work with government to make sure TB is chased out of the country. And that is actually an area of weakness that is slowing the progress. Poor attitude on TB services. Indeed, many of the private practitioners, more so the private for profit, establish their businesses with an aim of gaining profit. And they know that TB is a disease for the poor. And they also fear to contract tuberculosis. So they have an attitude that TB patients are poor, and when I work on them, I would contract the disease. And this is delaying actual diagnosis and treatment provision. And at times, these people are either informally referred or not referred at all to TB treatment units. And then TB patients can't afford services. Here is where I would want to re-echo the voice of the chair TB caucus that we really need to introduce the national health insurance. Let's put it in place to support TB patients.
1 minute.
Sorry? Okay. I want to talk about the challenges posed by COVID-19 on us. One, loss of follow-up. Our patients got lost to follow-up. We were not getting actually enough supplies when it came to COVID-19 lockdown. Most importantly, you had many of our facilities cutting down workers because the economy was not doing well. We lost many workers who were trained in working on TB patients. So the high rate of turnover of workers in our sector is contributing to the delays in making sure TB is fought out of this country. But we have some recommendations that we would give to this most important meeting. Chair, if I would be allowed 1 more minute. One, we need to support and encourage research among the private providers. Because most importantly, they need to have this data from their own, if they have done it, so that they can, based on that, to really understand the magnitude of the problem, and then appropriate standard efforts to fight the problem. We need to, please, Madam Commissioner, let us accelerate the approval of guidelines that we developed some time back of incentivizing the marriage between government and private in the fight against tuberculosis. It is taking too long. We need to move from words workshops and guidelines to action in order to achieve the acceleration. And then we need to improve communication back and forth. Let the government inform us of available opportunities that we can work through together to fight the disease. And we pledge to give you information on the TB work that we are doing in the private sector. We need to intensify monitoring and evaluation. Sometimes you introduce programs on our side, but you don't follow up on us to see how actually we are doing. And many of our facilities have closed down and have stopped doing TB work just because the DTLS people have stopped visiting them, trying to understand the TB work they are doing. Resource mobilization is important. Capacity building, you trained us, but you trained a few of us. Actually, we need you to roll out these trainings to other people. Lastly, but not least and most importantly, incentives. We need to incentivize, actually we need to be strategic when we want to deal with the private sector who have established themselves for profit. Incentivize what they are doing in order to fit the objectives of this fight against tuberculosis. Incentives may scare people who are in charge of resource mobilization, thinking that the private sector would want to get money from government. But an incentive can be as little as a signpost to a facility just to indicate that TB treatment is done here, that alone can pull numbers for this person, and they can do TB work. So it is as little as that, but that doesn't limit the fact that we also need incentives like microscopes, support on diagnostics, and rolling out more and actually enrolling more facilities to the GMS supply chain to get TB medicines, the standard ones for these patients. I speak all that for God and my country. Thank you for listening.
Thank you very much, Mr. Ambira, for that good presentation. The incentives are coming once the national health insurance comes in, because it will be for government and also private. So you pray for us.
Amen.
Now, the second last is my Dr. Herman Joseph Kauma. I think I'll give you 5 minutes. Is Leprosy Ancient Scourge still in us in Uganda? Where is he? Please, just 5 minutes. Just give a brief summary.
Hello. Yeah, thank you. Yeah, it's a shame that we have only 5 minutes. This is a TB leprosy program, and this is the first time that we are talking about leprosy, and only 5 minutes. Who is managing my slides? Please go to the slide where there is a picture. Go on. I'll skip all there. Okay, the question I was supposed to address in this presentation is whether leprosy, the scourge, is still with us. And I can answer this question from this picture. This is a photograph, the person consented, of somebody who is diagnosed with leprosy this year in 2021. So the answer to the question is yes. Okay? Leprosy is still with us. We cannot call it scourge anymore because we know it is a disease. We know how to diagnose it, we know how to treat it, and we know how to cure it. So we cannot call it scourge. In the remaining part of my presentation, I only want to say a bit more about the meaning of this picture today, but also to inform this TB meeting, largely TB meeting, that where TB is today is where leprosy was in the 1950s. And where leprosy is today, TB will be some years later. So there are a few messages to take from here. Going from the fact that in the 1950s, we know from history that Uganda had a population of about 6 million, and there were 120,000 people with leprosy with no treatment. And then we got treatment, and the treatment by the partner who I am representing here today, the German Leprosy and TB Relief Association, that are working with the ministry in leprosy for almost 50 years. Now, if we go back to this picture, that person there, just to tell you today what needs to be done when we see someone like this. The next slide. Next. Yeah, here it's not clear to you. What needs to be done? We need a laboratory test which shows that this person is a source of infection. That laboratory test is no longer common. It has almost disappeared, but is the one which tells you about infectiousness. This person was highly infectious, of course. So what we need to do, the next slide. We need to find out where this person got leprosy from. We need to find out who he has infected. Leprosy incubation goes from a few years to 10 years. So the people who are coming out of this patient scene now may not be seen until 5, 6 or more years from today. We need to provide treatment for 12 months. We need to do contact management, the same as TB, okay? And now what is new in leprosy, like for TB, when we find the contacts, we exclude leprosy, we exclude TB, and we give them preventive treatment. That is something new that is only beginning to be rolled out through partnership with GLRA, that which we hope will cover the whole country. Then we have a chance to reach zero leprosy. Let's see another picture. This is another one, also from 2021. This is a child. Leprosy in a child, that's why the indicator that the program picks is reducing leprosy in children. Leprosy in children means that leprosy is still being transmitted in the country. So this is a child in 2021. Is a child with disabilities of the hands and the feet. We have to do the same. Find out the contacts, treat this child, deal with the disability and the socio-economic consequences of leprosy. So this is the work we have to do regarding the, on average, 200 new leprosy cases every year in the last 5 years and in the way forward. What GLRA intends to do, that I will summarize, is to continue partnership with the government regarding leprosy control in as much as they have managed, but trying to go towards to go in line with 4 pillars of the Zero Leprosy Roadmap. The Zero Leprosy Roadmap is talking about having 0 new leprosy cases, having 0 leprosy in children, having 0 disability due to leprosy, and having no stigma, having 0 stigma and discrimination due to leprosy by 2030. So the organization that I am representing here today, German Leprosy Relief Association, in limited ways is trying to support and hopes to continue supporting the Ministry of Health in working along those lines so that come 2030, Uganda will be included among those countries that have attained 0 leprosy. I have answered the question. So the information about how much leprosy, where it is found, etc., will be presented by the national program tomorrow. Thank you.
Thank you, Joseph, for keeping time. Now I have the last presentation from Dr. Katamba Achilles. I'm also giving you 10 minutes that you can be in time. Thank you.
Good afternoon to you all. The slides? Yeah, maybe I will start by saying that
I think the title is saying the role of academia in controlling, reaching the NTB strategy. I think that probably, as you may have heard from many previous speakers who talked about poverty, stigma, the young man who was here talked about stigma, and many other things. Probably, academia has a role that we shall educate people, also do research. However, none of these interventions probably is going to impact TB alone. We need to really make sure that we work on poverty and any other indicators. So I'm briefly going to take you through really more to argue that probably the 2030 indicators probably are unrealistic and may not be attainable, maybe need to be revised. So you look at, these are the indicators you are all aware of, the NTB strategy, and we are aiming at that. And the next slide. And this is the roadmap which was put down there in 2015 to show that as we do research, optimize those tools that we have, make sure that they are implemented. We do a lot of implementation science research to make sure that at least interventions are optimized. Thought that there will be new vaccines that come on the way. Today, as we talk, we don't even have a point of care test for TB like HIV, where someone can do saliva. And so, as we were trying to do all this and play a role, it was thought that we should have at least a -10 decline in incidence per year, if at all we are to attain those 2030 goals. Earlier on, our assistant commissioner told us that they achieved 2.7%. Next slide. And there is a message here from this is the 2011 report by the WR. Maybe I can read it from here. It says that ending this debilitating disease remains a priority for WHO, and in recent years, we really made encouraging progress. But the COVID pandemic has put these gains at risk. Not only does the virus pose an increased risk to people with TB, it has also caused severe disruptions. I want to remind you that the struggle to end TB is not just a struggle against a single disease. It's also a struggle to end poverty, inequity, unsafe housing, discrimination, and stigma, and to the extent social protection and universal health care coverage. Really, when you look at that message, we need to work together. By 2030, probably poverty will not have gone, inequity and other things. So looking at that and looking at the disruption that even COVID, that when I was hearing the presentations today and I looked at the gap in funding, the Assistant Commissioner said they have about 30-something million, and there is a gap of 158 if I remember quite well. And you can see that with the miracles, things can happen, but you may think that those gaps may continue and probably we don't even realize what we are going to realize. And this is the argument to say that probably the 2030 targets may be unrealistic. Next slide. So what does it mean to end TB? It means to achieve those. Are they achievable? Next slide. So, ideally, it was seen that when COVID came in, the disruption that have happened, they have seen about a 2.3% decline, earlier than the 10% decline in incidence that was anticipated. Meaning that Okay, so you can see that in this slide, if at all we are to achieve what we aim to achieve, we need to multiply our efforts 6.5%. So the incidence should decline by about 15%, 14.9, if at all we are to achieve the 2030 global targets. And as you heard, as a program, we had 2.7. And we are doing well compared to many countries, as you may have heard also from the WHO presentation. So we need to look at what do we have now that we didn't have in 2015. We've not yet had a rapid HIV test, like an HIV test, rapid TB test. You can now use a saliva to test for HIV. So there is still a gap in diagnosis. We still have the same regimen for 90% of the people. Here it has not shortened. Prevention, we are reaching more than 7 million, but there are many people to reach. Who are those people who progress from latent TB to TB? We need biomarkers, and there are some studies going on to really look at some biomarkers even here in Mulago to see how can we find among those household contacts who are the people likely to progress to TB. We have effective tools, but we need to do a lot. The problem with ending TB by 2030, it is designed to fail, and that engenders defeatism. It's like when you were the 20th in a class and you say next term I will be the first. You may get discouraged that you did not make it. And the 15% annual reduction in TB incidence is probably unrealistic. Could have impact equivalent to averting COVID epidemic, and we fail. Not reflective of what we know about TB, issues of poverty, disparities will not end by 2030. And these are important components if we are to end TB. These to unintended consequences. Donor burnout, who funds an enterprise that never succeed because you set your targets. Recommend TB preventive therapy in people whom harm outweighs benefit, may increase disparities, accountability only where TB can be ended. So, as a last slide, in summary, I think that we need to work in partnership, whether in research and others, partnership with the government and implementers, designing efforts to make a meaningful impact on TB incidence at country level and local level. Maintaining close surveillance on TB trends in post-COVID world and performing appropriate analysis to know where we are. Ensuring that research and implementation efforts are of highest quality. Partnering with global and country level decision makers to provide high level leadership. So I think the key issue is that we need to work as a team, reduce poverty, reduce stigma, reduce disparities, but probably some of these indicators may be far-fetched and may not be achievable within the given time. Thank you.
Thank you, Dr. Katamba, for your presentation and for keeping time. He was the first presenter. Now we can have a brief discussion of what the presenters are still here. If you have any question, in addition, please, this is the time. We have only in 15 minutes time, we can be able to finish the discussion. I don't know your name, so should I give you numbers? Number 1, number 2, number 3. There are only 3 questions only. Number 4, only 4. Number 5. Do you have a second mic which can move around? Please. So we start from number 1 this end. Number 1 is this end, or we want to start from number 5? You can start from this end so that it can be organized.
In one of these remarks, he said that there's a high loss to follow up in the BDBD camp or in the refugee camp. But then when you look at the performance of the Western region, they have a very good treatment success rate. Maybe you need to throw more light. How are the two being combined? Thank you.
Number 2.
Beginning of this year, 2021, at Lira Regional Referral Hospital, we had registered 84 patients with leprosy. And in February, 25 cases were newly diagnosed. What does this mean? We need to use this conference to market leprosy. Dr. Joseph, you've talked about TPT or TPT drug that we need to use to give to clients who are found not to have TB and also not to have leprosy. Right now we are enrolling 3HP. Actually, we are trying to utilize the former isoniazid out of the market. I don't know whether there is any other drug besides this that is in provision for us to prevent both leprosy and TB, because I believe the bacilli are not the same. To Dr. Zbael, I strongly agree with you. There is need of mapping private provider, or integrating private providers to work together with the government in order to identify TB cases. Most of our clients who come to TB, they come with very many documents of treatment from privates. And these privates diagnose them at the late stage. TB diagnosis become the late and something they think about last. But how are we going to improve this? To Dr. Stavia and the rest in the room, we have TB lamb strips. Is there a way we can maximize the use of TB lamb among the suppressed clients? Because in privates they are being sold. And remember, if at all we can provide the TB lamb to these privates at no cost, so that whoever goes to test for HIV can be done a TB lamb there and then. Who is found positive, they can do a TB lamb because it is at a free cost. I think that one will help us to raise our worries and thinking of TB. Thank you.
Thank you. Number 3. Was number 3? Don't repeat the questions, eh? Number 3 is here.
Good afternoon, ladies and gentlemen. My name is Adamba Musisi, in the shoes of the Office of the President, RDC Wakiso District. My point goes to Dr. Katamba. I want to thank him for foreseeing the reality. His approach to the whole TB fight vis-a-vis the time is realistic. And I would want also to remind the other participants, protocol observed. Much as we are in this struggle of ending TB and leprosy, can we get out of the thinking that we have done all along, and that is the top to bottom approach? We cannot commit ourselves and sign saying the way forward is prevention, community awareness, and we are still lagging around our comfortable zones. It's time to go and become foot soldiers. It's time to change the sound, to change the strategy, the approach. It starts from now bottom upwards. We have registered a number of failures And it's time for us to rectify the situation and say enough of our offices, enough of our theoretical approach. It's now practical, it's grassroots. We need the political intervention on the ground. We need the awareness of the political leaders. We need budgets about TB to be inclusive right from the smallest council budgets upwards. On the issue of leprosy, much as it is reduced, the same strategy for leprosy you said will help the one of TB. I'm also saying the way we have approached COVID, the door-to-door strategy, where everyone knows that we are facing a danger, is the replica TB requires. Thank you very much for listening to me.
Thank you, Banara DC. Number 4. Kindly be brief and go to the point.
Mr. Chairman, thank you, and thank you for reminding us to be brief, but I would like to first observe that the designers of this conference have made it like a lecture, and we've been on the receiving end from morning. If I had my way, I would change the program tomorrow. My name is Robert Nachibumba. I'm a TB activist. And I would like to have 2 questions to Dr. Sevikali, the Honorable Sevikali. My first question is, in the Permanent Secretary's speech read to us this morning, she observed that going forward we should integrate screening of TB with COVID. So COVID came and disrupted TB treatment. Everybody has been saying this morning. But unfortunately, when the resources that came with COVID, a lot of resources, I have to say, in this country, record high resources, none of the resources went to TB. And that is a shame for us as a TB fraternity seated here, because we should have taken advantage of the so much resources that came to COVID, because COVID presents in the same way as TB. On the contrary, only PPE materials that I was supposed to manage TB and the gene expert machines were taken away from TB, and that is a shame. I would like to ask you, Dr. Sevikali, and the members of parliament who are here, that go and put the voice for TB to receive resources, some of the resources that are coming from COVID, because it presents in the same way, but if anything, TB lost out to COVID the little resources that they have. That's my observation to you. Secondly, so the budget for TB, and thank you very much for observing that we've had a 9% increment in TB funding locally. But I would like also to remind the members here present that that 9% only went to 5% of the national need, funding need. So in other words, 5% is what the government of Uganda puts in TB management, 35% is a funding gap, and the rest is done by partners, Major Global Fund, USAID, and UNICEF. I would like to find out from you, Dr. Sevikali, that although we are clapping our hands that we've had an increment, do you think we're standing in a better position, or we should work even harder to increase on that 5%? Thank you.
Well, thank you very much for those very hard questions. Question number 5.
Thank you very much. Protocol observed. My name is Akankwasa Johnson, Assistant DHO Shema. And my submission goes to the presentation made by Canon Dr. Johnson Vyawashija. Among the strategies he presented, he had increased the ventilation of prison wards. But I want to submit and bring to your attention, Commissioner, that the infrastructure that is coming up recently that you are constructing in different areas does not provide for that ventilation you are talking about. I have an example, I don't know whether you do monitoring, where you have back-to-back rooms for even the officers that you post in those areas. So in Harris, we have follow the leader approach, where we have to be exemplary. Two, and the last one, is we are strengthening prevention, which is now on floor. But I want to remind you how CB dots usually to be implemented is not how it is being implemented now. The CB dots of today is on paper, but practically is not being practiced how it usually to be. I submit.
About prisons, remember you are invited to visit prisons. There was an invitation. So we shall go there and see. Don't go there when you have committed a crime, just go there. Another question? Dr. Bok, okay. Two more questions. Just two, but brief ones.
Thank you. Edward Were from Ginger. Mine is to the gentleman from the prisons. In his presentation, he did highlight the funding for TB to largely come from CDC and other implementing partners. I wish to ask that from the supervision that I've done to a few prisons, there is a very big disparity here. They do not access primary health care funds. All the prison health center threes, for example, I'm not aware about the hospital, Maction Falls, Maction Bay. But the prison health facilities, meanwhile, other health facilities in this country access primary health care that they should use for the day-to-day implementation of a number of activities, including TB. The prison health facilities make a comment on the primary health care funds to them that can be used for TB and leprosy in prisons. The other thing is around the referral mechanisms. You did highlight that you have strengthened this, and we observed a decline in the loss to follow-up rate. But again, at the end of the presentation, you again highlighted that you still have a challenge of referral. Let me learn, how have you improved the referral or the tracking of these inmates who, after being released, the health workers are left not to know where these people have gone, you know? Thank you.
From the great man from Mobongi. As he comes, your question was not clear. Did you say they are not allocated PHC funds or they don't receive PHC funds, the prisons? Maybe you'll answer. They don't receive or they are not allocated. I don't know. They'll give us the answer. Obongi, please be brief. This is the great man from...
Thank you.
From Obongi.
Thank you, Chair, and the panelists. Boka Didi George is my name. I represent the people of Obongi. I have a few issues and concerns to be flagged to specific people. My first issue is on the drivers of the epidemic, the TB problem, which requires a multi-sectoral response. I thank the Ministry of Gender, Labor and Social Development and the Prison Service for being some of the sectors that are here present. My observation is that the conference seems more to be a public health conference with medicalized approach with the minimum engagement of other ministries, departments, and agencies. For example, the housing sector plays a key role in the design of our housing to address issues around ventilation and so on. What efforts are we making to mainstream TB programs in all ministries, departments, and agencies. If OPM was here, that question would have gone to the office of the Prime Minister. 2, Minister of Gender, Labor, and Social Development, I thank you for your presentation. We have a huge opportunity in the names of the parish development model that is going to be the vehicle for community transformation. And Dr. Stavia, I thank you for the concept of community-based TB and leprosy, the project that's just been launched. To what extent are we integrating TB and leprosy activities within the social sector component of the parish development model? Because other sectors are busy packaging what they want to deliver in every parish in Uganda. 3 is the financing issue. It's loud and clear, we have a huge financing gap. But also, the TB and leprosy program is at risk of collapse if our partners withdraw financing. I've seen that there's a lot of 41% of out-of-pocket expenditure, which to us we are lamenting about, but to me offers us an opportunity for starting a community health insurance program. Have we made an attempt to analyze the out-of-pocket expenditure and to explore opportunities of converting this into a social or community insurance scheme? Because that shows to me there is a willingness from individuals and families to finance their health. Last but not least is accountability for better results. One of the challenges we've noted that our metrics, our results may not be up to expectations because of lack of complete, accurate, relevant, and timely reporting, especially at the community level. Also within the parish development model, we are told that there's going to be an integrated community management system, information system. To what extent are we integrating health information to that system, but also specifically TB tracking information to that system? And very finally is about partners. We want to thank our formal partners, and I'm happy that we are seeing a progressively contribution of the private sector to the TB response. But there's a sector that all of us go to in one way or another, and that sector is called the traditional, cultural, and complementary practitioners that most of us first go to. To what extent are we engaging them in the fight against TB and leprosy? I thank you.
Thank you, Honorable Boka. So now we are going to respond, and I'm requesting my presenters to be brief, to the point. The questions are very, very simple, don't take a lot of time. We shall start with Honorable Joel Sebikali.
Thank you, my chair, and thank you very much for participating in this discussion. First of all, I would like to talk about the comments made by the RDC Wachiso. Now, I would like to inform honorable members and dignitaries within this room that planning is from bottom up, but there are some other planning methods or interventions that are done from top to bottom. For example, when we had the pandemic of COVID, when His Excellency talked about it, you saw how all households were observing what he was saying. He has been a chief fighter for HIV, and you have moved. But I have never heard His Excellency talking about TB. I bet in this room, if there is anybody who has ever heard His Excellency talking about TB, you can tell me. Even the First Lady, even the Prime Minister, except the Prime Minister Rugunda, I think he's the first one to talk about TB. The rest have never talked about TB. If I may ask, who began Emyoga? Is it the chairperson LC1 or it was His Excellency? Did the money go? It went. Who is bringing parish development, parish model development? Is it LC1? But he's saying whoever does not implement my program, that one is gone. So that political commitment, that is zero to get a ballot, a vote. We need it in this fight. If one day he has sent his signature on the bill, all RDCs, all GISOs, all PISOs, all GISP, whatever, they will get information from the communities. And we shall achieve what we want. There is a leverage that these partners are giving us funds. And he has left it the way he's at a freelance. But if there is this introduction of national health insurance, the government will commit itself to fund the indigents with a percentage, the way other countries are doing. And that money will go to them. More medicines will come. More PHC funds will come. It's what we need. There is no way you can tell me that by 2030 we shall reach a middle income state. Who told you? When the percentage, 76 are peasants. And these are the people we want to bring up to that middle income state. And now we are saying it should come from up. LC1 planning for national health insurance, my RDC. Please. My question about the 9%, the 35% gap, mark you. If this national health insurance has come on board, nothing will fail us because the money will come as planned. So, but I think we should thank members of parliament in the 11th parliament. Madam Commissioner, we found you at 1%. We are at 2.4%. At least there is, it is a drop in the ocean, but there is an improvement because we worked as a team. This time round, we are graduating, we are improving gradually, but if that national insurance comes, it will not be gradual. It will be robust. Because Karuru, the wananchi, the ones you are looking at, Mr. RDC, they will get all what they need. Because the government will fear that if we do not provide what we promised, then it will not come. Money will go there by all means, as we are going to get this money for parish. Isn't it going? Because of that. Okay, we continue. Thank you. Now, there is the gene expert. Madam Commissioner, I think you will answer this. Because I went to Entebbe Airport with the committee members. They are here. We went to ask, and we asked the doctor who? That one in Entebbe who is in charge? Doctor, no doctor in Entebbe. Who is in charge of COVID testing and that doctor. And for us, what we wanted to know, we were assessing whether to pick an extra and leave the other working. So there was no like, they take away all gene experts, they leave the districts suffering. The gene experts will have, they are sufficient in those districts where these ones came from. On top of that, the government, in collaboration with the partners, they bought more gene experts to create a point of care at the airport. In fact, we have what is enough for this country. And I don't want to say that we endangered those districts. If there is any district without a gene expert, where that gene expert was removed, and they do not have, you can report today, the commissioner is here, so that we follow it up. The following day, you get a gene expert. No worry. The money that came for COVID was taken without looking at TB. It was a pandemic that came without planning. It was not planned for sure. It came, but there is no way you could add the two together. We say, now COVID, go with the TB. At that time, things were hard. Things were hard. You know very well how we panicked, how the country panicked, how we panicked as health workers and members of parliament, even up to now. Let me tell you. Money for oversight role for members of parliament, money for outside travels, all that money was taken to buy COVID vaccines. And we do not have money at all to travel. I'm with the committee members here. Instead of getting 120 million for travel, we got 19 million. 19 million out of 120 million. So COVID affected us all. Not TB alone, not HIV alone, but all programs were affected. And we are still, getting into those problems, but we shall overcome, God willing. Thank you very much.
And let's first give a mic to Honorable Nekesa. She's there, Kano. You know, when COVID came in, there was lockdown, everybody was panicking, but I've never had a lockdown when you have tuberculosis. So, but at least as of now, we are trying to understand the COVID-19 and the TB, so we can be able to rearrange our systems. So, Honorable Nekesa, just one or 2 minutes.
Thank you, Chair of the session. I'm sorry for giving a step back, giving us highlights as to the fact that our vision of Uganda in terms of ending TB is almost null and void. So there's an issue here strategically. And now I would like to have clarification or pose a question. How does the Commission, the TB, the managers of TB and the planners of TB work? What way forward we have? That because apparently health is a right in Uganda. So when they plan and they work hard to get TB out of Uganda, yet there are detractors like poverty. They're trying to launch the models, the parish models. They're trying to look at so many things to make Ugandans better, including TB going away, eradicating it. Now they're saying now from researchers of Makere or the academicians that no, it's not possible. How shall we get this out? Can we have a way forward to that so that the commission or the government or the commission on TB and the academician researchers get something that will help us get some? I'm really energyless about that. I'm feeling weak because it looks like we are not here to get our health rights as we always think the health is a right. Thank you.
The performance in TB detection rate and treatment success rate vis-a-vis the challenges of mobile population. I think I really want to highlight that this has been possible because of the following support. One, as a district, we really have that support from the German Leprosy program. German Leprosy program offers feeding for dizzy patients in those who are on treatment. And remember, one attribute of TB management, the issue of poverty and feeding. So this greatly improved on their adherence, and that resulted into the outcomes of treatment. Then there's support for follow-up by BRAC. I think BRAC has been supporting us a lot in issues of community follow-ups and even community TB diagnosis. So these ones improved on the detection and even the success, the treatment success. Then there's also partner support. We have a number of partners that are supporting us, the UNHLM agencies, IDI plus others, who are supporting us in the management of TB. So I think despite the challenges of mobile population, with these supports, so we are able to improve on some of the indicators of TB. But what remains on the ground is this mobile population really poses a very big treatment or the management challenge in the management of TB overall. I think that's what I can say. Thank you, Chair.
Thank you. Those are the answers. If you want more clarification, get his contact. Joseph?
I had only one question, I think, from the colleague from Lira Regional Referral regarding the prevention for leprosy and whether there could be the same prevention for leprosy and TB. As of now, no. That the prevention for leprosy that is being piloted here in Uganda is shown by researched evidence that if people who are contacts of an index leprosy patient and do not have TB and do not have any reasons not to take the drug used for prevention, they will be protected from getting leprosy up to 57%, okay? And if those people had been vaccinated with BCG, for which we have very good coverage, that protection increases to 60%. So the prevention that is being used for leprosy is a single, one-time treatment with rifampicin. And rifampicin is a very important medicine for treating TB. So it is to be used very cautiously. I think I have answered the question.
You? Now, Kisambir, that is for private medical practitioners. Less than a minute.
Yes, thank you so much, Mr. Chair. One, we need to redirect efforts to the right people. When efforts come from government to the private sector, or as they look at the big guns in the private sector, yet actually the actual patients who suffer from TB go to the small facilities. So the government needs to redirect the efforts to the smaller facilities. Two, we need to empower intermediary organizations like the Society of Uganda Private Medical Practitioners, which can gather the other private medical practitioners so that the message comes from their own, so that it can be easily taken up. And lastly, we need to build their capacity. Then we shall reduce the volumes of medical forms that the patients present with the government facilities if they land on the people who are knowledgeable and they know what they are doing. Thank you so much.
Reasons, 1 minute.
Thank you. Rising from the way forward, increasing your ventilation, true. For historically, the prisons facilities have been the worst of it. But it has been a deliberate policy to redesign, redefine, and hitherto what my colleague is observing, some part of some units, it has been taken as a deliberate policy to revisit, because you find that some departments were acting in silos, but this time it is a deliberate policy that we must move interdisciplinary. So it is being addressed accordingly. The other one was about referral mechanism. People were getting to be discharged from our custody when we have registered them, some be on treatment, and they would give us contacts so that we give a follow-up. But by virtue of what these people have been or well, at times they would give us wrong contacts. But what we've done is that we have now cascaded it through our regional health coordinators, the health facility unitors, and giving them referral notes to the next public health unit, and getting the contacts of the next public health unit wherever somebody is being released to, so that we keep following up with the other facilities on the other corner. Thank you. On the issue of the public health, as we all draw from the same basket, it is limited, but the little that we get, rest assured we are trying to put it to the best use, notwithstanding limited resources, both human and physical. Thank you.
So that the answers from prisons, to know they are right or wrong, but those are the answers he has given. Dr. Katamba, 1.5 minutes.
Yeah, the targets, I'm not saying that maybe, what's the question, that they are not achievable or
Sir, you have to use Ugandan English, eh?
Dr. Katamba, I would request that you, the academicians, and the Ugandan Government Commission on TB join hands and forge a way forward. Give us a clear way as to what we shall do in terms of TB so that is cleared and out of Uganda, so that health is a human right, as they had planned earlier. By 2030 or 2035, TB will be out. People will live free of TB and we live healthy. Health is not a right. So in your way, as academician researchers, what do you try to advise the others who are giving us the other one? What is your way that we should do to get it out? Because it's like it may never be achieved, that we still have the poverty indices high and everything else bad. Thank you.
Yeah, I remember there were targets earlier on of health for all by the year 2000. Some of us waited to get to that point, what it meant, but it looked like it was not achieved at that time. I think I was 34 years in 2000. And then I realized that, it has not yet been achieved. So I'm trying to say that probably these global targets, given the challenges that are there, given what COVID has created and many other challenges, it is something you say, I have not achieved as a country or at all levels, and you feel discouraged as if you have not done anything. Really, what are the realistic targets that can make people say thank you? You sent your child at school and he was the 25th last term. And as a parent, if he comes back and is 23rd, 22nd, you should appreciate. But if you set a target of being first, this child, whenever he comes back, he may even just get more demoralized and become the 50th. So, because the targets may be so high that within the existing resources and other things, probably, that's what I'm just saying. I'm just debating openly and saying that probably, as other people have also started debating this in the academic field, trying to say probably, given the challenges and others, need to be. Yeah, as what we can do and other things, probably some of these targets are set globally and some, but debates come in and other things, and probably these debates are taken at a global level and also globally debated and look at what is it. But I'm not saying that this is what, as you know, some of these targets are set globally, and probably my role anyway is just looking at the numbers and being a bit critical, but I may not have much to do.
Thank you, Dr. Katamba, for answering it in the simplest way, as if you are becoming a politician. But your answers has been taken. We have so many questions online, but we may not be able to handle them now, but they'll be handled tomorrow. Please, for those online, if there's someone from OPM, then we can have the last response from this side.
I think Indy, you can come over. The other mic has had a problem.
So he can be answering as the other person comes to gets the mic. I'm giving you only 1 minute because yours were the simplest.
Okay. There was one comment raised by the Honorable MP from Obongi, how Minister of Health would integrate TB and leprosy in the social development sector. Now we no longer speak of sectoral approach to planning, and therefore this means it should be under the community mindset, the community mobilization and mindset change program, which is leading. We already have meetings going on of the different technical working groups, and I'm sure that Minister of Health, which will implement these programs of mobilization. So I think it's possible. Thank you.
The response then from OPM, you're giving us a response, not a presentation.
Yeah, thank you very much.
Okay.
It's indeed not a presentation, Chair. Good evening, colleagues. My name is Enid Mbabazi, and I'm from the Office of the Prime Minister. I want to respond to a few issues raised by my colleague, Dr. George Boka Didi. And I am not responding as such, but I would like to get clarification from the program manager, assistant commissioner, whether the resource materials that we have as a program have been disseminated widely. The reason I'm asking this is if my colleague George Boka had actually accessed these resource materials, he wouldn't have asked those questions. Relatedly, the issue that was put to Dr. Katamba about the targets is well taken care of in the multi-sectoral accountability framework for TB, which is one of the resource materials that I'm talking about. This is a framework that was launched. Sorry, I might give a speech as I try to respond to this. It is a framework that was launched in 2019? 2020, yes. But of course, the process started much earlier. The Right Honorable Prime Minister represented Uganda at a high-level meeting in New York, the General Assembly, where he made commitments on behalf of government of Uganda to end TB by 2030. So following that meeting, the country mobilized, and we came up with the framework, the multi-sectoral accountability framework for TB. And I would like to request that Stabby and your group, you circulate that framework widely so that members can appreciate their role in ending TB 2040. And I would like to state that if we stick to that framework and the roles stipulated therein, we shall indeed end TB. Dr. Katamba, you're one of the stakeholders. I'll refer you to page 2022 in that booklet that enlists the stakeholders. You're one of them, the academia. I remember when you launched the framework, you're with us at OPM, and I was wondering actually why you're querying the targets, and yet we have the actions clearly stated in the framework that will lead us to ending tuberculosis. The other issue was about the catastrophic expenditure. There's a leaflet that has been circulated. Please make sure that you avail it to our colleagues in Parliament. We had a program to sensitize the new government. Somebody talked about the Prime Minister and other leaders not talking about tuberculosis. And I would like to really say that this multi-sectoral accountability framework is actually hosted. The Secretariat is hosted by the Office of the Prime Minister, and it has really been on the lips of each and everyone in the Office of the Prime Minister, including the former Prime Minister, and the current one. So hopefully we can sensitize the new government, and everyone will be brought on board, and you will appreciate your roles, and we shall work together, as most of you have recommended, as one government, as we have done during the COVID pandemic, to make sure that we attain our global targets to end tuberculosis. The other issue was about the parish development model. Again, the role of the community is well articulated, and I was asking the commissioner whether you watched a documentary that was produced for purposes of educating us about a number of issues, including how we are going to improve community control and prevention in the context of the parish development model. I would also like to refer you to the National Development Plan, particularly the program of mindset change. I think TB control will require mindset change, and I see a lot of involvement of stakeholders at that level of the community who are going to help us to effect that. Thank you very much. If I've not if I've not addressed other issues, tomorrow we shall have an opportunity as OPM to talk about our role in coordinating multi-sectoral efforts, and also take stock of where we are since we launched the MAF-TB. So tomorrow we shall have an opportunity to address some of the issues that have not been tackled today. Thank you very much.
Thank you, OPM. RDC, you wanted to say something in 1 minute? Just 1 minute.
Thank you, Mr. Chairman. I would want to make a few points straight, raising from how Mr. Joel responded to my alerts. First and foremost, when I talked about the bottom-top approach, I looked at or envisaged in a few issues, and the most important one was data analysis and incorporation of the community against the fight of TB. That was my approach. That's the reason why I said we need a bottom-up approach this time around, other than the office theoretical manner in which things have been going on. Secondly, I want to mention to all the participants that His Excellency Yoweri Kaguta Museveni has been at the forefront of fighting all health ills in this country. He's fought malaria. He's been part of fighting HIV/AIDS. He's been fighting COVID. And he's committed to fight TB as well. But there's a question. We don't have the right data to show him what's happening in the communities. When I discuss with the DHOs, I find that they have a problem in analyzing the true data that can heal. So I would want you guys to focus more on supporting proper data analysis collection and analysis about TB, do a door-to-door awareness campaign by involving the political stakeholders at the grassroots, and we will do our part. And trust me, the president will be with us. Thank you very much.
Thank you very much, RDC, for that clarification. And I would like to thank the presenters, the panelists for very good presentations. It has been very nice. And also the participants. For the questions which have not been answered very well, you can get the contacts for these panelists. They will be able to give you the responses. So I think in interest of time, let me stop here. My term of office has ended peacefully. Thank you very much. I want a very big hand clap. Good. Thank you.
Chair, as we end our term as your co-chair, I've been receiving requests for the presentations. So I'm just informing the members here, the delegates, and those online, that the Secretariat is going to develop a link which is going to be posted, sent to your emails, such that you'll be able to receive all the presentations that have been made. Thank you.
What a wonderful way of handing over peacefully. Can we give a big hand clap to the chair for this evening for running us through? Another big round of applause for all the presenters. And how else can I thank all of you? Let's give a big hand clap for ourselves. Thank you, ladies and gentlemen. I know every good thing comes to an end, but I want to appreciate those ones who have been with us online, and also those ones who have been here physically present. Before we have a word from me to say bye, I want to invite the program manager to come and give a few words to send us off for tomorrow. Dr. Stavia, Commissioner, can you come and give a word? The podium is yours.
Thank you, our MC, for today. I think you have done very well. You deserve a thunderous from our participants. And thank you, the just concluded panel. Thank you, Dr. and Honorable Ruyonga, for taking us through very, very well, and our panelists. We are very blessed to have you inform us. I want to start from what Honorable Nekesa was requesting. I want to re-energize you. I am a positive person, naturally. And I know things are possible. That's why we have set ourselves strategic targets to achieve. You will remember from the very beginning in the morning, from our speakers, there were hopes that we are progressing and progressing. The fears that the academia is seeing based on the evidence that they have, I guess that with the renewed energy, the door-to-door that we have all launched today, if really we get your support and get the funding to reach every household with, like the RDC is requesting, it is possible. We shall end TB. We shall go to zero leprosy in Uganda. So we need your support. And to you, Boka, the conference today is not medical. I think for the first time in the life of the TB program, at least at the panel you have seen there's someone from Ministry of Gender, Labor and Social Development. The Commissioner General himself of Uganda Prison Services has spoken to us. We had the Minister of ICT with us, Minister of Housing online, Minister of Works is due to present to us, I think tomorrow. So in our multi-sector accountability framework, we have made sure that we map out what contribution each of the MDAs can have to support this response towards ending TB by 2030. And we are really working closely with them, and we hope to make them really as part of our response effort. The parliamentarians, the caucus, we need more voices from you to make sure that we get the things that we need. About the gene expert machines, yes, the little that we had as TB was taken, but we still are there because, like I think you were explained to, some districts had more than one machine. The taking away of the bigger version creates a gap, but we can still work, and the ministry is bringing in more machines to fill the gap that was created. It was a temporary, urgent action that needed to be done, and the machine was only available through the TB program. But we need your support to make sure that there is enough, the resources that come to COVID leave a lot to strengthen the whole system, including the TB system. Lastly, I want to once again appreciate, we had a number of you from the Parliament. We can't take that for granted. We had our Honorable Minister for some time, the whole of today, we can't take that for granted. The Director General, the Director of Regulation and Policy was here with us, and the Commissioner and other commissioners like him. We cannot take that for granted. All our participants online, we had the Honorable Minister of Primary Health Care also online, and other Minister of Health officials. We expect you also tomorrow. Thank you for today. I think the discussions were really encouraging, thrilling. The energy that was almost going away, I think, is back. We want to go door to door with TB awareness, TB prevention, testing, and treatment, including leprosy diagnosis. So it is possible with the support. We are getting to understand about the parish model, and we are making inroads. We want to see what it can bring as far as TB and leprosy programming is concerned. Thank you.
If you can clap now, I will not ask you to clap again. Let's clap for her. Thank you very much, ladies and gentlemen. I had promised that I will not take you beyond 4, but I promise that I will not take you now beyond 6. Some small announcement. I know this administrative announcement should have been made earlier, but let me give it to you now. That the registering for is very, very important. There will be payments by 2 separate institutions. One will come from Ministry of Health, one will come from USTP. Now, all will be paid through mobile money. It will depend on how you have registered. If you have not, I beg, please go and register so that starting tomorrow, your pocket should start smiling. Otherwise, thank you very much for your time and for your effort. From me to you, I want to say bye-bye, and may God bless you. Tomorrow we meet.
The Prime Minister's delivery unit for the last 6 years. I'm also a senior presidential advisor for economics and planning. Tuberculosis as a disease has been with us for a long time. It's a serious problem that has killed, I understand now, It's actually killing more people than HIV. And I think it was 2 days ago, the president was urging the Minister of Health to do more, sensitize the population about HIV so that our rates of infection would continue to go down. I would say the same thing applies to tuberculosis. It's a disease that tends to be prevalent among the poor who have no or little or no means of looking after themselves, who are living in bad conditions. And so it's important that we are able to access these people with information and with medicines and with care so that they don't die. And without that kind of access, without services being nearby, they will die. The PDM, Parish Development Model, is now government policy. And the idea is that the planning and implementation of essential government services and programs should be done at the parish level. Once we accept as a fundamental principle that health care should be as close to the community as we can, and that's what should happen with PDM, bringing health care close to the community. To me, it is even more critical than the primary education. Primary education is important, and if it is going to be at every parish, then certainly health care institutions should also be, we should make sure that they are available so that when people fall sick, they can get urgent care, they can be looked after, and they will not die.
Please, tomorrow we want to start earlier than 8:30.